Next we have, Petra next is the founder and CEO of Prime Imaging, specializing in radiology technology innovation, medtech consulting, and AI-driven diagnostics. Her focus is on integrating advanced imaging solutions into telehealth, enhancing remote diagnostics, and shaping the future of AI-assisted healthcare. Dr. Glenn Loomis is next. He's the co-founder and CEO of Query Health, a startup bringing an AI physician agent to market. He's an experienced physician leader with over 20 years experience as a health system president and chief medical officer. And finally, on the end is Ryan Zumwalt, is the co-founder of TruePoint Health with over 28 years experience in acute, post-acute, and ambulatory care centers. His specialty is high acuity, post-acuity, and telemedicine platforms. He's held CEO positions at health systems in Washington, Idaho, and currently in California. So, welcome everyone. Thank you. Let's get started. So, as I mentioned, we've seen Telehealth 1.0. The focus was originally on consumer adoption of telehealth. It was on modalities such as sync and async, and it was about the special COVID rules. The question now is, what form is Telehealth 2.0 going to take, and what will we see in the future? So let's get started with that. And Scott, if you don't mind, let's start with you.
Sure. I think the biggest hallmark we're seeing as telehealth, telemedicine starts to really evolve going forward is it's no longer the domain of simple software. It's no longer just the access points where we can look into our doctor's office from a remote location and have that conversation that is both helpful and health supportive, et cetera. Now we're starting to see this kind of ecosystem surround the telemedicine in the form of home diagnostics. We're starting to see overnighting testing. We're starting to see a lot of these other pieces that are not only having now moved the interaction into a remote setting, but it's also moving the rest of the clinic into the home setting. And so when we talk about telehealth, at least as far as the capital we deploy and some of our clients, we look for those that are trying to use the tele root word less around just the visualization in the software and more as a moniker of moving the entirety of healthcare into a more convenient, consumable fashion.
Great, thank you. And Ahmed, love to hear your thoughts on this.
I would take a step back and start that the telehealth is not new. If you look back, you'll find the evidences of the tele using the mobile on the phone was already existing in as early as 19th. Over that, with the COVID and everything, as the internet evolved, we have more on the video conferencing. That was the first step, and with the COVID, the things really speed up. Now, what we are looking at the next era of it, like Scott said, the telehealth is going to evolve. I don't want, as a patient, to practically visit a hospital just for my regular checkup. Well, how can we eliminate those needs? With the use of the AI, where I can have symptoms checkers, where we can have the monitors being into your hands, devices to your arms, and with that, you being at your home, you can still get a telehealth from the physicians. That is very much possible. With more and more AI coming into the picture, as a patient, you should look forward to use your time at your own comfort rather than being in the premises just to visit at 15 minutes or 5 minutes with a physician, and rest of the time is with your commute and the travels. That's where the telehealth is going to come into the picture, is going to reduce the burden not only on the physician, on the facilities, and towards the patient. Your care will be much more advanced, but the time spent by the physician on an individual patient is going to reduce, and they're going to put the time where they interact with the patient rather than using the technology. One of the good example, I was at the HIMSS yesterday, ambient mode being used by a lot of facilities with the larger ones, where based upon the conversations, we could do the notes. As a physician, you can create the care plans, and this all can be done with the use of the AI. The physicians don't have to sit behind the computers to document all this, and that's where the telehealth is slowly progressing.
Thank you, Ahmed. Appreciate those thoughts. And Ryan, I know this is an area where you have some expertise as well. What is Telehealth 2.0 going to look like?
If I'm looking at for Tele 2.0 Health, as from my background, I come from those rural underserved areas. So adding Telehealth 2.0 or a telehealth medicine, actually be able to reach further out away from the confines of the physician walls, and further meet with those patients where they're at. Healthcare is really a change model, especially after COVID. We're looking at that acceleration of being able to do labs in homes, remote patient monitoring, and adding that component of that physician element in there to make those judgments, to get medications, get the services needed to that population that may be 50, 100 miles away from the nearest hospital or tertiary center.
Thank you. So the question now becomes then, with Health 2.0 or Telehealth 2.0 evolving, what are going to be some of the diagnostic applications of telehealth? And you've touched upon them a little bit, but I know what we're seeing in my business, for example, is we're seeing very complex patient journeys now evolve into a telehealth model. It's no longer a simple transaction. I'm going to see a doctor online to get a prescription. It's I want to see a doctor online to go to an infusion center or to get an injection or something more complicated than a typical prescription for a medication. But I'm curious, Glenn and Petra, have you seen or are you thinking about areas where telehealth will evolve into different diagnostic areas? And Petra, I'm sure you have something to say on this.
Yes, my space is in radiology, so we went from a model like we have been talking about where it's no longer a patient-doctor interaction over a video conference. With telehealth, now we have providers speaking to each other, advising each other, assisting remotely with surgical procedures, one specialist talking to another specialist with patient history, getting together, collaborating. As far as remote radiology applications, we could have people on the field in remote areas communicating with radiologists, other specialists, or sonographers and techs being able to perform radiology studies and communicating from afar. And also with the AI component, that's going to drastically change the future of radiology. Diagnostic imaging, with AI interfaces, there's going to be it's going to be hyper-personalized medicine. It's going to take genetics. It's going to take demographics, patient history, and combine that with the medical imaging to provide more accurate diagnoses.
Thanks, Petra. And Glenn, what can you tell us about future diagnostics with telehealth?
Yeah, I think at Query Health, we're really on the cutting edge of AI use in medicine, and we think that there is going to be a lot of additional diagnostics that happen through telemedicine that are AI-based. And so we have now the ability to do vital signs through AI, through just your camera. We have the ability to listen to a snippet of your voice and tell whether you're depressed or whether you might have Alzheimer's disease. A whole host of things are coming that none of us have even dreamt of in the diagnostic world. And all of that mixed together with what we're building, an AI agent that will actually go out, talk to you at home, be able to work with you on your medical issues at home, give that information to your provider, and really is going to bridge that gap, I think, between what we consider telehealth now and the brick and mortar practices where most of you get most of your care, and be able to start putting those two things together in a way that we haven't been able to do. Those two sort of worlds have stayed pretty siloed, but we think that with the use of AI and some of these other diagnostic techniques, we're going to be able to bring access better to patients, but at the same time, keep you in the loop with the doctor who you go to when you're really in trouble.
Great, great. And when I think about Telehealth 2.0, I also think about what needs to change in our regulatory environment and how we have to become more flexible and available and make things available. And so some of the fundamental issues we're running into, for example, are we need to have nationwide licensing of clinicians rather than 50-state licensing, and we need to have national licensing of pharmacists rather than 50-state licensing, and the corporate practice of medicine rules need to evolve because we all in telehealth work through these complex legal structures to be able to get around or to be able to deal with the corporate practice of medicine statutes. And finally, it's been a big issue in the press lately, is happening. Let's take that.
Peter, just a second. I want to just add a stat over here to give more confidence to the people that how does the policies impact? For an example, the WHO in 2022 said 1,000 patient to the 1 doctor ratio is a fine. If I go back to the state of Massachusetts over here, it is 3.6 per 1,000, which is very good, which is really a good number. But when I reach back to the Nevada, it practically changes. It's 1.9. Now, how can the physicians based in Massachusetts can assess the patient here? That's where your telehealth is going to evolve over a period of time. But what comes in between this barrier is the policies. That's what Peter is trying to convey, that, okay, these policies need to change. I, as a physician based out in any one of the state, should be able to treat the person other place. I don't have to get registered and licensed in every state. Those are the changes need to be put across. And if I go beyond the states where the ratios are very good, you go to the countries which are developing countries, you are going to find the shortages much, much higher. How can the physicians over here, and if they have the time in a particular state, how can they extend beyond? And we could help the countries which are underdeveloped to be taken care. That's where the telehealth is going to be more and more precise to be use case.
Well said, very well said. So the title of this segment is Telehealth, Personalized Medicine, Medical Chatbots, What's Next? So now let's go beyond just talking about telehealth in general terms. Let's sort of do a double click into the advancing technologies. So my next question is, how are advancing technologies going to impact telehealth and the healthcare ecosystem in general? So let's start with, if you don't mind, we'll start with Ryan this time. Let's go from that end.
All right, for telehealth and looking at the advancing technology and adding AI, I believe I sat at a conference last year roughly about this time where Optum, and you're looking at how AI can jump in and accurately predict whether a person is going to be in the hospital in the next 2 to 3 weeks based on picking up their medications, their food and nutrition, how often they exercise and their mobility, to loneliness, depression. It puts all this into an algorithm to help us avoid hospitalization and unnecessary utilization of resources if we can get in front of any issues that may arise.
Great. Glenn, what are your thoughts on advancing technologies that are going to impact the healthcare ecosystem?
Yeah, I think we've talked about a number of the technologies in terms of home-based labs and online AI testing, but I do think that AI in general is going to completely shake up how we do telemedicine going forward. I think as we're looking at how you use AI agents to actually do portions of what physicians do, portions of what nurses do, portions of what other healthcare providers do, and do that with you as a patient in the comfort of your own home, where you don't have that pressure of being in a visit and that 10-minute clock ticking, where you can actually talk to the agent, give it the full history, give it the full context of what's going on in your life. It distills that information and gives it to your provider. We think that's going to be a game changer for how medicine is practiced moving forward. And like I said before, how we bridge that gap between what has traditionally been telehealth and brick and mortar medicine, and how we bring those together in a way that benefits patients and makes care and outcomes better for patients.
Great. And Petra, you'll have some thoughts on AI and other technologies?
Yeah, so with AI integrations, especially in regards to radiology, it's going to be an assistant to radiologists. It won't be a replacement, but it'll help triage, for example, complex cases that need urgent attention versus something that could wait. It will also, like I've mentioned before, take all of the history together with the medical imaging and provide a more better diagnoses. There's also augmented reality will be useful for surgical procedures that can overlay medical images, on top of patients and assist with surgeries that way. And also, this is a big one. It's going to be predictive, a lot of predictive applications when it comes to pathology, disease, mental health care decline.
Well said. I agree. It's going to be highly predictive technologies that help us treat patients. And Ahmed? What are you seeing?
I'm going to the foundation again, and all of this AI technologies require the data, and that's where the whole concept lies. The moment we say about the data till the moment your data was local to your particular provider, we moved a step of it. We had the health information exchange, which means your data can be shared between all 50 states. In the case of emergency, a physician can access this data. And not only in this country, across the globe, the health information exchange is expanding. What happens beyond it? The next concept is upon your international patient summaries, where your data across the countries can be extended. One of the best use cases which I have seen so far is with the collaboration of Indonesia government and the Kingdom of Saudi Arabia. A lot of people from the Indonesia travel for the Hajj in Saudi, and they make sure that your patient summary is available. The last 6 months of your patient summary is available. So if something is due on you, they are aware. That saves the life. With the data being shared across other countries like Estonia, which have used the blockchain to make sure that your data remains personal, it's not being misused. The technologies are evolving. On writing on the Petra, the more and more AIs you have, if I talk about the mammogram, most of the females at the age of 35 and plus requires a test to be done. It's not an easy test, all of us know that. It's not an easy one, but with the proper use of the AI, we can make sure that who's the right contenders so that your burden on your insurance practically reduces. Not everybody has to go for an age of 35, has to go for a mammogram test. Based upon your symptoms, your past history, we could predict whether you are right contenders or not. That's where the AI come into the picture. Moving further on the radiology side, you could reduce the burdens on the radiologist, where the reports can be automatically generated with the help of the AI tools. And the radiologist who was doing around 30 reports a day could churn out around 90 reports a day with the help of the AI. And we could have a right manpower being used at the right place. That's how quickly the AI is evolving and making you the more precise decisions.
Well said. Well said. Thank you, Amit. And Scott, what are your thoughts?
I mean, it's a lot of good points brought up. I think for us, what we're looking for is not just the disruption from a technological standpoint, but how that actually changes the care flows themselves for a lot of these patients than what we're finding. I agree with the point about agents are going to massively disrupt who's involved and at what points. We did a big project with the Gates Foundation in Northern Africa around the assessment of pulmonary disease. And there's really only a few really leading causes out there of various infections, obstructive disorder, things like that. And there was this attempt with the Gates Foundation to figure out how to treat more patients. And what they ended up doing was deploying with us a bunch of agents that would have you breathe into a cell phone, like into the cell phone. AI would determine what level of pulmonary malady you were currently experiencing. It would then go through and provide scripts to the local pharmacy, and within a controlled environment, tried to make this something that was completely administered by the patient. And it had virtually no other human interaction apart from going to pick up your medicine. And that sounds like an insane idea, that we have now removed the healthcare provider in that very narrow case, in that very narrow situation as a test case. But what they found was when a third party went back, the AMA actually went back as a part of this overall project and assessed the quality of diagnostic around what was happening, they found that they were catching over 73% more cases and more accurately. And so I think we're going to continue to see the disruption of what it means for who and where they're plugged in there. And another great example where I think it provides a lot of encouragement that this isn't just about technology is eating up jobs and we're going to worry about what all of us are going to do tomorrow. You know, in another place of healthcare, in the animal health space, we're seeing a very similar thing where AI bots are a heavy provider of information gathering, of pre-populating soap notes and treatment notes, so the physician has a much better roadmap before they ever walk in to look at your wonderful family dog. And in theory, what happens there is the vets become very, very scared of you're not going to need me anymore. But what actually happened was quality of care and accuracy of diagnostic went way, way up. And those wonderfully trained vets actually increased their billable rates and increased the amount of revenue coming into the clinics because now they were being used for incredibly important cases that were not just wellness exams, not just day in and day out. And so there tended to be some very exciting positive outcomes for this, but it was because we're relying on agents to effectively take some of the low-level work away from what's going on. And so I see that disruption kind of coming full circle of not just we're disrupting the technological side of the equation, but it comes back to that age-old piece of what do we then do with the people?
Well said. So many times in healthcare, it's been my experience that new technologies are invented, and there's a lot of fear. There's a lot of fear about, well, you can't treat people with telemedicine. You can't have good diagnostics. In the early days, before there was telemedicine, there were a number of studies done on the way people interact with computers. They're more honest in their interpretation of question or in answering questions. The results were interpretive, and it resulted in better healthcare results. And the same is true now, is what you're finding is AI can really enhance the healthcare experience significantly. So let's now dig a little bit deeper, because you touched on a number of subjects here. One is, what are your thoughts about how do we regulate AI? There's been so much attention to, oh my gosh, AI is going to take over the world. It's such an awful thing, and how do we control it, and how do we manage it properly? And so I'd love to hear the panel's reaction to that. And then in addition, think about things as simple as clinician burnout. And will AI help? Will it hurt? What will happen with job losses? Will there be new jobs created by AI? Would love to hear, sort of double click into the whole AI agenda here. So if you don't mind, let's start. And Ryan, we might as well start with you again.
All right, let me jump into the workforce for AI. For coming from hospital-wise and post-acute environment, we look at where AI is starting to jump in now and just scratching the surface of things like coding, MDS coordinators, where these are actually nurses, 4 to 5 nurses per facility pulled off the floor that do coding and read through the doctor's notes every day. Now with AI has been able to relieve a lot of that data collection and be able to query the doc back to put this workforce back onto the floor where it's needed most right now. We're short 5,000 nurses in the United States at a minimum. So this will restructure a lot of that environment, and providing more staff, more boots on the ground in that workforce is definitely what we see there. So I'll pass on from here.
Yeah, I could, that's where I see the game changer with nursing care. They spend so much of their time charting, very little hands-on interaction with their patient. I could see that freeing up a lot of their time. That's something to look forward to.
Yeah, I think that's also true on the physician side. As we look at deploying agents to help physicians, we believe we'll be able to decrease the visit time for physicians by maybe as much as 50%, because almost 50%, sometimes more, is spent on history taking, which is not necessarily value added if it can be done by somebody else. And so we believe that there's a looming physician shortage of up to maybe 100,000 physicians over the next 10 years, and we believe that AI technology is going to be able to alleviate that, and so we'll be able to do the same work or much more work, but take care of all the patients with the doctors we have, rather than trying to figure out some more convoluted way to train a bunch more doctors. So, that's part of it. On the regulatory side, I don't see a lot of regulation coming down the pike from the new administration. I don't think we are likely to see a lot of help in that regard. So a lot of us are looking at voluntary organizations such as CHAI, C-H-A-I, that is putting together outlines of ethical guidance, of ways to check out your AI technology and make sure that it's going to be compliant and things like that. So for those of us who want to be ethical and want to be on the cutting edge but want to stay compliant, we think we're going to likely have to band together on the outside of the government, kind of like we did with EHRs in the beginning. ONC was a private thing first and then eventually co-opted by the government. So that's likely what's going to happen here, we think.
Yeah, and you raise a really interesting point too, and I think it needs to be parsed apart between there's the ethics of how we operate some of these AI models and agents, and there's the legality of how we operate some of these models and agents, and both of them need to be addressed. I agree with you. The current administration seems uninterested in helping define some of those parameters there, but there needs to be a more concerted effort around acknowledging that an AI agent in some way, shape, and form as a thought experiment does not act in our society a lot differently than a person being held to the same standards. And there's a thought experiment that Chai has done and the AMA has done called the Dead Mary problem. We all know Typhoid Mary. You know, she carried typhoid, made a lot of people sick. And the Dead Mary problem is, logistically, the best thing you can do is kill her and be done with it. But we as a society think that's wrong, and rightly so. It is a bad decision. It is the wrong thing to do. Instead, we want to treat or isolate or do all these different things. We need to be able to create a legal framework that acknowledges that AI bots live largely in the same world, where they can't logically say the best thing to do is kill poor Mary. Instead, we need to treat. And that requires an extra layer of legality and an extra layer of ethics that aren't currently being mandated in some of these bots. So as we go forward, I think it's a bit more of an imperative than we should try to band together and hopefully, gee whiz, all do the right thing. I think we're going to find ourselves facing decisions around people's healthcare outcomes that are going to need to start conforming to what we consider the guidance of society. And the only way you do that is through legality, because the bots are not going to be regulated themselves in terms of social norm.
Yeah, and I think we should be clear with people at this point. All of our bots have somebody in the middle. They're, physician in the middle or nurse in the middle. Somebody else is looking at those outcomes and pushing the button for a prescription. But I loved your example in Africa, where we will eventually get to a place where some of these things will be autonomous, and when they do, they have to be ethical and they have to be held to the same legal standards.
Just adding on to it, in the UAE, we have a ministry for the AI regulation. It's a complete ministry which focuses on the regulation. So we as a developer, when we try to build anything, we have to follow these regulations. Like my friend said here, without the regulation, it's going to be difficult. For each of us as a developer, we need to expose which data set has been used. We should not keep them as a black box. We should expose these data sets, where they have been taken, what has been the outcome of those, what is the threshold on which we are operating. We are building up a product for the revenue cycle, and we are trying to eliminate the need of the manual errors by around 40 to 45%. This is done using the AI agents. The moment we involve the AI agents, we have put a threshold over there that, yes, if it has been 60%, it's good to go, but beyond 60%, you require the human in loop, so that over a period of things, that thing can be trained and be more effective. And this can be possible only when the countries are putting the regulations. I see the UAE, I see the China, and the Europes are putting the much regulations, which I see is kind of being lagged in the States, and that need to be brought up. Otherwise, the developers will keep developing it. They are right on their side. I'm not saying they're wrong. They have a data set on which they are building the product. And based upon the data set, it says, yes, my efficiency is 90% or the 100%. But when it goes to the practical scenarios, that's not the case. When you get the real data, that's not the case. So the data, again, has to set as the foundations, and these data need to be regulated.
Jump in. AI is coming from DC. This is the first time in healthcare that there is a implementation of another way of doing healthcare that has no guardrails or controls, as we talk about, and that comes back into that self-governance. But diving in, just to echo off of everybody, where we really see it, it also pulls into that patient safety. I mean, we're applying this into nursing IV pumps that calculate medications, things like that. It used to be the nurse can put in an IV and start a run rate. Now, if that medication is off, we don't know. I mean, that can run that cardiac med at 10 times the rate based on human error. But now with AI, it stops the nurse and questions. You put in this medication. Are you really sure that it's micrograms and versus milligrams? So it questions them and adds a large element of safety. So just echoing, I see where everything's going with it, and some guardrails and our own, us putting that middleman in will help.
With regulations, there needs to be accountability, split liability between manufacturers, manufacturers of AI models, physicians. When it comes to regulations, it's going to have to be split that way. We need to, I'm not sure how it works with state lines right now with telehealth, but I believe there's borders that you can't work past, right?
There's 50 state rules
Okay,
about
so
telehealth. It's
for
ridiculous.
platforms like these to work, obviously there needs to be changes. to those type of regulations. When it comes to regards to radiology, we need to have very accurate imaging, very good resolution images if we're going to have AI interpreting diagnostics. That's all I had to add to that.
So if we were going to draft some regulations right now, and I'm not suggesting we do that, but what would be the guardrails? What would we put in place to assure patient safety, to assure?
Someone needs to oversee. There needs to be, we talked about the loss of jobs. The jobs that are going to remain is people that are going to be overseeing the technology. Yeah.
I think we have to be really careful about regulating AI so that we don't sort of go where Europe has gone, where all the European AI companies basically can't use their products in Europe. They're all coming here because the European AI regulation is so onerous that it's really difficult. And so we have to be careful that we don't want to do what we usually do, which is wait until there's some tragedy and then say, oh my God, we got to regulate this thing. But we also don't want to go off the deep end the other way, and because we're scared of AI. We need to be thoughtful and create a good middle ground. And some of the things that the AMA has proposed and some of the things that Chai is doing, I think are a really great way for us to get that middle ground.
You know, that's a really great point. I don't know if the audience is aware, but Europe has taken a very cautious view on AI and its implications, and they've really implemented regulations that curtail creativity and development. And then the US right now is sort of the Wild West to a certain extent, where we have a lack of regulation. And the answer is going to be somewhere in between, ultimately. But the U.S., I think, is the right tactic in that we're waiting to see how things evolve before we make decisions about which guardrails to put in place. I do think that's wise. So with that, let's perhaps talk a little bit further. I'm trying to envision if we were here at this conference 10 years from now talking about telehealth 3.0 and healthcare 3.0, any idea what that might look like? Anything? Just curious.
I just envision robots and us humans not doing much work anymore.
As funny as that is, Petra, I think it does get us closer to this where, again, I don't worry necessarily that we're not doing anything as humans. I think that elevates us to a place where we get to do more interesting, more innovative medicine. But I do think my yearly exam, and I do think that, you know, typical checkups and bumps and bruises and vaccines, I may start living in a world where I am the sole administrator of that process, in as much as I initiate it, I walk through it, and I go home after it, having possibly never interacted with another person. Now, whether or not having gone through that means I did it all from the comfort of my home, or I go into a vaccine clinic or something like that, but I cannot imagine that I will continue to burden my physician and 2 nurses worth of time just to go get my next physical.
Yeah, I agree with Scott on that. I think, you know, if you say 5 years, I'd say, not sure. 10 years, I think we will be living in a world where we have truly autonomous AI algorithms, agents, whatever you want to call them, that are doing primary care to some extent. And then they will refer you on to, you know, hey, you need to actually see somebody. I also think you're going to see that many of our specialists will be in a place where they are mostly focused on procedures, because the base stuff that they, you know, cardiologists doing basic hypertension is unlikely to sustain, because we will upskill primary care physicians and we will upskill nurse practitioners and PAs to a point where they can take care of that at a specialty level, and we don't really need specialists for some of that care. That's what I think is going to happen.
I would bring up the concept of the health span and the lifespan, where we know what duration you are working until what duration you have an extra years. The more and more predictive analytics is going to come into the picture, I will see the people to be more active, more younger, more able to do more creative things that they should be doing, rather than putting an effort into the areas which does not require the human interventions. So I see as a person that I would have more time to spend with my families, to do more creative things, play around with my dog and the cats, rather than spending the time to just go to the hospital for a visit, to ensure that That's what the AI is going to bring for me. I don't see there is a need for a false fear regarding the AI. The technology was always evolving. From the decade, if you look back 2 decades back, there was a different technology, now it's something new, and that's what's going to keep happening. 10 years down the line, we might not be talking about the AI, we might be talking about something new term altogether. But that fear of the AI has to go into it. We have to adopt with it, we have to live with it. And it's going to only help us to be using the right time at the right place, rather than just having a fear of it.
So we've been really effective at talking about different technologies and the evolution of telehealth and healthcare delivery. Let's go a different angle. We're getting a lot of data, right? We haven't really spoken to the data issue. We're learning so much more and being able to create tables of data of all sorts of populations. What are the implications of that for healthcare? We'll start. Anyone who
Let me start this one, because I come from the Health Information Exchange, where we are collecting the data from across. And that's where the data set is required by almost everyone who is trying to develop anything on the AI, anything on the machine learning, anything on the predictive analytics. The data has to be the foundation. The more the clean data is, more the discrete data is, more you are able to going to take a thoughtful decision on it. You are going to structure your data well. Now, the data is coming from the multiple source. If we look how the data was coming in the couple of years and the way the volume is increasing over every year, it's almost a 10-fold increase every year on year. How do we put the data on the right place? How does my data, all data for me as a patient goes to my EMR? And now I'm not using only one device. I am using an Apple Watch. Sometimes I change it and I go for a Samsung Watch. I wear up a ring. How do I ensure that all the data has been reached to my EMR? And the physicians are able to view it. Based on that, all the applications which we are building here can do an analytics on it, can predict something, and the systems can use into it. That is what is required.
To answer 2 parts on the question, the last one and a little bit on this one, if we're looking at 10 years out, we're already in the development of a hospital at home program in rural areas. So those low-level hospitalizations, where they're that 1 to 2 day for sepsis, pneumonia, COPD exacerbation, some of those type of things, we're already have that in development. Should be fully executed by December of this year for physicians and AI and those remote patient monitorings reaching out and starting to manage those that population before they get so septic or so sick that they need to go to the hospital and take an hour ride to the nearest tertiary center. And then to dive into the data aspect. The data aspect is that earlier recognition of disease by gathering of data through AI and starting to put all the links together to go, oh, yep, this person's heading down the line for cardiac disease, or they're set up for cancer based on XYZ. So early information.
On the data piece, what I hope is that we create better ways of coalescing all the data so that we actually have all of the data about a patient in a place where I, as a clinician, can actually use it. What I fear and what I see is that we're going to continue to create islands and archipelagos of data that don't talk to each other. In fact, they all talk different languages, and we're going to continue to just have patients falling through the cracks because the data is here, there, and everywhere and doesn't actually come together in a seamless way that makes it easier for us to treat patients. And I don't think AI is going to solve that problem.
I agree with you. I don't think AI solves that. And I think a couple of steps down the road from that, even a little bit, thinking about there's going to be a dialogue that massively redefines what we think about as personal information. And it's driven largely by 2 things. Like right now, we all take that very seriously in terms of our own personal information, how it's shared, where it goes, how we control for it, and it feels normal. That is that's appropriate from our societal standpoint. But we see a generation that is 25 years and younger that does not prize their own personal data the same way. And so from a personal standpoint and from a people standpoint, this idea of personalized data being very personal is already starting to fade away independent of AI and independent of those things. And then you couple that with the better aggregation and much better data coming out. And we're, within our lifetime, going to very rapidly step into a world where we may just wake up one morning and decide that everything about me medically is simply not that interesting and we can share it freely.
I want to make a couple of comments about how we're using AI within Upscript. And specifically, we're not so much, we've spoken on this panel about the front-end patient relationship and the implications of AI. We really are using AI more in the background. In other words, we have dozens and dozens of engineers and software developers on staff. We're finding that they can now write code 3 times faster than they've ever written code. We've been able to not eliminate jobs, but change jobs and change functions among our employee base, which has been terrific. And then to the data issue and the use of AI, I think the way we'll use data is to try and create some predictive models based on demographic information. You know, this group of people in this socioeconomic level, in this race heritage background or work employment background, they run into, for example, we're seeing it in firefighters, for example. We treat esophageal cancer through telemedicine. We have a diagnostic program involved. And what we can do is, if someone is a firefighter, we can determine the likelihood of them developing esophageal cancer. And that's how we're using data sets within our organization. So with that said, I want to be sure to open it up to any questions in the audience. If anyone has any specific questions, please feel free.
Good morning. My name is Dr. Liliana Levato, Chief Medical Officer from White Wilson, Fort Walton Beach, Florida. So my question is that yesterday in one of the panels, we were talking about limited time from the physician to see the patient, to evaluate. We only have 15 minutes. Would it be, and how would that be regulated if we add AI to interview the patient pre-visit and go over gaps in care, education, because we don't have the workforce. It's impossible to load the offices with case managers to educate. It's not financially feasible currently. So how about deploying AI agents to interview patients before the visit and give a synopsis of to the primary care to empower the physicians to deliver the best quality of care? That would be, it's not really a question, but how can we do that? Can we get help on that? Because that's the crisis that I'm currently living.
And that's already happening.
Yeah, I mean, that's my company, so I'd love to get you to give that speech, and I'll put it on my website, because it's exactly what we believe and what we're doing.
That's really a great use case, by the way. So thanks for the question. You had a question there? Yeah.
So, James Seeberger, MD, PhD, work in the emergency room full-time, have a part-time practice. I use AI all the time. I just do Google, it comes up with an answer. I use it to test my thinking, go quickly to see what's new, if I'm treating appropriately, because I don't want to get caught in a sort of tunnel vision of going down a direction. So I'll say I use AI a good deal. I use ChatGPT, create a graph of births per 1,000 for the last 30 years. Boom. 1 minute, I mean 10 seconds, it's a direct line down. So what I would say is the ability to get information to me very quickly that can inform how I think is very powerful. Now, I talk to the radiologist and say, Andy, what do you think about AI? And he's like, I hate it. I'm already overwhelmed, and it's another layer that I'm going to have to go through in which I already know the answer. And so it's pretty interesting, perceptions of what helps me make decisions along the way. Depends upon the circumstance. I have a business partner. He's like, look, my mother had this heart rate, it was 180. I took all the symptoms and I put it in, and 2 minutes later, DeepSeek is telling me it's PSVT. And I'm like, I know that in 5 seconds. I literally know that in 5 seconds, faster than you can enter that in as somebody. I don't need that. Maybe palindromic, okay, what does that look like? Review EKGs. So what I would tell you is there's a lot of misperception about what's advantage and what's disadvantage. Please work with doctors. The last thing a couple more things I'll say. Europe has a prove safety first. Prove safety first. That's their background. The US is prove harm. Prove harm. So it allows innovation, but then we have, all kinds of chemicals and crap and shit that's causing us to get diseases and die. It takes 20 years to prove that. And the industry is like, okay, we know that this is the change, so we're going to change the molecule a little bit. We have dioxin and we have brominadoxin, 40,000 times worse than dioxin. So there is some sense to having safety built in. I would argue that. The last thing I would say is when you really, one way of looking at living is we're going through quantum fields of all kinds of probabilities of possibilities, and that's how we live. And that's actually true when we look at people who are sick and maybe dying. How do I change that future for them? Always to living. The problem with computers can be it's very deterministic. This person will die, this person will die. And it's not true. That's what the future is. That's what living actually entails. I just say, if it's possible, build that into your AI.
Thank you.
Thank you.
And you raise a really interesting point, too, with your example of being able to determine some heart condition there, and that you can, in fact, determine it in 5 seconds when it took someone 5 minutes to put that into AI. And I think what we need to parse apart is a little bit of the misconception that AI is simply augmenting your decision-making versus AI can be there in your absence of your decision-making. So, for example, if you're making such an astute and very good diagnostic, an AI bot can help you do that for 5,000 people all before lunch. And so your ability to determine that case isn't really about how fast, the road race of could you put that input into your brain faster than I can put it into a bot. I have no doubt you win. But when I want to treat 5,000 people before lunch, I win.
Well said.
I would just add here. First, I'd like to thank you for taking the part that, okay, yes, AI is not there to be replacing you. Yes, it definitely gives you an answer, and like what Scott rightly said, that if you are not there, then what's going to be the next? And that's where the technologies come into picture. Definitely, if the physicians are available and they have ample time, they will spend more time with the patient and then look around to a better treatment. We are nowhere doubting on it. AI is there to assist, is to increase the, like what our friend asked in beginning, that how do I reduce the load on it with an ambient technology. For an example, the time spent on documenting something can definitely be reduced to a couple of seconds because you're speaking on it, it gives a note to you, and you are done with the next patient, and you spend more time with the patient. Right, you rightly said, you know the conditions in 5 seconds, but because you are already experienced. And that is when experience is going to come as more the system improves. That's where the data come into the picture. If you look at the ChatGPT 2 years earlier, it was not so accurate. If you look at now, it's more precise. DeepSeek is more precise. The new models which are coming are more precise, and that's what's going to, the evaluation is going to come into it.
Thank you. Time for one more question, perhaps? No? No, we got to cut. So, listen, thank you very much, and thank you, panelists, for participating. We are basically hoping to correct a broken healthcare system that we have today. There's a lot of good things happening in the world and in the world of technologies, and that's what this panel is really focused on. So, thank you very much.
Thank you.
Thank you, panelists. All right, what happens when cutting-edge technology meets a well-structured healthcare system? Germany's digital transformation in healthcare and pharmacy services has set a benchmark for innovation worldwide. From electronic prescriptions to AI-driven patient management, the country's success offers valuable lessons for global healthcare. To take a further dive into this topic, our next session is a keynote, Digitalization of the Healthcare System Pharmacies, Success Stories from Germany. Leading this discussion is Stefan Wall, the pharmacist at Vital Welt Apotheken, and our bronze sponsor, bringing forth his expertise on the subject. Please welcome Stefan to the stage.
So, hello everyone. My name is Stefan Wahl. I'm a pharmacist from Germany. And today I want to talk about the digitalization of the healthcare system with a special focus on pharmacies in Germany. But first, I want to give a big thank to my family. Today my entire family is with me here. We have holidays in Germany. Universities are closed, the schools are closed, and we have a chance to be here for 1 week. And now they hear the first presentation from me live. Last year, I think, only per video call. Thank you very much. And all my children speaks better English than me. They can translate, and my English is not so good as it should be, so please forgive me if I search some words. Okay. So, why is the digitalization the most important topic for our company in the coming years? I think there are 3 big challenges in the future. We have a massive shortage of medical professionals. In Germany, I think also in the US, we have a rise of big data, and we have the quest to keep the costs low. And these 3 challenges, I think we need digitalization to achieve it. So I want to give a brief overview over the content. So I want to give a short introduce of my person and my company. Then, now I need the glasses. We are going to the German healthcare system, background information about digitalization. We look to the electronic patients records. We look to telemedicine, telepharmacy, e-prescription, e-health apps and wearables, and further, last but not least, we have examples from the practice from our company. So, I'm 51 now. I studied pharmacy in Halle in Germany, and then I changed to medicine in Heidelberg. That's a city the most citizens from the US know, I think. And 2001, 3 years after, I don't end the medicine. I have the chance to found a new pharmacy. And I told me, okay, it's time to work and it's not more time to party. And so I opened the pharmacy, the first Vital Welt pharmacy, Vital Welt Apotheke. And we expanded the next years. As you can see, ich muss das hier machen. Okay. That's me. And we expanded. Here on the slide are 6 pharmacies. Now today consists the collaboration of 8 pharmacies, and we want to grow the next years also. Today we provide between 4,000 and 6,000 customers per day. We provide to 3 clinics, 3 hospitals, and approximately 2,500 nursing home residents. And just have a look to the further companies. Of our group, we have the LMU. The LMU is responsible to build medical houses and operating rooms, and the Diametral is providing healthcare in rural areas with telemedicine, with telepharmacy. And our newest baby is a shop for babies called Vitalwelt Family Store, where you can buy sustainable clothes and toys for newborns and babies, and where we also offer advice by midwives. So, now we come to the topic, digitalization of the healthcare system. I make a question mark. Is it a success story in Germany? I think the leader of digitalization is the US. I'm now here in Las Vegas. And we will see if we have in Germany a success story. In Germany, we often be a little bit slower, and we have a big regulation, but we need to develop the digitalization faster. So, in the beginning, just a look to the German healthcare system. So you see it's a complex system. In the inner circle, there are the patients and the service providers like doctors, hospitals, pharmacists, physicians, midwives. And in the second circle, there are the administration, insurance, government. And in the outer circle is the free market, where you can buy medication, Wegovy, all the medications who the insurance don't pay. And there's a complex system, and we take a look to the insurance system. In Germany, it's mandatory to be insured. That's different to the US, I think. We have 85% in the statutory insurance, and we have 15% in the private insurance. And how can we get in the private insurance? You must be self-employed, or you need to earn more than 6,000, around about 6,000 euros per month. Then you can decide in which insurance you want to be. Yeah, and if you can see here, the government and the insured pays in a healthcare fund, and the healthcare fund paid the service providers then. Okay, and we have also a national digital health agency. It's called Gematik. The Gematik is responsible for, one moment please, is responsible for all the digital projects like telematic infrastructure, like e-prescriptions, like APA, and all the other things. 51% is government, so Gematik is a government company and no free company in Germany. Okay. So, take a look at the digitalization overview. If we can see, the global market has a growth rate per year around about 15%. That's a big market in the future. And when we look to the numbers in Europe, 155 billion euros in Europe 25, 38 billion euros in Germany, and this is from 2022, 330 billion worldwide, and I think it's now over 300 billion in the market. So as I said, it's a big market for the future. So, the essential projects, digitalization in Germany. We have the electronic patient record called APA in Germany. We have the e-prescription, we have telemedicine, we have telepharmacy, we have wearable devices, and we have healthcare apps. And let's dive in the first in the EPA. The EPA is the essential element of connected healthcare. It's a digital file in which you can store, view, and share your health data. it enables quick access to all relevant informations. So everyone can see, not everyone, but service providers normally can see all the health informations from the people, from the patients. We have in Germany the EPA in an app or with a health card, and it's important for multiple illnesses who are treated by different specialists. Yeah, you don't have all. You can see all the data. The advantage. Sorry, I have the problem. I switched the iPad and not this one. Advantage is fast and easy access to all relevant medical informations, better interdisciplinary collaboration, and no more paper needed. Disadvantages, data security is a problem. In Europe, we have a stringent data security. Then in Germany, still too few providers are involved in the telematic infrastructure because it takes time and it takes financial investment, and you need to keep it up to date every time. So, telemedicine, just have a look at telemedicine, telepharmacy. What is it? Telemedicine makes it possible using audiovisual communication technologies. Telemedicine is an important part of medical care, especially in rural areas. And if you see this map, it's like we heard before, on the white parts of the map, you need more than 30 minutes to the next hospital, you need more than 30 minutes to the next doctor. And in the next years, perhaps you need also more than 30 minutes to the next pharmacies. In the last 2 years, we closed over 1,000 pharmacies in Germany. And I heard in the US it's the same problem. CVS and Walgreens want to close around about 50% of the pharmacies. That's a big, big problem. And it comes from a shortage of medical professionals and from too less money. It's everywhere. So telemedicine, telepharmacy can help for these rural areas. So we have advantages, the faster access to doctors and pharmacists, and it's important for the structurally weak regions. Disadvantages, older people could have problems with technology, and also everywhere the data security is a problem there. So then we come to the e-prescription. E-prescription in Germany, we begin 2002, and we started 2024. Yeah, it's insane. And now, today, we have 50% e-prescription in the pharmacy, and we have 50% paper prescription in the pharmacy 1 year after the start of the e-prescription. Not good. I hope it's better in the next years. So was it the e-prescription? You can get the prescription on your health insurance card. And then you can come to the pharmacy, you take the card in the terminal, the pharmacist download the e-prescriptions and handle the medicaments and give the medicaments to the patients. It's better for the patients. He must go to the doctor. He can also make a phone call for the medication and go to the pharmacy, and the medication is on the server. But it's only one server in Germany, and if this server is going down, you cannot use any e-prescription all over Germany. That's a problem too. So here you see our old paper prescriptions, and today you have the card or you have a QR code. You can present it in the pharmacy, and then you get the e-prescription. One problem is the paper prescription, every patient can see what he become. With the e-prescription, he come to the pharmacy and told us, oh, can you look if there's something on it and what? And often it's the not the right medicament, not the right medication. That's also a problem in the moment. Okay. Advantages is faster and safer redemption method, and the storage of paper prescriptions is not necessary anymore. Our insurances store the paper prescriptions for 7 years. They need thousands of square meters to store the paper prescriptions, and this is no more necessary. And disadvantages, data security. Yes. All data is stored in one server, and I think this is a big problem in Germany, but it's a thing what the digital agency has made. So we wait what will come. Okay. Short, the wearables, what we have for wearables in Germany. It's activity tracking, fitness apps. We have fitness trackers, we have health apps, medications, nutrition, symptom checker, smartwatches with fitness apps functions and other devices. And one, I think you knew it, you know it in the US. It's my favorite wearable device. It's for the blood sugar. You can overview your blood sugar by an app, 14 days, 24/7. And it's very disciplining. Yeah, eating cake goes to zero quickly when you take it. So, I want to show you some further examples for the digitalization from practice. And first, we have a photo from our first video pharmacy in 2014, 11 years ago. She looks like she need to go to a museum now. But at this time, everyone told us, video pharmacy, no one needed a video pharmacy. Our colleagues, we need no video pharmacy. Sorry. Where is it? Okay. Old. But today, there are many video pharmacies in Germany and also many telemedicine places. Digitalization of the medication. This is the storage machine for around about 15,000 medicaments, so the medication. So we don't need to go to the, I don't know the word in English. If I take the Schublade, can translate someone? Oh? Medicine card, okay, yes. So we store this in this machine. And the next one is the most important and successful project what we have. What we did in the past is we delivered all medication to people, to nursing homes, and they were blistered manually by geriatric nurses or people himself or daughter or son, and the mistakes are very high, up to 10% in the nursing homes. And what we do now is we download the digital medical plan. We make a double check. We blistering with an automatic machine. We control with the automatic machine. After that, also a pharmacist looks if there are problems, and then we deliver the medicaments. And this is our box for 7 days. And I think digitalization should increase the quality of life. If you get a prescription in 2 minutes or in 20 minutes, it's great, but it's not a must-have. But if you can avoid side effects, if you can avoid drug interactions, if you can avoid hospital admissions, I think this is increasing the quality of life. And if you see in Germany, we have 5% hospital admissions only caused by drug interactions or side effects, 5%. And I think worldwide it's the same. And if we have the chance to reduce it with digitalization, with AI, with KI, then it's good for the people. So, the last example, what we have in our region, we digitized the AEDs, the automatic external defibrillator. So, if you have a heart attack, then the layman calls the emergency number, the operation management directs the layperson to the AED and back to the victim, and the layman can revive the patient faster than normal. Yeah. So we have an evaluation in collaboration with the Universität Hohenheim, and the use has been increased above the national average since 2017, between 53 and 117%. So I think this is a success story. Okay, thank you for your attention. If you have any question, feel free to ask. Okay, then thank you very much.
Well, the day is rolling right through. It's been a good morning, but we do have a few moments to go ahead and do a business card exchange with the people at your table. So get to know your friends and meet new friends, I guess. We'll reconvene at 10:20. All right, everyone, welcome back. And now from our technological advancements to growing public health crisis, let's talk about the impact of loneliness and isolation on overall health. This panel on loneliness and isolation, addressing the health crisis or health risks of social disconnection, brings together experts to explore the long-term health risks of social isolation and the urgent need for systemic solutions. From community-based interventions to digital mental health support, they'll share their insights on how to reconnect a disconnected world. Please give it up for our moderator, Devaki Tharasha, for independent volunteer at Data Transparency, and the rest of our panelists. Welcome them to the stage.
Hi everyone, really good to see you. Can you all hear me okay? I think the mic's turned on. That's it. Thank you. It's really an honor to be here with our esteemed panelists, and I'd just like to thank everyone for being here for this important discussion. Loneliness and isolation has affected a lot of people, especially after the pandemic, and got some really profound and insightful stories, and I'd love our panelists to introduce themselves. Lisa, go first.
Okay. Hi, I'm Lisa Driggers-Milam, and I am from the mountains of Georgia. So a little ways from here, but I am the founder of the American Women's Empowerment. We are the large women's nonprofit group that if you've ever been bullied or harassed and you want to heal, we work with that. So thank you.
Thank you. Moving down.
Good morning. I'm Dr. Carl Forkner. I'm from Mesa, Arizona, right down the road. I am a psychologist focused primarily on research rather than clinical work, and my focus area is on veterans, and this is a very important subject for veterans because it plays directly into one of our primary focus areas for veterans medicine, which is suicide prevention.
Good morning, everyone. My name is Maria Burke, and I'm a registered nurse, and I'm a home-based company called Celtic Angels, and it's just such a joy to be here with everybody. So we take care of a lot of patients, a wide variety. Our youngest would be 41 quadriplegic, and our oldest would be 103. So this is a very relevant conversation for me, loneliness and isolation. Thank you.
Good morning. My name is Liz Connolly. I'm the founder and president of the Thin Line Peer Support Team. We are a nonprofit organization based out of Connecticut. We are a peer-to-peer mental health support team for all active military veterans, regardless of discharge status, and first responders, so dispatchers, police, fire, EMS, Department of Corrections, and emergency department staff.
Good morning, everyone. My name is Tony Curtis. I am a full spectrum doula. I own a company called Birthwise Doula Services out of North Carolina. We are a full-scale maternal health support system. We cover every aspect related to maternal health support, from birth, postpartum, nutrition, lactation, anything that goes on, including mental health, we cover.
Thank you so much, guys. I'd just like to see a show of hands in the audience. Who here has felt loneliness or isolation during any time in their life? All of us, yeah, definitely. I just want to go through each of our panelists and just discuss what loneliness and isolation, how it's impacted you and how you've helped to combat that in your lives.
That's a great question. 3 years ago, I had a brain tumor and a stroke. And during that time of healing, I learned a lot about isolation and loneliness. It was a very scary time, but it was a time where you wanted someone to be there just to hold their hand, just to know that you were important, that you have value. And it has become a big mantra for me since then.
Thank you, Lisa. Dr. Carlford.
My experience came kind of along the lines of the Grand Slam of military personnel. It came after I left, retired from the Navy. I moved cross country, so I had just lost my job. I was leaving my friends. I was leaving my 2 adult kids and moving to a place where the only person I knew was my fiance. And she was working full time. So here I was at home, knowing nobody, and there all day. The only thing I had really to focus on was finishing my first PhD. And then once that was done, there was nothing to focus on. So I had lost my job, I'd lost my friends, I'd lost my family, I'd lost my mission, I had lost my purpose. And I got out of that hole by focusing on my physical health, which eventually helped my mental health.
Thank you, Carl Maria.
Well, I'm originally from Ireland, and so immigrated here about 30 years ago. And myself and my husband, we came with a phone number. And I'm from one of 6 myself, so I was just desperately homesick. And this feeling of loneliness and isolation, coming to a different culture, and I'm sure maybe there are very many people in this room that can identify with that, made me more of an extrovert to reach out to people and reach out for more community support, which I feel is part of the solution of our epidemic, that's what I'm going to call it right now, of loneliness and isolation post-COVID. I mean, everybody in this room outside of the immigration part has survived COVID. And it's amazing that we're still here. I really do feel like it's a miracle. So I think that's my experience. That's what I bring to my practice with my patients, because I do a lot of hospice work, and I've been with a lot of patients that have taken their last breath, and they are scared, they are lonely, and they are isolated because they're afraid they just don't have that forum to talk about how they're feeling, because they're too afraid of upsetting their families. So, that would be my experience. Thank you.
For a lot of first responders and for a lot of our military, the nature of our jobs socially isolates us from our families, from our friends. I'm fortunate that my husband is also a paramedic. He also is on the fire department. So when I go home, I can talk about my day. I can talk about what traumas I've seen in my job, and I don't have to worry about him turning to me and saying, I can't hear about that. It's too traumatic. But I can't talk to my parents about it. I can't talk to, when I was married to my ex-husband, I couldn't talk to him about my day. I can't talk to a lot of my friends about my day. They don't understand when we go out to dinner why I have to be facing the exit. They don't understand when we go to a hotel and we go on vacation why I have to count my steps from my hotel room to the exit door, and why I have to know exactly how many steps it is from my hotel room to the nearest exit or to the nearest fire escape. These are things that almost every single person that I know that has served in the military, or that serves on a fire department, that serves on a police department, that works in EMS, does. Every single one of them will not sit with their back to a door. Every single one of them will know almost, or at least have a general idea of how many steps it is to get to their nearest exit. That's ingrained in them. They have a heightened sense of security. They won't be able to come home from a day at work and sit down with their loved one unless they're in that same field and talk about their day. And just the nature of their job isolates them from their friends and family. And that's a very difficult thing, to be able to come home from your work and not be able to talk about that and not be able to unload any amount of stress from your day with the people that you do truly care about, because you want to be able to share about your day. You want to be able to share about the things that you've suffered, or even the good things that you've done at work. You know, I had a great save at work, but even those great saves at work are traumatic and you've seen somebody at their worst. You've seen humanity at its worst. And those things are things that the general public don't want to hear about or can't hear about. And that socially isolates you from everybody else. And that takes a very heavy toll on the mental health of our first responders and our military personnel. And that's really what pushed me and my team to start the Thin Line Peer Support Team. And you know, our motto is no one fights alone, because no hero, no first responder, no military personnel should ever have to fight their mental health battle alone.
In our work as doulas, we're always in the community. And for COVID, our entire world shut down. Doulas are not accustomed to necessarily being alone. I had a very small child. I was in my postpartum period myself. When it closed down, I got to experience something that I hadn't, which was depression. I went through that depressive state trying to take care of a toddler and a baby, and there was nowhere to go. There was nowhere to go. The only thing I could manage was sleep, because every day I woke up, I had a toddler, a baby, and nowhere to go. And we worked from home. Everything was virtual. So even though my husband was home, he was working. So there was no connection, no community. And children, they do not care. They have zero interest on whether or not that's working out for you. So what we ended up doing after I went through that, we started virtual programs where we started doing fitness together. We started interacting more. We did get our community health workers going out and doing visits in the grass, in the yard, yelling into homes, asking if they were okay. Because we were watching our mothers de-evolve. We were starting to get phone calls on a greater frequency that we had never had, where they were leaving their babies. They were dropping them off and they didn't know where mom went. That is not how we operate, but we had to acclimate in a new world of being isolated. So to overcome it, we did what we could with virtual. And if you've never met a doula, just know that the minute that the world opened back up, we were outside and looking for all of you. So.
Thank you so much, guys. Briefly, just my aspect of loneliness and isolation, I can relate with all you guys, and it kind of more so just before the pandemic, I moved to a new area and I was away from my friends, and I think the pandemic hit and then it was difficult to make new friends, and with that social age, you just need human interaction. I know technology is a big part of things, but we still need that human interaction, and finding that sense of community is really important. Otherwise, you feel kind of empty. And I just want to ask, because we've talked from Liz's point of view, sometimes people don't quite understand what we're going through. I'd like each member of our panel, how can like friends or family help, you know, loved ones go through loneliness and isolation? Any tips and tricks you'd like to give?
Okay, well, I'm a Christian, so my spiritual gift is encouragement. And so that is it's a big thing for me, is I look and I see people that are down or quiet, or sometimes you just know something about somebody that they're just not right. You can take that time and just walk on by. Or you can stop and you can look at them and say, hey, are you okay? What's going on? And you have to be vulnerable enough to tell a little bit of your story, which makes them vulnerable enough to be real with you. And when you get that kind of response, it gives you the courage to go back through and to do it the next time, and then the next time.
I really like that. Thank you, Lisa. How about yourself, Doctor?
I think one of the important points to make is that alone and loneliness are different things. You can be in a room full of people and be lonely. I think one of the key points that my colleague just made is the point of getting involved, not just walking on by. Because we're busy in our lives and we see lots of people, but sometimes you just get that gut feeling that something's off with somebody. And just giving them a smile and saying good morning may open a conversation, but we have to be receptive as that person to let our guard down enough to be able to have that conversation. And oftentimes, that's the long pole in the tent. Especially when you talk about veterans and first responders as well, we have walls that we've put up, and we've compartmentalized our lives. And so when you find somebody that has compartmentalized themselves like that, it's sometimes hard to break through that wall. And somebody told me many years ago something very important that I used as a naval officer, and that is you have 2 ears and 1 mouth for a reason. And that is to listen. And don't listen to reply, listen to understand. And so I think making that connection is so important.
I just love what you just said, because I think being a good listener is such a gift to have, because you're giving that person space to express whatever it is that they want to express to you. Of course, and it's all about timing and feeling connected to that person, because I think that our gut is a great indicator when something is not quite right with a person, and that you can offer your presence, which is hugely powerful in our busy world that we have today. To let that person know that you really care about them and that you are there to help them, even if it just means that you're there just to listen to whatever concerns or difficulties that they're having in their life. And I would just like to say that none of us in this room is an island. We all need each other, much as we probably don't like to hear that, because we feel that we want to be independent and self-reliant, which you can be, but just that you do need family, friends, support.
I think, building off of what my colleagues have said, the idea of getting comfortable with silence is something that can be hugely helpful when trying to help somebody who is struggling with loneliness. I think when you are trying to help somebody who is struggling with mental health or struggling with depression or trying to, especially when they're first at the beginning of their mental health battles, and they don't necessarily know how to ask for help, or if they're not even sure if they're willing to ask for help, get comfortable with silence. Just sitting with somebody and, as my colleagues have said, just being present for them, but not overwhelming them with giving them advice or telling them what they need to do or what you think they need to do is going to just push them farther away from getting the help that they probably need. So being comfortable with just sitting with them in silence and giving them support and showing them that you're there to help them when they're ready to take that step is hugely helpful.
I love everything that I've heard. I think one of the big things that happens when a person comes to you is that people think that someone is looking for a solution from you. A lot of times they don't need a solution from you. They just need you to be present and actually listen to them and not judge them, right? Silence is a big part of the problem, but they're silent because they feel like they're going to be judged. Or you're going to tell them what to do when that's not what they're looking for. They're looking for support. And there's nuance to support versus the over-engagement, the judgment, or quickly trying to build a solution for them.
Thank you so much, guys, for sharing your perspective. I just want to say big thanks to our panelists as well. We didn't know each other before this discussion, but we managed to, we reached out to each other and build that kind of rapport and conversation, and that's what we want, happening more as well outside in our lives. Just don't be scared to strike up a conversation with someone. We're all the same people. You just don't know what people might be going through inside. So I think just being there and present in that moment and just having that listening ear is just really meaningful. And I know there's been a lot of talk about digital technology and things in this conference, but I think with loneliness and isolation, it's something that, AI can't answer our problems. And in your organizations and in your daily lives, have you ever had any kind of digital forms that have helped you out? Or is it more internally within gratitude and things like that have helped you more?
Well, you know what? To be honest, I've never thought about it, but I have never had any type of AI or anything help me on my emotional level. It's helped me learn. It's helped me figure out what exactly I am going through, but I think that you need person to person when it comes to that.
That's a great question. I work primarily with veterans. There's 3 sets of veterans that are most at risk for loneliness, isolation, the mental health challenges that come with that. The first group is the group that's just left the military, left their job, left their friends, left their mission, left their focus. The second group is the 75-plus-year-old group, the Vietnam vets, who have outlived many of their friends, outlived many of their family, have health issues, physical health as well as mental health, that are fighting all of those demons. But the one that strikes me most is we have a lot of rural veterans that live quite a ways from both physical and mental health capabilities. And I've used not necessarily AI, but video teleconference with them on many occasions, which allows them to have connectivity and see somebody physically face to face that they can talk to. And oftentimes, if you think of social media and how brave people are on the other side of their avatar, people tend to let their guard down a little bit and be a little more open when they have the protection of that screen in front of them between them and the person they're talking to. As I said earlier about how we build walls around ourselves, they're not violating their wall that way, but they're able to make connections that are meaningful to them.
I have to say that I wouldn't really know much about AI, but what I will say is I loved Zoom and Team that we used for all of our nurses, our staff. They needed the support, and that was like a miracle to me, that Zoom. I loved it. We could see each other on a screen. We could have up to 100 people on a screen. I was like amazed. But it really helped, even though nothing replaces, I feel, the one-to-one connection for sure. So we incorporated that during COVID with all of our patients as well, and their families who also needed to see a face. So really, that's all I have to say about AI. Apologies.
I don't know specifically about AI. I'm not a technology person. I'm the person who gets frustrated with my smartphone and throws it across the room. Any of my team members will attest to this, that they don't trust me with laptops, they don't trust me with computers, they take technology away from me. But I agree with Dr. Faulkner in that we have been able to reach a lot more first responders, a lot more veterans, a lot more of our military personnel, and help a lot more of our heroes get the help that they've needed with the use of Zoom, with the use of technology, because one, they're more willing to talk with that protection of having a screen between them and a clinician or them and us without having to sit face to face and, it's that barrier, having that kind of wall between and giving that little bit of protection, or they don't have access to get to us physically. But it's also that double-edged sword because, for us doing peer-to-peer work, now I don't also have that face-to-face, and it's a little bit harder for us to read those nuances for if somebody is truly suicidal, if somebody is truly homicidal. Now it's a little bit harder for us to do intervention work with them, but it's not impossible. So it's a double-edged sword, but it's certainly come a long way in terms of us being able to help the people that we need to help.
For us, we were restricted from going into hospitals during COVID, so we could no longer serve our birthing community, and we had to switch over to virtual. One of the cornerstones of healthy birth practices is to have continuous support. As been mentioned throughout our discussions, the shortages in healthcare. Well, one of the helpers was restricted that could have come in and helped that community, and we are seeing the implications of it now with an increase in mortality in this country. But we did have to go in and we did have to start getting virtual. We had to quickly get up to privacy standards and HIPAA compliant really quickly as soon as COVID hit, because we could not go in with our families anymore. So it changed a lot of how we had to work together.
If I could follow up real quick on your comment here about what we look at with suicidal or homicidal people is very hard to make that determination. The earlier discussions on AI and technology, that's something that's coming that with a minimum amount of visibility of the client or the patient, that AI could use markers to be able to help us in the future be able to detect those tendencies earlier.
Thank you so much, guys. As you talk, I'm busily typing notes down for the next set of conversations, so I don't want to seem rude like I'm looking at my phone. I think that's what technology is more useful for documenting ideas and not so much the kind of, like it doesn't give you that human aspect in terms of the isolation and like how to combat that. It's more of a tool. So with COVID, I know within your organizations and just daily lives that impacted a lot, like in a very negative way. If something like that was to ever happen again, a pandemic, or just if someone all of a sudden finds themselves feeling lonely, what can they do? So we've talked about what others can do to help, loved ones, but what can people do to create like an armor within themselves to feel strong and in future, if we are socially isolated because we have to go to a new country, what can people do to help themselves to break out of that feeling of isolation?
That's a tough question.
Yeah,
Yeah.
it is really
Thank you. If you can move on to the next question,
Yeah.
that'd be great. No. I think that it is important that we realize what we've been through. Every one of us is a survivor. It was a very crazy time. It was a difficult time. It was a sad time. So everybody here is a survivor of that. But if I were going through that again, I would be very thankful for the computer, for the Zoom, for the numbers that are on my phone, for the ability to text and things. I think that staying in touch with people even more is more crucial now than it was before the pandemic. I think that we have realized what it can be like. It gave us a shot at how dangerous, how scary something like that is. And I think it's taught us what we need to do differently and how we need to change things and to keep everything in perspective.
Thank you so much, Lisa.
I agree. One of the things that oftentimes we don't do because we take it for granted is take an introspective look at who we are and understand who we are, because we have to be comfortable with ourselves, really, to be comfortable with others, especially those that we're not familiar with. And we don't do that enough, I don't think. So I guess that's your homework for today, is just take a few moments for some introspection and say, who am I? What's my mission? What do I stand for?
I think self-care is very important when you're going through a tough time, and to be extra kind to yourself. And I also think if you can get out in nature, not in Boston in the winter, it's been freezing cold, but find an alternative, maybe go to a greenhouse or something. And pet therapy. I just love animals, and I feel that this unconditional love that you can get from your pet, nothing replaces it. Sorry, husband. But and also, I also feel that, you know, this is going to sound crazy, and maybe I am a bit crazy, but giving yourself a hug when you feel that you're alone. And just telling yourself that it's okay, everything's going to be okay, God has a plan for you. And I actually had a near-death experience myself, so I do know that there's a God and a heaven. And just meditate, whatever makes you feel good. Yoga, good food. We all know food is medicine. And just be extra, extra specially loving and kind to yourself.
It is okay to not be okay. That is something that we tell our first responders. That is something that we tell our veterans. And it is something that every single one of them, when we tell them that, sits there and laughs at me for. Because it is something that when we tell them that, they go, well, yeah. But every single one of us, when you hear that, you go, well, yeah, I know it's okay to not be okay. But when you're the one that is in crisis, or when you're the person that is feeling lonely or having a mental breakdown, you're struggling to tell yourself that it's okay to not be okay. I'm strong. I can get through this. I shouldn't be struggling this much. But no, it's okay to not be okay. It's okay to be struggling. It's okay to have a bad day. What's not okay is when you let those thoughts and that bad day overtake everything, and you start talking to Jack Daniels exclusively, or you start talking to Jameson exclusively, or you start talking to that little bag of pills in your pocket exclusively. That's when it's not okay. That's when you need to get your phone out and start going through and finding the people in your phone that are going to sit in silence with you and help pull you back.
I think something that we always need to remember is that we're a communal people. We don't do well alone all the time. There is no human experiment that is even remotely considered ethical where human interaction has been completely removed from another person. So, one, when you are lonely, you need to have a community or someone where you can say something and say, I don't need anything, but I need you to know this. So someone will know to check on you in the coming days. That is how we help prevent that loss of life. Because if we don't, we're going to continue to see what we've seen. And it's happening over and over again.
I love that. Thank you so much, guys. Just that sense of community really does make you feel like that sense of belonging. And we touched upon the topic of self-care as well. I know there's things like comfort food or, doom scrolling that is not, people think that they're taking time out, but it's actually not useful. I was thinking, because we're at the health conference, could the folks working within like healthcare and just you or I, just people who are not medically trained, are there certain foods or drinks that you recommend that kind of made, like, elevated your sense of, like, energies, maybe during, like, a tough time? Like they say, fruits, vegetables, drinking water. Is there specifically anything you found that kind of gave you a boost?
Well, being that I'm getting older and I'm gaining weight, yes, there definitely is. I think it's true that dark chocolate has some definite health benefits. So I say we all need to eat more dark chocolate, but it is important that you eat and drink something, but you need to think about it. I cannot tell you how many people I see who are on their phones and doing things like that while they're eating. So they're not enjoying the moment, and it makes me sad.
I'm all in for the chocolate.
Yeah, I like the chocolate.
Love dark chocolate. I like fresh fruit. I start every morning with yogurt and fresh fruit, and that starts my day off right and gets me pumped up, ready to go. And I think I found that, yes, there are comfort foods, but it's all about how much, not what. And we can tend to overeat when we feel down, and that just pulls us down a little farther. So, moderation in all things, regardless of what it is that makes you feel better.
When I lived in Ireland, we used to have blackberries that you could just pick off at the side of the road, just pick them off. I know it sounds really unhygienic, but they were delicious. So I was delighted when I came here and I found blackberries in Stop and Shop. And berries, raspberries, all the berries have been proven to improve your brain health, and I need all the help I can get. So that's my go-to, and of course, chocolate.
Water. Everybody does not drink enough water, and I'm guilty of it too. So definitely drink your water. I love fruit. I try to eat fruit. My rabbit comes and steals it from me every single time I try to eat fruit. So do my dogs, so I never get to actually eat my fruit. But I would say the same, though. If there's something that you truly enjoy food-wise, just keep it in moderation, because what inevitably ends up happening is you overindulge and then it makes you feel worse. So, and I'm guilty of it too. We went and had ice cream last night, and I loved it while I ate it, and then I paid for it later. So, but food can definitely be a mood lifter, but it can like everything else, be a double-edged sword.
I can't think of a specific food. I wouldn't lean on food. But I always think if it makes you smile, if it makes you laugh, if it gives you a good memory, if it gives you something to talk about, then you're probably in the right place.
That's amazing. Thank you so much, guys. I can see chocolate is the common theme here, so we should all go get some chocolate. I think for me, I love chocolate, but it triggers one of my health conditions, so I have white chocolate instead. I think it's the cocoa. So, yeah, chocolate is great. I just want to say a really big thanks to everyone who's joined here, and I want to ask, has anyone got any specific questions for our panelists here? Yeah.
So I just have a question for the veteran. I know you mentioned something about you can actually be with people or live with people and still be lonely. Because I think that's a point people don't get. And they think, oh, you're a man, you're married, or you're a woman, you have a husband, you have kids. How would you advise someone who's going through that? Because I think we do have a lot of people, especially with men. I work mostly with the veteran population, and I have a lot of cases like that. And men just don't speak up. I don't know what it is with the society and them feeling unable to say that they are lonely. It's easier for a man who's living alone or who's divorced to say I'm lonely, and he feels people will understand. But just as a married man with kids and all of that, they just have a problem with saying that they are lonely. So in a case like that, what would you advise that person?
Yeah, I'm a man, so I don't need a map. I don't need directions. I know how to get there, right? That's a great question. We all put up those walls, but men tend to put up a thicker emotional wall than women do. We tend to push our emotions deep when we're feeling anything is off with us. And depending on the veteran, or depending on the first responder, or whoever else may be feeling lonely in a room of people, it's really one of those things where if a person wants to stay shut down, it's very difficult to break through that wall. But approaching that person in a non-threatening way, in a, putting your happy face on, so to speak, and opening up a conversation, that may be the trigger to that person opening up. And sometimes, I don't know, don't raise your hands on this, but if you're a husband and a wife and you sit 3 feet away from each other and you don't talk, that can be difficult, because now it's hard to find a way in. It's that pregnant pause, and then who's going to speak first. But it's starting the conversation. And the other thing is, away from just that interaction between two people, remember, it's not just about people like us who have practices that help clients overcome some of their challenges. It truly does take a community. The military and the Veterans Administration have latched on to that concept and have brought in community members from ministry professionals to work with mental health professionals with their patients, to give a more holistic look at what the root cause is of why that person is shut down.
That's brilliant. Thank you so much, guys. I just want to say a big thank you to Health 2.0 for helping us, give us this opportunity to talk about such an important topic, and also to create, hopefully lifelong friends within our community. And if anyone's feeling lonely, please don't ever feel like you can't talk to someone. And I hope the audience and everyone on our panel, we can take something from this really important discussion. And just thanks so much, everyone, for your time, our panelists and audience. Thank you.
Excellent. Thank you, panelists. Next, we move from modern health challenges to time-tested healing wisdom. Let's explore the scientific validation of traditional medicine. For centuries, traditional healing practices have been at the heart of wellness in cultures around the world. From Chinese medicine to herbal remedies and energy healing, these ancient methods have stood the test of time. But how do they hold up against modern scientific scrutiny? To dive into this question, let's call our next panelist and moderator, Dr. Noreen Gallara, for our next panel of Advancing Scientific Understanding and Validation of Traditional Healing Practices. Give it up for them.
Good morning. Can everybody hear me? So my name's Noreen Galeria. Welcome. It is truly such an honor to be here with such a remarkable group of individuals who are committed to advancing the field of health and wellness. Today we're going to explore a topic that sits at the intersection of ancient wisdom and modern science. For centuries, herbal medicine has been a cornerstone of traditional healing practices, offering holistic approaches to wellness. As we continue to explore the scientific potential of herbal remedies, we recognize the importance of validating these age-old practices through research and evidence-based methodologies. I'm fortunate to be accompanied by a renowned panel of experts who will all share their invaluable insights into how we can bridge the gap between tradition and innovation. To start us off, we have Dr. Joyce Maleba, a medical doctor in the Philippines who specializes in aesthetic medicine, and she's now actually expanded to practice naturopathic medicine in North America. She's a certified medical laser aesthetics practitioner in Canada who operates Joy Skin Laser Clinic, and she's been operating that for 8 years. She's also the CEO of Joy Skin Products, a North American trademarked skincare brand. So Dr. Joyce, can you please share how your conventional medicine background and then now this new interest in naturopathic medicine really kind of aligned or came together to create Joy Skin Products?
Surely, Doctor. So I think my background in conventional medicine and now naturopathic medicine afforded me to take the best of both worlds. So the evidence-based approach of conventional medicine and the restorative power of naturopathic practices, they align in how we do and how we source Joy Skin products. So for example, we have retinol, which as we know is the gold standard for anti-aging. But because of what I learned from naturopathic medicine, we are launching bakuchiol, which is a plant-based derivative of retinol. This is for those with sensitive skin and also for those who cannot tolerate retinol because they have sensitive skin, as well as if they plan to get pregnant or if they're pregnant. So I believe that aligns with what we have because we can now broaden the product line that we have to combine both what we have right now and scientifically studied plant-based alternative.
Is this on? So, you know, as a dermatologist, I will say retinol is like the fountain of youth for us, right? So the fact that you've combined it with bakuchiol, I think, is amazing, especially because then you can offer it to additional people who can tolerate. Another thing we hear about a lot, just kind of in social media, it's viral, is L-glutathione. And I know that's something actually that you have also put into your Joy Skin products. Can you tell me a little bit about that?
Yeah, so Dr. Galares, you know, L-glutathione is dubbed as the master antioxidant. So it helps our body detoxify, fight oxidative stress, toxins. But over time, our body cannot keep up with the toxins that we subject ourselves on a daily basis. That's why we get our sources from outside, which is, in this case, fruits, vegetables, and also supplements. So and we studied biochemistry, we study about glutathione. And for Joy Skin products, the Joy Skin Pure L-Glutathione, we make sure that we source our products from organic sources with patented fermentation process to extract the highest, purest quality of glutathione. And so that combines both what we know of glutathione and how we source it. And if you don't know, Joy Skin is based in Canada, and Health Canada has very strict regulations when it comes to natural products, supplements. So having been approved by Health Canada to have the highest dosage of glutathione and also being approved of NPN speaks highly of what Joy Skin puts into our products.
Thank you.
So let me introduce to you our next speaker, Dr. Sarvajit Singh. Dr. Singh is biomedical scientist with a PhD in cancer biology and advanced scientific training in cardiology. He holds an MBA with specialization in project and healthcare management. After serving as a faculty member in the Division of Cardiology at UT Southwestern, Dr. Singh currently manages his life science consulting firm and is an associate professor and program director at the University of North Texas. So Dr. Singh, earlier we discussed about the evidence-based validation of products such as Bakusho and glutathione. What are your thoughts about natural products and herbal products in cancer or cardiology?
Thank you, Joyce, for that question and the introduction. So we just started talking about traditional medicine, and the two terms that were brought up were retinol and glutathione, right? So clearly these are the two of the most heavily studied compounds where we have robust evidence indicating that they have a variety of positive and beneficial health effects, not only in cancer and cardiovascular disease, but also a variety of other inflammatory disease, right? And then I think we have on our panel another expert today who's been working with curcumin. Again, a commonly used spice, component of a spice that comes from the root turmeric, an integral part of Indian and Eastern diet. So I myself worked with curcumin about 10, 15 years ago during my PhD. And that, again, is one of the most heavily studied compounds that has shown, again, over the last 20 or 30 years that the compound has been studied, that it does indeed have anti-cancer properties. Its ability to hijack cells and actually cause apoptosis or cell death in those specific cells. And just to kind of put it in perspective, so curcumin has been studied in colon cancer as well as in cardiovascular disease, head and neck cancer, oral cancer, even prostate cancer. Now, if you look at the incidence of colon cancer in India over the last 20, 30, 50 years, and then you look at the same incidence of colon cancer, colorectal cancer in the United States, you would be surprised that in India the incidence is at nearly 1/5 rate. So about 20% of incidence rates that we have here. And of course, part of it is genetic predisposition or genetic susceptibility, but also an important part is the diet, which again, as I said, is consisted heavily of curcumin and other spices. Quercetin is another compound that has been heavily studied. That again is a small compound of flavonoid, comes from plants, shown to have significant anti-cancer properties. So now the trick with curcumin and quercetin is what I've seen in my research and elsewhere. It's the dose that maketh the poison, right? People in pharmacology know that phrase very well. So with curcumin, what we know is that at low concentrations, utilized consistently over several years, it does indeed have a range of positive effects on cancer and cardiovascular health. Now, on the other hand, if you increase its consumption, and this is again coming from in vitro cell-based data, if you triple the regular concentration, the cells actually become more carcinogenic and they start dying in a way which is actually more harmful to the organism or the tissue. So again, it's the dosage. And in Eastern cultures, the diet has always been consisted of these spices at really small levels, but consumed over perhaps the entire lifespan of an individual. So there is, again, to sum it up, a lot of robust scientific evidence that has linked small compounds, natural compounds, both retinol, glutathione, curcumin, quercetin, resveratrol, that comes from red grapes is an integral part of the red wine, accounting for the French paradox, right? Again, so all of these effects are now studied to shed light on not only their beneficial effects at the cell level, but also at the level of microbiome, our gut microbiome. Yesterday we had a panel where a lot was said about the importance of microbiome in diseases that are as varied as cancer and Alzheimer's, right? But again, more and more data is now accumulating to indicate that it is not an isolated or a solitary system. Everything's connected, ranging from your diet to its effect on the microbiome and the eventual disease moiety.
Okay, so you said that a lot of studies have been done. Has modern science adopted, or modern medicine adopted this?
So there has been a lot more systematic focus on exploring and investigating the role of these natural compounds, especially in cancer, more in cancer than in cardiovascular disease. So I know, during my consulting work, a lot of hospital systems, especially in California and the University of Chicago, they have now started looking at curcumin as a beneficial dietary supplement to cancer patients, a range of cancer patients. So again, this is not yet an FDA-approved process, but now we have enough evidence to indicate that there are actual benefits. And that's why it's making the cut for the dietary supplement that your nutritionist prescribes to you. Now, if you were to simply take the term curcumin, put into PubMed, NIH medical literature database, the number of results is astounding. You get over 97,000 research publications just by this one key phrase. Even when you account for a mismatch, that still leaves a staggering number of research articles dedicated to studying the role of curcumin. So yes, the focus has been on, we have come some way, but again, we're not quite there yet where we have a systematic focus in terms of late stage clinical trials. A lot of clinical trials in both quercetin and curcumin are early phase clinical trials, stage 1 or stage 2A, but I think there is a slow and steady trend towards exploring benefits in a much more systematic manner. And I hope that we get there sooner than later. Yeah.
Thank you.
Thank you, Joyce. So before I introduce our next panelist, I want to circle back to yesterday morning's panel discussion so one of the things that was talked about in that discussion was the social determinants of health. And the term that stood out to me was food. So food, as we know, is medicine. That was said just a few moments ago. Food is medicine. And then food and culture are inextricably linked, right? So our next panelist takes this relationship between food and culture and applies it to specific population-specific communities in the United States. So Neha Shah is the founder of Diaspora Nutrition. And Diaspora Nutrition is a wellness platform that serves to help Indian immigrants in maintaining their cultural identity when it comes to food. So essentially what it does is it helps the Indian immigrants make healthy choices, nutritious choices, while still maintaining the integrity of their culture. Diaspora Nutrition, I earlier learned from Neha, bridges the gap by looking at the modern science, perhaps some of the studies that I have been a part of, what I've come through, looking at modern science, scientific evidence, and then seeing how does that translate into traditional food wisdom was the term that Neha brought up, and that really stuck with me. So Neha, wonderful. So could you, as we talked about, food is indeed, it can be a medicine, or if not washed carefully, it could be a poison, right? And then when we have such a strong diaspora of Indian community here, immigrants, they come here and then they have to navigate the United States food market, right? Whatever we have here. And again, coming from India myself, I know one of the first things that comes to the surface is vegetarian versus a non-vegetarian, right? And that becomes really challenging because protein being protein, such an integral part of a nutritious diet, so how do we manage that? So your firm, I think, has done tremendous work on that, your company. So how do you then help Indian communities, make these informed food choices, still maintaining the traditional food wisdom and aligning with their cultural values?
Thank you, Doctor, for introducing me. And once the immigrant Indian grandma was advised to include steamed broccoli into her daily diet, and she started suspiciously poking at it, and with a great dramatic nose crunch said, "Not in my kitchen." Not because she didn't want it to be healthy, but she didn't know where does this stuff comes from. What is the traditional background of this broccoli or Brussels sprouts? Now this is exactly what the food dilemma is for many immigrants in the US, where we are trying to adapt to the new environment without getting rid of our roots. So how do you do that? There is a great health disparity in the US for the immigrants, where exactly this is one of the main reasons where they feel isolated and lonely, just before we spoke about, right? So the way through which we can navigate the US food environment system without, in fact, trying to, build our cultural roots based on that, is by including the core concepts of ancestral food wisdom. Now, I would like to bring up the 3 food concepts. First is the quality of sourcing, the food sourcing. All of the ancient food wisdom talks about sourcing from the farmers, from the soil. The food should not be known by which brand, but from which soil it's coming from. So start connecting to the US local farmers, because even they are fighting every day against the ultra-processed food market. By this, there's a win-win situation. You source your traditional foods from US local farmers, and you also support the local economy, right? Second is the ingredient quality. There's a big red flag if you are using genetically modified soy or genetically modified corn. I know all the Mexican people would be very angry if their corn tortillas are made up of genetically modified corns, which has been proven to create a disruption in not only gut microbiome, but in your brain, in your thyroid, in your reproductive health system. So the ingredient quality, where it's not genetically modified seeds, where it's not sprayed with heavy glyphosate, all these things connect back to your roots. Just like the way your grandma, your mother used to go for the grocery shopping, they exactly knew by the weight of the wheat and by the color of the wheat that if it is stone grounded or not. So specify your ingredient quality inside the ultra-processed US food market and you are good to go. Third is your cooking methods. So many of our ancestral food wisdom relies on the cooking methods such as sprouting. Yes, the beans will cause you gasiness if you are not soaking it or sprouting it, right? Then fermenting it. We all love our idlis and dosas. I know what I'm talking about. And this is nothing but a fermented batter. How about fermenting it, soaking it, and sprouting it, and adding the nutrient bioavailability to our food? And all this have been already talked about and practiced by our women ancestry and being passed on from one generation to another, but somehow we miss it when we land in the US. We don't have to. All the scientific methods and all the scientific research papers are validating these processes already. We don't need any more validation. We just need to have more faith on these processes and start implementing it. So yeah, this is one way where we can navigate the US food system.
No, I couldn't agree more, especially with your comments on the heavy consumption of ultra-processed food, right? So again, yesterday we had that panel where one of the panelists brought out the significantly ill and severe side effects of ultra-processed food. So again, there's plenty of data there. And also, and I hadn't thought about it till you actually just said it, how you actually cook the food, right? Steaming versus roasting. That's got to do something different to the product to increase or decrease the bioavailability. And that's just one of the things we're talking about. You know, we recently talked about curcumin, and again, several thousand number of studies have shown how to alter the bioavailability, because it's only useful when it's biologically available in your system. So excellent point there. And then my next question to you is, how do you think we can shift the narrative to empower the immigrants, especially from India, to make these healthier food choices while still, trying to manage their chronically existing diseases, diabetes and hypertension, so all of that. So how do we shift that narrative to empower informed decision making?
That's really a good question, and I think this is where we all need to come together. And this is such a great platform that Health 2.0 is giving us, where the health providers as well as the nutritionists can come together and help us in changing this narrative, where the cultural competent health solution is needed. And this is the one way where we can decrease the gap. Evidence shows that when the cultural competent nutrition solution or health solution is integrated in our healthcare systems, there is a positive diabetes outcome and also the patient satisfaction. Later part of the day, we are also going to talk about how seniors specifically feel isolated and lonely once they are dismissed, saying that, hey, your rice and beans are not going good to you and you need to switch into the quinoa or with some side of Brussels sprouts. Man, this is not going to help them anymore. So you need to bridge out the cultural gap. You need to ask them questions. What are the foods you eat? How do you cook it? Okay, so can we do one thing? Can we add more diversity? Can we just add more fiber to it? How can we add more healthy fats or protein content into it? And by that way, your cultural resemblance will be intact with the most cutting-edge healthcare facilities. Thank you so much. Coming back to our next speaker in the panelist group, I would like to introduce to Dr. Shinjini Singh. She is PhD and has about 18 years of experience in the field of cancer biology. After being a basic scientist for about 8 years, she transitioned to cancer clinical trials, working as clinical research scientist. She has worked at the world's leading healthcare institutes like MD Anderson Center and Cleveland Clinic. Dr. Singh, I want you to enlighten us with what is the genome-based, multi-targeted approach to the treatment of cancer, but the gifts of Mother Nature and superfood spices like turmeric.
Hello all. Thank you so much for the wonderful introduction. I'm really honored to be part of this wonderful panel. And as Dr. Sarvajit Singh already said about the curcumin, so I would begin with my experience in clinical trials, as I'm right now working at Cleveland Clinic in Cancer Center. As a basic scientist, I have worked on turmeric and have seen the anti-cancer role in cell lines, and during that period, the lab in which I was working, I've seen a lot of patients coming to my professor with whom I was working. They were like stage 3 cancer patients, stage 4 cancer patients, brain tumor patients, and they would be like, my professor used to tell them the exact dosage for turmeric for their cancer treatment. Don't stop your cancer treatment. What your oncologist is giving, just try to have this. And because it's not in, as the panel has already talked about, turmeric is a part of Indian food. But here it's like a herbal product. And so they tried it, and I saw so many patients coming back and saying that they were, like, their tumor was shrinking, their scans were getting better, and even their oncologist or surgeon, they were saying, like, I'm happy, whatever you're doing it, just keep doing it. And the best thing was that, which I would like to enlighten everyone, that not only it has anti-cancer role, it has chemoprotective role too. So chemo, radiations, and I not only the patients at MD Anderson, but with my family and friends, I have recommended a lot of them, and they are literally, like, I see their reports coming back. They have much better cholesterol, like it increases a lot as soon as your chemotherapy starts, your blood work starts getting really bad, and all the side effects. So with the pain and everything, they feel much better, their blood reports are much better, and it has helped them a lot. And that's the basic science and clinical trials combined. And as going with the flow and with the panel, I would like to say that this is not a new information or knowledge. It has been, like, from the history of humans, because even being an Indian, I would like to say that in our epic Ramayana, it was described as a word called Arbuda, that is a Sanskrit word. So it was described even in Ramayana, and which was said to be like 5,000, more than 5,000 years ago. And treatment that was being done at that time was with arsenic pastes. So it has been there, treatment has been there, and so the multi-targeted approach for turmeric would be, cancer doesn't happen by the dysregulation of just one gene. There are multiple genes involved, right? We call them driver genes, passenger genes, and there is one that starts causing it, and a lot of other genes, they start getting dysregulated. So turmeric is like, it has the multi-targeted effect on the cancer cells, and I guess that's why it helps with the chemoprotective role, radioprotective role, and it's really great. And a lot of, and also I would agree with Dr. Singh that there are a lot of clinical trials that have been done, not only in India, all over the world, and even in US. If you search publications, there are like a lot of publications right now. And along with cancer, I would also like to share one experience. I got an opportunity to work at Digestive Disease Surgery Institute at Cleveland Clinic, and I was working on a clinical trial, which was a medical device. So I used to go and see patients and note down all the medical history and everything. And so in their chart, I used to see a lot of patients, they themselves asked the physicians to recommend curcumin, which is a component of turmeric, and they used to be IBD patients, ulcerative colitis patients. So, and that was really helping them a lot. So the awareness is there, and in the US, if you go to pharmacies like CVS or Walgreens, you can see curcumin added with Tylenol, or I've seen that, and you get it in Costco. So it is like, people know that, but I would just, as being a basic scientist and a clinical scientist, I would like to bring the awareness that please, you can add it in your diet. Have golden milk, which is like turmeric with a little bit of black pepper, and at night, and you'll sleep very well, you'll have very good digestion, and you'll feel much better in the morning. And why I said black pepper is because turmeric, there is a term called bioavailability, like the amount of drug that goes inside your cell. Once you add black pepper into in the milk, so the turmeric needs fat and black pepper to increase the bioavailability, which increases 1,000% more. So, and for cancer patients, that's really awesome. So thank you so much. And I would like to introduce our next panelist, Dr. Kyra Montagu. Kyra is a naturopathic doctor who lives and practices Ayurveda in the Dominican Republic. Kyra founded and built Kyra, an Ayurvedic and holistic hotel, retreat, and wellness center in front of the Caribbean Sea, and has been offering retreats, motivational workshops, therapies, and classes for over 15 years. I'm so happy to have you here. So the question I would like to ask you is, given the plants that have been discussed during this conversation, used in Ayurvedic medicine for 5,000 years, do you think Ayurveda can play a role in more modern medicine-based approach to modern science, and how can it be implemented?
Wow. Good morning. Thank you so much. It's such an honor to be here having this conversation, this amazing conversation. Thank you, and thank you, Health 2.0, for this opportunity. Great question. Firstly, every concept that we've talked about today already comes from Ayurveda. If you don't know what Ayurveda is, it's the traditional Indian medicine. It's over 5,000 years old. And turmeric, L-glutathione, bakuchiol, diet, food, culture is all a part of the Ayurvedic philosophy, which is ultimately a philosophy that sees the interconnectedness of everything as kind of its core, along with every other aspect of life and lifestyle. Does it have a place in today's world? I think most definitely. I think the theme of this entire conference has had an underlying kind of idea that mental health, mindfulness, meditation, connection with each other. Somebody even said yesterday how important it is, the connection with your family, with your friends, with your community. All of this is a part of the ancient traditional healing methods. And it's very important, especially seeing as technology is becoming more and more prevalent, which is excellent and being used more and more, but with that is coming potentially a sense of more separation, a sense of more loneliness, as was talked about before. And I think that the Ayurvedic philosophy, which is based on reconnection with nature, not just the nature that's around us, but the nature that we are, and therefore plants and eating well, being outside, breathing fresh air, and it goes on and on and on. If we don't start to reconnect with nature a little bit more than perhaps we do, it's going to be to the detriment of our health, because we are a part of nature. And just the simple, I would say, there's a general idea, which is that humanity is kind of outside of nature, is really where a lot of our imbalances have come from in the first place. So again, coming back to where Ayurveda's basis is, we need to reconnect with the natural cycles of nature. We need to come back to ourselves as part of this planet. And in that is included all the plants, how we eat, how we relate, what times of the day we wake up and go to bed. And we could speak for 5 weeks about the philosophy of Ayurveda. But I think that the future of medicine, at least from my perspective, has always been bringing the ancient, the traditional healing methods together with the modern science, which is excellent for acute, emergency, things that we need right now, and for healing diseases. When we bring the two together, we will actually have a medicine that is what we need today. And I very much hope that it will be the future of medicine. I think that's where we're going. At least this conference is heading towards that. And I don't think I need to say a lot more. You guys have said most of it, or a lot of it. And I would like to introduce Dr. Galeria, Dr. Noreen Galeria. She's a board-certified dermatologist with a laser and cosmetic fellowship and has been in practice for more than 20 years. She's also the CEO and founder of Inner Glow Vitamins, which I happen to try one, and they're very delicious, so I suggest you try them all. It's a dermatologist and plastic surgeon-developed brand of skin nutraceuticals. So, my friend, Dr. Galeria, I'd love to hear how the average person can improve and maintain skin health without spending a fortune.
Okay, so, given that this is an herbal talk, most of my, most of my experience is in skin cancer research. So we run 3 skin cancer clinics across Washington, D.C. And, you know, I think that it's really important to lean into this concept, right, of food as medicine. And one of the things that we've done is, you know, I was looking at patients and they were coming in cancer after cancer after cancer, and there's very little that you can do sometimes after the fact because you've already gotten a lot of your sun exposure by the time you're coming in to see me. And so a lot of what Inner Glow is based on is the concept of nourishing your skin from within. And, you know, the gummy that you tried this morning is a polypodium gummy. So polypodium is a fern that has been used for thousands of years by tribes in South America. They, you know, it grows near the equator, which is a great place for it to be because people would harness the fern, boil it, and drink it as a tea for internal sunscreen. And so what we did was we began researching this fern to figure out how to really use this fern as sunscreen. And if you look through the literature, you'll see that there's like, you know, dozens and dozens of studies on polypodium. And what our company has done is it is the first company to ever put this fern into an easy to take, actually I think delicious, sugar-free, vegan form, thank you. And now we have clinical trials proving that it works like sunscreen. So as a dermatologist, I will never say use it instead of sunscreen, but you know, I love it as an adjunct. We market it as sunscreen's best friend. And you know, we've basically taken this herbal ancient medicine and used it to help people with skin cancer. Another one of our products, if I can just kind of touch on what the group said, is a product that we call Age Defense. What we've done is we've taken the most highly researched herbals, so things we talked about, turmeric with a little bit of black pepper because it's important for bioavailability, blueberries, green tea, which is shown to be anti-cancer, resveratrol. We've taken 14 different ingredients that we know are really important for skin health. We've combined them into a supplement that you can take every day. If you've got a great diet, great. You don't need the supplement, but you know, it's hard to get things like these ferns and some of these barks that we have in there. And I will say, you know, very much to your point, none of it is mega-dosed because, you know, we really feel like when you are taking something on a daily basis, day in and day out, your body just needs a touch of it to really get the benefit that it needs. And so, you know, based on, you know, we've probably treated maybe 500,000 people with skin cancer in my clinics, and based on the work that we've done and the work that other dermatologists are doing, we're really starting to see the benefit of just this low dose, you know, supplementation along with all of the stuff that you said, you know, healthy diet, healthy living, proper sleep.
Amazing. Thank you, Dr. Galeria. Well, before we finish, just wanted to ask if anybody has any questions. Otherwise, I would like to say thank you very much to all my esteemed panelists, colleagues. I think this was an amazing conversation, and really think that the underlying theme of this whole thing is how do we bring, how do we come together? How do we come together in all the different branches of medicine? How do we use, well, we already use plants, but how do we bring plants into the mainstream so that, like has been said before, let our food be our medicine be our food through nature. Thank you so much. Enjoy the rest of the conference.
Thank you.
Okay.
We're not doing the sponsor certificate. So right here, just none of this.
Okay.
None of that.
But,
And then,
but don't call.
no. And then Ronnie is not here, so they're trying to find another presenter.
Okay.
Just let them know our award will start shortly.
We'll be starting shortly for awards. So I can start? All right, now let's take a moment to honor those who are making groundbreaking contributions to healthcare. But before we do that, let's pause to express our gratitude to our wonderful bronze sponsor for their incredible support. I would like to invite Dr. Ronnie Costello, Strategic Advisor at Regine Global, to the stage to help present certificates today. Please help me give him a warm round of applause. Welcome, Ronnie. And award winners, if you'd like to say a few words, feel free to do so. All right, our first award is for Dr. Abhat Singh, Health 2.0 Conference Excellence in Healthcare Award. Dr. Singh, MD, MHA in Healthcare, is a pro bono chief medical advisor of We Heal Foundation. Dr. Singh has extensive experience as practicing drug discovery and clinical oncology physician. In his free time, Dr. Singh likes to ski, paint, play tennis, and write poetry.
Thank you so much to 2.0 Conferences for awarding me this prestigious honor amongst all of you esteemed folks. My association with 2.0 goes back a long way. I received the first of these kind of awards in 2019, then again in 2021, and now again. And it's an honor to be affiliated and associated with this fantastic forum. There are many folks who work tirelessly behind the scenes to make a conference of this scale possible. A few notable names: Imran, Jatin Sidhu, Faisal, Raghib, and many, many others who really worked really hard to bring a lot of us together. So I really wish to acknowledge them. And I hope you all are having fun, some great panels, and I look forward to chatting with many of you. Thank you.
Our next award is for Dr. Alicia Jones for Health 2.0 Conference Excellence in Healthcare Award. Dr. Jones is the Chief Medical Information Officer at Vitus Consulting Group. With over 25 years of experience, Dr. Jones has excelled in bridging the gap between clinical expertise and healthcare solutions. She holds a Doctor of Osteopathia and Fellowship in Geriatrics, focusing on health policy.
I'm humbled. Thank you so much. It's a pleasure to speak with all of you, and I look forward to talking with you all on a panel coming up. Thank you so much.
Our next award is for Dr. Andrea Sasha Ortiz for Health 2.0 Conference Excellence in Healthcare Award. As the Chief Mental Health Officer of Texas Integrative Healthcare, Dr. Ortiz brings extensive expertise as an international award-winning consultant, coach, and clinical psychologist. Her specializations include PTSD, depression, and anxiety treatments. She holds a PhD in clinical psychology from University of North Texas. Congratulations. Our next award is for Dr. Barry Latchman, Health 2.0 Conference Excellence in Healthcare Award. Dr. Latchman is the president and CEO of the Latchman Community Development and Consulting, is a national recognized leader in healthcare with over 50 years of experience providing care, program development, and advocacy for underserved populations. He has made a lasting impact. Notably, Dr. Latchman originated the concept for the National Health Service Corps. Congratulations. Our next award is for Brett Warner for Health 2.0 Conference Excellence in Healthcare Award. CEO of Fresh Starts Behavioral Therapy, Brett began his entrepreneurial journey selling slushies at summer camp in the first grade. A speaker on training, culture, and advocacy, he is dedicated to leadership in healthcare, education, and advancing ASD laws. He holds a business degree from the University of Miami. Congratulations.
Awesome, I appreciate this award. I think that our company is looking at different ways to treat children on the spectrum. And with Down syndrome and all the other related disabilities, I call them special needs. I don't think anybody has a disability, really. So I hope that we're able to expand nationally, internationally. We have some cool new techniques that we're using that are all evidence-based, so they still fall within the realm of what we're allowed to do. And we're going to start doing that right when I get back to Miami, which is very early in the morning tomorrow. So I'm excited. Thank you for allowing me to have this award. I've been here in 2019 as well. I'll be speaking at the Inclusion and Advocacy for Neurodiverse Students in the Classroom. It's very important to me at the Education Conference at 1:55. If you're interested in that, I'll be moderating. Okay? Thank you. Appreciate it.
Sure. Our next award is for Chitra Nana Zabasan for Health 2.0 Conference Excellence in Healthcare Award. Principal Consultant of CS Care Solutions, Chitra is a clinician, educator, and senior level administrator. With 25 years of experience in healthcare, academic health sciences, and social services sectors, she has contributed her expertise in various leadership roles. As a consultant, she has implemented operational and strategic initiatives.
I'd like to say a few words. I forget that I need glasses these days. So from scrubs to the stage, I want to first thank God for my existence, preservation, and resilience. I provided care and service to children and youth with developmental disabilities and adults with intellectual challenges. This was all possible because of my family and their support. I dedicate this award to my son Jeremy for being the water that sustains me, to my daughter Jasmine for being the wind beneath my wings, for my mom for being the rock that strengthened me, for my dad for being the light that guided me, and for my brother for the fire that propelled me. As a woman of color, I'm a lady that wears her color well through trials and tribulations. The higher you rise, the more humble you should become, is what my parents taught me. Keep rising, tell the highest level of truth, and lift someone else towards freedom of knowledge and thought. So just listen, learn, live, and love. Thank you so much to Health 2.0 for this prestigious award and for me to share these words with you today.
Our next award winner is Chris Vittorio for Health 2.0 Conference Visionaries Award. As an owner and founder of the Holistic Embraced Healing, Inc., Chris aims to help clients achieve optimal health. Beyond this, he is a licensed massage therapist in New York State. Opposed to a one-size-fits-all solutions, he focuses on integrating structural alignment, tailored nutrition, and technology to enhance well-being.
Thank you very much. So I'm trying to change how healthcare is formulated in regards to preventative care, and hopefully with the help of this crowd and other individuals, we can change how healthcare is approached through insurance, government, but most of all, how personal treatment is done for that individual and the choices that they can make by putting the power back in their hands. So I just want to say thank you to Health 2.0 and everyone that's here for the greater good.
Our next award winner is Dr. Edward Anselm for Health 2.0 Conference Visionaries Award. As a consultant at public health advocate, Dr. Anselm has served in diverse clinical and leadership roles, including CMO of HIP Health Plan and Fidelis Care. Beyond this, he is a clinical assistant professor of medicine at the Icahn School of Medicine. His areas of expertise are smoking cessation and tobacco control.
Thank you very much, and I really appreciate the many themes and ideas that have been socialized here at this conference. I'm excited to have discussed with several of you and look forward to talking to others here in the audience about many of the great ideas that we can share that empower patients, that provide additional choices to individuals and their practitioners to advance their health care. Thank you all for participating.
Our next award winner is Elizabeth Conley for Health 2.0 Conference Excellence in Healthcare Award. Elizabeth is the founder and president of the Thin Line Peer Support Team, Inc. A first responder for the past 17 years, Liz has worked as a paramedic and a firefighter across the state of Connecticut. She enjoys spending time at her home with her husband, 2 dogs, and Flemish giant rabbit.
I would like to thank the Health 2.0 conference for having me back as a second-time award recipient, and also for providing me on a national platform for bringing awareness to the mental health plight of both our first responders and our military personnel. One life lost of anybody is one life lost too many, but especially for our first responders and our military personnel who have written a blank check for our country and for their state, in serving their country and in serving their states, and expect nothing back in their return. It is so important for us to be able to give back to them and to serve their populations. And their mental health has been ignored for far too long. And I want to thank Health 2.0 and the Health 2.0 conference for giving me a national platform to bring the mental health plight in front of so many people, and to thank my parents for their unwavering support, my husband for being here, and my amazing team back home of all volunteers who are all first responders and veterans themselves for helping me get my team off the ground and for being there to help support our first responders and our veterans in their mental health plight. No one fights alone. Thank you.
Our next award is for Energy Lounger LLC, Health 2.0 Conference Outstanding Organization Award. Energy Lounger LLC pioneers innovative wellness solutions, specializing in advanced light therapy technology. The company is renowned for its flagship product, the Energy Lounger, a cutting-edge device utilizing red light and near-infrared therapy to promote holistic well-being. On behalf of this organization, we have Barry Warrington, the CEO, to receive the award.
Thank you, everyone. I bring the glow to the show. So if you haven't had red light therapy before, we're just at the back here. It's a 20-minute experience lowering inflammation at a cellular level. More than happy to let you experience what an ergonomic red light therapy delivery device is, and hopefully help you bring more healing and health to your clients, customers, patients, etc. Thank you, 2.0, for the award. Much appreciated.
The next award is for Dr. Goni Weiss for Health 2.0 Conference Excellence in Healthcare Award. CEO and founder Dr. Weiss Wellness PLLC. Dr. Weiss has 20-plus years of experience in the industry. She is a board-certified psychiatrist and diplomat of the American Board of Psychiatric and Neurology. Beyond this, Dr. Weiss is a former associate professor, unit chief attending, and psychiatric clerkship director. Congratulations. Our next award is for Greg Bauer, Health 2.0 Conference Excellence in Healthcare Award. Greg, the managing partner at Health Connections, has commercialized digital health innovations for the last 15 years. Before founding Health Connections, he was the senior director of alliances and partnerships at the HIT Lab in New York City. He has earned an MS in healthcare delivery leadership and a BA in economics.
Thank you very much. It's really an honor to be invited here and to accept this award. With Health 2.0 conferences really bring so much great value. The crowd here is very inspiring, the information we're sharing. And it was yesterday, I was on this panel with the team from the diabetics prevention group, and I was just, number one, I learned a ton from them, and two, it's just inspiring to see all the work they're doing. So thank you again for this honor.
The next award is Dr. Lashim Kutaparatha for Health 2.0 Conference Excellence in Healthcare Award. Dr. Kutaparatha is an accomplished interdisciplinary scientist with over 15 years in experience in computational biology. She began her career as a computational physicist. In her most recent role, she spearheaded computational efforts and develop and implement a strategy for preclinical target discovery at the Lexicon Pharmaceuticals.
Hello, everyone. What a breath of fresh air this conference has been. This is my first time here, and I did not know what to expect. But what really inspired me in the last 2 days is how beautifully and creatively the organizers have incorporated the human element into all the sessions, whether it's medicine, science, technology, business. So I think this conference has been really, I would say, like wake-up call, or, you know, something that makes someone like me from a background of science, who's a scientist and who's been working on fundamental problems, to start thinking about how we can bring in the shift, even from the fundamental level, right? The holistic thinking about interconnectedness of our system, our body, and how it can sort of, you know, how it can actually change how the body works, and how we can start this thinking process from the beginning itself. So this has been an incredible honor, and thank you so much for the recognition, and this one is truly special. Thank you.
Our next award is for Dr. Lillian Alvato for Health 2.0 Conference Excellence in Healthcare Award. Dr. Alvato, the Chief Medical Officer at White Wilson Medical Center, brings 40-plus years of healthcare expertise spanning internal medicine, cardiology, and geriatrics. Beyond this, she specializes in compliance, quality, and utilization management. She also holds the key leadership role in quality and compliance for MSOs and hospital medicine groups.
Thank you so much for the award. It's an honor to be here today and meeting such special crew here. You know, it's been a very enlightening experience, as all those years in the care delivery, to have the opportunity to still mingle and dream about improving healthcare delivery at the patient care. So thank you so much, and looking forward to my panel this afternoon with wonderful colleagues. Thank you.
Our next award is for Linda Crockett for Health 2.0 Conference Excellence in Healthcare Award. Linda is the CEO of the Canadian Institute of Workplace Bullying Resources. Beyond this, she is a certified consultant, trainer, coach, and therapist, drawing on 37 years of professional experience, including 14 years of specialized expertise in trauma-informed care. She is dedicated to addressing systemic gaps that lead to institutional behavioral betrayal.
Thank you, and thank you, Health 2.0, for this platform. I've learned, I've met a lot of wonderful people, but the opportunity to encourage leaders to prioritize, be interested and prioritize the need for trauma-informed training on the prevention, intervention, repair, and recovery for workplace psychological hazards. I hope that that influence has happened here this week. Thank you.
Our next award is for Lisa Driggers-Millam for Health 2.0 Conference Excellence in Healthcare Award. Lisa is the founder of American Women's Empowerment and a national speaker at the forefront of what women need to be heard. She lives in Georgia with her husband. Lisa has 4 grown children in which she helps them to pursue their dreams. She loves to read, write, and paint.
Hi, I want to thank everybody for this award. American Women's Empowerment is about helping the healing of these women that have been bullied or emotionally abused earlier in their lives. So I'm honored that I get to head up such a wonderful group, and thank you so much.
The next award is for Reverend Dr. Lisa Nesneski for Health 2.0 Conference Excellence in Healthcare Award. Reverend Dr. Nesneski, BS Pharm B, BCPS, is the CEO of the Health Mindful South. She is the leading authority in integrative medicine, integrating traditional medicine, meditation, and an alternative holistic health and healing approach. Additionally, Rev. Dr. Nesnensky is a certified mindfulness meditation teacher and a board-certified pharmacotherapist, and much more.
Thank you. Thank you all so much. First, I'd like to thank the Academy, Health 2.0. I'd like to thank my current husband for his support, and he's here as the Chief Logistics Officer. That means he carries all my stuff. And I'd like to thank my children. Ed, my oldest son, who is a master's in nursing and an MBA. He works for Cigna as a health, he works as a case manager. My son, George, who is a physician at Banner Health in Tucson. So they followed in my footsteps, and I'm very proud of that. And so I'd like to dedicate this award to my grandchildren. I have 2 granddaughters, Ruth and Trixie, who I foresee being in the STEM world at some point. My grandson, Lucas. So thank you all so much. It is such an honor to be in the presence of so many amazing healthcare practitioners. Thank you so much.
The next award is for Madonna DeBlowy for Health 2.0 Conference Excellence in Healthcare Award. Madonna, founder of Life Thrive Solutions LLC, is a leading advocate for mental health and comprehensive care. As a licensed psychotherapist and a registered nurse, she is dedicated to enhancing her clients' overall wellness. Additionally, Madonna serves as a qualified supervisor, mentoring emerging clinicians and extending her impact.
Thank you so much. It's really an honor to be here. It's been a wonderful experience, and I had just decided to leave my corporate job and open private practice when I received the call from Health 2.0 and the invitation. And you know, the theme has been about connections, making connections, those important connections, and also, you know, how we maintain those connections in so many advancements, you know, online, virtual. And those are great, but they will never take the place of those personal connections. And the more we can strengthen those, the more we can bind them together, the stronger we all become. And I remember that for all of my clients that I work with and I try to help. You know, they need those connections, and we've got to find ways to improve those connections and strengthen them despite the obstacles. And for years I've worked in healthcare as a nurse, as a therapist, and I always seemed to have to segregate my roles. But my desire was to always bridge those gaps. We know there are so many gaps between mental, you know, physiological health and our mental and emotional health. We've got to bridge those gaps because therein lies real healing. And so the more we can bind together, find ways to bridge those gaps, I think that we will really propel health for everyone that we're seeking to give help to. Thank you so much for this. I cherish this award. Thank you for the whole experience. It's been wonderful.
Our next award is for Dr. Maria Rodriguez for Health 2.0 Conference Excellence in Healthcare Award. Dr. Rodriguez is the CEO of Care Counseling Center, a best-selling author, a renowned licensed professional counselor, and a mental health expert. With a master's in clinical psychology and a PhD in general psychology, she has spent over 2 decades empowering individuals, families, and immigrants facing emotional challenges.
I just want to say thank you so much, Health 2.0, for this award, and thank you for having this platform that we can learn from each other and contribute.
Our next award is for Mainak Kumar for Health 2.0 Conference Excellence in Healthcare Award. Mainak is the Director of Data Science at United Health Group with 15 years of experience in data and analytics practice across the healthcare and life science industry. His current role is he leads a global team of data scientists, engineers, and analysts.
And this is Mayank. I know a lot of people don't get the name kind of pronunciation right the first time. I want to thank Health 2.0 for this honor. I have heard a lot of our colleagues talk about AI. I have been in the healthcare space for 12, 13 years now. And I'm kind of really excited on what it has to unfold, how it is going to transform, and leading it from the center. Thank you again.
Our next award is for Nishtha Jain for Health 2.0 Conference Excellence in Healthcare Award. Nishtha is the head of innovation and digital technology at Takata, has 14 years of global IT experience driving digital transformations and innovation strategies. She is experienced across healthcare, biotechnology, pharmaceuticals, and vaccines with expertise in R&D and commercial sectors. Additionally, Nishtha serves as the president of Healthcare Business Women's Association Mid-Atlantic Chapter.
Thank you very much, Healthcare 2.0 Conference, for this honor and this opportunity. As an immigrant and women of color, I do not take this lightly, so I definitely see this as one of the biggest milestones. And here at this conference, all I see is innovators and healthcare visionaries. And I do want to say it's been an enriching and enlightening experience. But then, innovation is not only about technology, but it's also about, the ability to challenge what's not there. So I do believe that we have innovations that are yet to come that are going to change the future. And, we haven't seen the best yet. And just want to thank not only, again, a person's journey to this is not only theirs, it belongs to a lot of other people. So I do want to thank my family for in making me curious and making me fall in love with science and technology and starting to think about not only science, but how to use technology to solve the best science problems. All my mentors and coaches, throughout my journey, and then Takeda Pharmaceuticals, which is, such an amazing company to work for. So I am incredibly grateful today, and this is a true honor. Thank you, everyone here.
The next award is for Dr. Noreen Galleria for Health 2.0 Conference Excellence in Healthcare Award. Dr. Galleria is CEO and founder of Inner Glow, a brand of nutraceuticals backed by research and clinical trials. She is also a board-certified dermatologist with lasers and cosmetic surgery fellowship. She graduated summa cum laude as a #1 medical student from Jefferson Medical College. Our next award is for Dr. Paul W. Dyer for Health 2.0 Conference Excellence in Healthcare Award. Dr. Dyer is the CEO of Whole Life Health, who has devoted 40 years to learning and studying human development. Dr. Dyer holds 4 PhDs, 5 master's degrees, and several certifications. Dr. Dyer has served in Special Operations Armed Forces for 15 years.
I'd like to thank everyone for coming to Health 2.0. What I believe is innovation and serving our country, seeing the best of what we could be and the worst of what we can be. I took study, I'm a theoretical physicist along with neurology. I'm a neuroscientist. So I see where health can be weaponized. And as we together pull together, we can humanize the information that we are giving out to people. This way, it doesn't have to be so fearful. I see where health and mood disorders and the balance of emotions can integrate with AI. I've been doing this research for the last 5 years of how AI is going to integrate with mood disorders, and we can help navigate that a little bit better, because we are losing the battle with mood disorders. Right, we have 60 million people that are afflicted with taking medication. We're not even talking about the other people who are self-medicating. And as a veteran and as a person that is serving, and all the other first responders, like other esteemed guests have said, is that we need safe places for us to unload, right? And that is difficult when we don't feel like there's a safe place. So there's suicide prevention. There's suicides that happen often to veterans and friends of mine who have taken their lives because they felt like there was no way out. So that's how I got into neuroscience and the study of the brain and the chemistry, is because I wanted to stop my friends from committing suicide. That's how weaponized health can be. But if we humanize health, by giving the information when people aren't as fearful and they're not as scared and they can have a safe place to land, we don't have to worry about how health is used for financial gains. We can only take care of each other. So I do want to thank everyone for being here at the Health Point 2.0 conference, and everyone stand up and please give yourselves a hand on my behalf and my veterans, because you're here to help people. So please stand up and give yourselves a hand.
Excellent. All right, our next award winner is Robert Hedquist for Health 2.0 Conference Excellence in Healthcare Award. Robert is the founder and CEO of Ronin Awaken Coaching and Hedquist X Center of Excellence, where he excels at shaping and leading high-performing individuals and teams. His leadership is built on a foundation of fostering key qualities. Specifically, his approach is deeply rooted in resilience, authenticity, empathy, and collaboration.
I just want to thank Health 2.0 for this prestigious award and the opportunity, most importantly, to be part of the dialogue and the solution going forward. So thank you all.
Our next award is for Dr. Sarvjit Singh for Health 2.0 Conference Excellence in Healthcare Award. Dr. Singh is the Associate Professor and Program Director at the University of North Texas at Frisco. He holds a PhD in cancer biology and an MBA specializing in product management, entrepreneurship, and mental health care management from the University of Texas at Dallas.
Thank you. I just want to thank the organizers for giving this opportunity and setting up this wonderful, wonderful conference. Thank you.
The next award is for Srivana Singh Araju for Health 2.0 Conference Excellence in Healthcare Award. Srivana is the founder in charge of CEO of Qbit Wellness Pharmacy. She has over 20 years of experience in hospital and retail pharmacy. Srivana champions preventative care at the molecular level, ensuring no patient leaves without medication. Her diverse background spans hospital, outpatient, retail, and compounding pharmacy. The next award is for Dr. Thelma C. Ono for Health 2.0 Excellence in Healthcare Award. CEO and Medical Director of Cybus Medical Group, Dr. Ono is driven by a commitment to enhance primary care and manage chronic illnesses for over 8 years. Dr. Ono holds an executive certificate in public leadership and strategic fundraising from Harvard.
I want to say thank you to everybody in here, and thank you to Health 2.0 for actually recognizing us and what we do. One thing she didn't mention was that at Zips Medical, all we do is just take care of our veterans for all their disability exams. For some of us that obviously wouldn't have made it past boot camp, this is the closest we can get to through to military. I want to say thank you to everyone in here, and I'm so happy for everyone I've met here. For the award, I'm dedicating this award, to my wonderful husband, my kids. I have a lot. So thank you, everyone, and I have a very supportive family. Yes, when I say a lot, it's a lot. So I do have 5 kids, one set of wonderful twins that are keeping all of us busy. So I say thank you very much, and everyone, and thank you to all the veterans in here. Like we always say, we're so proud to serve the people who served us. Thank you.
The next award is for Tony Curtis, Health 2.0 Excellence in Healthcare Award. Tony Curtis, CD Donna, CCE, CVD, TLV, CHW, SPB, CPE, is the founder and director of Birthwise Doula Services, LLC. She serves as the director of advocacy for Donna International. She holds a BS and a BA from Sullivan University and certifications in various maternal health fields.
I'd like to thank Health 2.0, my family, my friends, my colleagues that came here with me. Any preventable loss of life due to perinatal health is one too many. And for my team that believed that we could change things, I thank them.
Our next award is for Vital Wealth Pharmacies for Health 2.0 Conference Outstanding Organization Award. Vital Wealth Pharmacies is a group of pharmacies that provide comprehensive pharmaceutical services and products. They are known for their wide range of medications, health and care products, expert advice, and the production of special medicines. On behalf of this organization, we have Stephen Wall, the pharmacist, to receive the award. All right, that wraps up our awards. A huge congratulations to all our honorees. Your work inspires change and drives progress in the healthcare industry. And now let's take a well-deserved break, enjoy lunch, meet fellow attendees, and continue our conversations. Don't forget to check out the 2.0 Conference's exhibit booth to see what we have planned for 2025 and 2026 in Dubai, Singapore, and the U.S. Speak with Jatine and grab your opportunity to be part of this future. Don't forget to explore the exhibit hall as well. And before we break, I'd like to have a big thank you for our silver sponsors, Cinefuge Inc., and our bronze sponsors, VitaWelt Apothecary, Regine Global, and Dr. Weiss Wellness PLLC. We'll see you back at 1:30. Enjoy your lunch. All right, I hope you guys enjoyed your lunch and made some excellent connections. With that being said, let's pivot to our next session. Ancient Indian medical traditions like Ayurveda and Siddha medicine have been practiced for thousands of years, emphasizing holistic well-being and disease prevention. But how do these methods hold up in modern healthcare systems? Our keynote speaker, Dr. Jamaya Crescentia, is the head of medical coding and audit at Cure Medical Centers, and she will explore how ancient healing techniques align with contemporary medical research, highlighting scientifically proven applications of herbal medicine, mind-body therapies, and dietary interventions that are gaining recognition in the global medical community. Please give it up for Dr. Jeremiah Crescentia. Welcome.
Good afternoon to all. I hope everyone have a good lunch. Okay, so we hope we all are happy and we all are healthy. So here I'm Dr. Jamima, already she introduced myself, but anyway, small introduction about me. Audio. Okay, so anyways, so the video played over here, first it says food is medicine and medicine is food. So it is together with my picture, so even if you forgot me, no worries, please don't forget this one, food is medicine, medicine is food, always. So just quickly we will go through let me understand something like, how many of you know like the traditional medicine that is called Siddha medicine? Nobody, right? Yeah, no. Ayurvedic? So many of them you know. Good, thank you. So now we are going to quickly understand the ancient Indian traditional healing practices through proven medical solutions. So my agenda will be like this, like a quick introduction regarding all the traditional Indian medicines, which consist of Ayurveda, Unani, naturopathy, and homeopathy. And we will just discuss on some of the origin, how it originated and the basic concept of it. And basically today I will be discussing only on Siddha medicine because most of my colleagues over here, they have already discussed Ayurvedic medicines. And also the prominent scopes of Siddha medicine and the principles of our medicine and the uniqueness in Siddha medicine and various medicinal herbs and the importance in the treatment options and very importantly, the proven healing practices with many case studies. So that is clinically, trials are being done and we have more clinical studies over there which will be presented in this session also. And also how we can see the traditional practices which now had been already integrated with modern healthcare techniques. We can discuss something on that. And finally, if you want to opt for this kind of treatment or any medicines, you're always free to reach. So I have given you the list of university medical colleges and hospitals in India for your reference. So let's quickly go into it. So you already know that India is a diverse land which have a lot of traditional medicines originated from India. So these are the medicines you can see, Siddha, Ayurveda, naturopathy and yoga, and Unani and homeopathy. So I don't want to discuss in detail on that. So my topic will be Siddha medicine. So we have a ministry from India which is called Ayush, which standardizes and which regularizes the medicines which is prepared. And the clinical trials are done by this Ayush Ministry of Health, okay? So this is the one. And if you quickly see, the origin of Siddha is basically very long back, as my colleagues over here during the last panel discussion. It originated basically more than 2,000 years ago, about many years ago when there were no scientific interventions were there. Our ancestors, basically we call them as Siddhas or saints, whatever. They lived for long years. They invented this medicine through their practices and proven solutions. So as per Siddha medicine, we have 4,448 types of disease, and we have medicinal treatment, but this external and internal also. So I will quickly go through it. So the basic concept of Siddha is the 5 components. So you already know, like whole universe is also made of 5 components. That is earth, water, fire, air, and sky. So same, our body is also made of 5 components. So both correlate with each other. If something goes wrong in the 5 component, automatically our body will also be affected. So that is the main thing. An interesting aspect, what I have to mention over here, we all know vaccines, right? How many? We all know, and we have took vaccines also. So during those years when vaccinations or vaccines were not intervented, you know, our Siddha practitioners, they did a clinical practice like smallpox and chickenpox, you know that. The treatment of smallpox and chickenpox basically with turmeric and neem. They don't have any vaccines. And how they do vaccination during those days, actually they took the crust of this lesions, and they do allow the other people to inhale those crust, so which automatically create the immunity for them. So vaccines were created, not now, long back ago, by our ancient practitioners. And also the basic concept of Siddha. So as we said, food is medicine and medicine is food. So whatever you have, whatever you eat, if you have to have it to the limit. If you eat something more than it will become a poison. And we have 3 main factors, which we call it as the basic factors for Siddha medicine is Vata, Pitta, and Kapha. These is the main components which is there in our body, and we do diagnosis based on this analysis. If some component of it's deviating or this variations is there, then automatically it leads to disease. So when we want to correct a disease or when we want to cure something, you have to clear this components instabilities or imbalance. So it should be running in our body with a balanced state. And we basically depend on the food. I already mentioned you, and because the food, it has 6 types of taste. So every disease is related to your taste. So for example, if you have a common cold or flu or something like that, so it is a disease of Kapha. So this disease, you should not be having anything sweet. You have to have something opposite of it, that is a sour taste. So when you have a food of sour taste, automatically your Kapha level will be stabilized and you will be getting healed from your flu or cold or whatever may be. So that's the reason we always say medicine is food, food is medicine. And also our basic concept, the 6 taste is made of combination of each components out of this 5 Panchaputas. That is already there. So the basic concept of Siddha is like basically predictive, that we diagnose, preventive, personalized, and also participatory. So in Siddha medicine, basically, rather than going for surgeries, we recommend for conservative treatments. So my slides will be there as a clinical practice. So the prominent scopes of our medicine is a herbal treatment. So herbal treatment is a plant-based medicine. So food is our medicine, so all the medicines the food is our medicine, it is a plant-based. And we have a regeneration therapy, we call it Kaya Kalpa. So in ancient days, our physicians, our siddhas, they lived for more than 100 years, 200 years easily. How it is possible? It is due to this Kaya Kalpam. Kaya Kalpam is nothing but a combination of combinations of plants or the fruits like amla, honey, we know ginger. So these they started eating it regularly, which became their habit, and they were able to live for long life. And we always concentrate on mental health because Siddha says body, mind, and spirit should be unified. And we have a preventive medicine also. And as we already discussed on this, there are 3 main vital factors. We already discussed on this, Vata, Pitta, and Kapha, and 5 elements we know. And we have 7 basic tissues, that is our body components. So I'm quickly skipping on this because I want to cover all the slides. So whenever there is some changes in any one of these components, it automatically leads to disease. So it has given you. And as I already discussed, when there was no diagnostic methods invented, either blood test was also not there to diagnose the disease, our traditional practitioners, they do diagnosis with these methods. That is tongue examination, color examination, speech, eye examination, stool examination, urine, touch and palpation, and the pulse examination, that is Siddha pulse examination. So out of which, so if you see this is a unique pulse examination, you can see here. So the Siddha practitioners, they diagnose the disease by carefully analyzing this patient's pulse with the rhythm, strength of the pulse, and also location. So it should be 1, half, and quarter. If any one of is differentiating or imbalancing, automatically the body have a disease. So based on the imbalancement, so if the vada is more, we will give medicines to control the vada. Similarly for the other pulses also. And also this is the same, we have given the symptoms when like these components or imbalancing, you will get these disease. So you can have this as a reference, I'm quickly. And this is a unique examination. You will say what is unique in it. So this is a normal urine examination, and we have one more examination in the urine, which is called, you can see here, basically they drop a gingerly oil on the collected urine. So based on the settlement of the urine drop, they diagnose whether the condition is acute or chronic. So there are that much knowledge there. So these are the routine things. So this is related to this oil examination in the urine. So the uniqueness of Siddha, so we already discussed. This is Kaya Kalpam, pulse diagnosis, and yoga and medications, and very importantly, the Varma therapy. So I'll be talking on that. So these are the treatments. And what about the medications in Siddha? So the medications in Siddha actually of 3 types. This is the plant origin. So we all know it is a herbal-based, plant-based medicines. It is harmless. The second one, we use animal-based, like the ghees, milk, curd, yogurt, whatever we call, we use it. And the third is very important thing, it's the metal and mineral origin. We call it as Herbal mineral products or mineral products. So you might be thinking, how this mineral, we are not using the mineral products like Azara or directly. We are making it into a nanoparticle. We are processing it. And finally, the toxicity of the products are clearly verified, tested, analyzed, and it is recognized, standardized by Ayush, by IMCAPs, and various drug mandatory companies, and then only it is released for use. So no need to worry on the toxicity of drugs. Okay, and the strengths, as I discussed, and this Kaya Kalpam already we discussed, and the drug standardization. These are the organizations who standardize the drug. It's not like before. Before we used to say that Siddha medicine we have minerals which have toxicity to liver, kidney. No, because we have many drug organizations, standardization organizations, who do standardize these drugs for toxicity. Okay. So these are some good food habits and lifestyles which is followed by our ancient traditionals, and they advise, and we advise you to do the same. Please always drink warm water instead of cold water. Okay, this is my first advice. And take food twice a day, and take quality of cow's milk, and do therapeutic emesis. Emesis, you know, it's like a cleaning of our stomach. It's a vomiting thing, like. So it could be done by every 6 months, and we have therapeutic purgations once in 4 months, and we should install nasal drops. Nasal drops, it's not as a medication, it's as a preventive medicine. We can use it for every 45 days and take oil bath once in every 4 days. And we usually use eyeliners as makeup, as cosmetics. But our traditional practitioners, they use these eyeliners as a treatment. We have medicated treatments. And we have unique external medications and treatment options. You can see here, these are different external treatments which are unique for our Siddha medicine. So you can see here everything just, so this is called Tokanam, or this is a form of massage therapy with medicated oil. And it treats hemiplegia, paraplegia, and all muscular disorders, and also sciatica, on most of the musculoskeletal disorders handled by these therapies. And we have Otterdam. This is like a fermentation thing where the medications are put in a pouch and they are used as a treatment. And there are many different diseases treated over there. This is medicated pouch. And this is a very important treatment method, which we call it as antiviral or leech therapy. You would have heard on it. Actually, leech therapy, these leech are grown in a medicated situations, and these leech are used to treat and remove the toxins of blood. So basically, we use this leech therapy for arthritis, eczema, and dysmenorrhea, many disease, okay? And this is a type of cauterization which you use small heat therapy for treat various arthritis and sinusitis pains. So let me quickly go through this Verma therapy. I don't know, how many of you heard this Verma therapy? So it's a unique thing. It's all over body we have 108 Verma points or energy points. So this Verma therapy is nothing but stabilizing or releasing the energy from these points through like hands, with some pressures and massages. So this have given a unique effect, and it have greater beneficial effects in controlling the fatigue and nausea of chemotherapy patients. So the chemotherapy patient usually have like side effects of nausea and fatigue. It is controlled by this Verma therapy and yoga therapy also. Other than that, the Verma therapy have many benefits. You can see here, cervical spondylosis, migraine, psychiatric disorder, asthma, many things, okay? So these are the Verma therapy points. So recently, in December 18, 2024, in the Natural Research Institute of Chennai, India, there was a Guinness record made to create an awareness of this Verma therapy. So nearly 555 community people received Verma therapy from 555 practitioners. So this is the newsletter of it. You can quickly go through it. And this is a small video related to that. So it has some Verma, just why I am playing it, just for you information how the Verma is done. So through this, many diseases are healed. So it's a unique technique of Siddha medicine. So I will quickly skip over it because I don't have time for it. And this is one of the greatest achievement I can say. Because you can see here, Mora School of Medicine students to travel to India for training in Siddha medicine. So in US, the Atlanta University have recognized our Siddha medicine, the traditional healing practices, and the medical students over here are sent to India to have training from our doctors. So this is the, you can see here, this is from the newsletter. And this is a very important thing. This is the yoga or asanas. So I was discussing with some of our colleagues that yoga or asanas is nothing but a positional change of our body. So you can see it can treat many chronic diseases, not only our psychiatric disorders, it's creative digestive disorders, it's like it can treat any, even the thyroid disorders and any reproductive disorders, disease or cured by this asanas. So you can see here, every posture heals specific disease. So when we practice these asanas or posture, we will be able to get rid of these disease. Okay, I'll quickly go through it because I don't have time. And this very important slide, actually, let's go back. So this yoga therapy, it's an integrative. So my colleague was mentioning on the MD Anderson Cancer Center. Actually, it has recognized yoga therapy as an integrative medicine for cancer patients. So it's already there. And this is a very important thing. This is the Vasi or Pranayama, is our breathing exercise. If I could find a time, or if time allows, we will do a breathing exercise with it, actually. It is very, very useful, actually. It clears your mind, and it controls your blood pressure. It controls your asthma. It creates like happiness from your inner. And also it creates all the heart disease, and most of the disease are cured by this pranayama. So this one I quickly see, this many diseases are treated by this Vasiya pranayama. So if time allows, we can have a quick rehearsal of it. And you know already, there are many medicinal herbs and plants which are originated from India, and it's treating many diseases. And my colleague were discussing about turmeric, curcumin, and also we have amla, we have kilanali, thuduvela. Every one plant have their own potential of anti-inflammatory, antiseptic, antioxidant, anti-cancerous. So I don't have time to discuss very in detail, but these are the plants and their uses. So I'm quickly skipping over it. So this is a very important topic. So this is a proven healing practices and medical solutions with case studies. So before going on, actually, our Siddha medicine treats chronic diseases, mainly skin diseases which could not be treated by other medicine department, or it is a chronic thing. So for everything, I'm speaking with a proof, and there is a journal for it. You can go and look into it. So here, a clinical study done on psoriasis. So you can see the psoriasis, how it was, and after this is after 17 days. You can see the difference over there. And after 17 days, so this is, you can see the desquamations, how it get healed after 45 days. So this is before and this is after. And this is also the psoriasis patient. As a different patient, this is. So I'm quickly skipping on it because the picture is shocking to you. This is after 45 days, so you can see. This is a case study and a clinical trial done with this medicine, and it has been proven. So the graphical, and this is very important thing. We all know diabetic foot ulcer, and also you know cutaneous ulcers. So with a single decoction or like a single medicine called Manjiti, these non-healing ulcers are healed. So you can see there, and I have given you the references also. You can just go through it, and it's a proof in front of you. With a duration of 2 months, in 50 days, the patient was taking only internal medicine or internal decoction. That's it, herbal medicine, not any external, but it's healed after 50 days. And you can see the traumatic ulcer, how it healed after 70 days. And also you can see these all bed sore, how it's healed. You can see there after 45 days. And this is a very important thing. It's a diabetic trophic ulcer. So you can see within 40 days how the healing is. You can have a closer look on it. So I'm quickly saving out. This is varicose vein ulcers, which is healed. And this is one of the typical case. This is a dermatitis treated with Siddha medicine. And you can see the difference after 90 days. This is only internal medicine. And this eczema, we don't have any internal medicine. It's only an external oil. You can see the difference over there. And is also lichen planus. This is also an external oil only for 1 month, and you can see the difference over there. And each and everything, I have kept a reference for you. And we all know COVID-19, right? So we have lost our loved ones, and we never forget COVID-19 in our life. So during COVID-19, India also have a lot of mortality rates, but we have a medicine invented, or we were using there, which is called Kabasurakudini. This is made of 15 herbs. These are journals. If you see, the death rate in India, basically in South India, is far less than the other part of India because of the usage of this Kabasurakudini, of this decoction, or a herbal tree, whatever may be. So this is, I can? Okay. So these are the graphical representation. I quickly skip over it because I'm getting signals from back, sorry. So it has proven results. COVID-19 is cured by this medicine. So this is one typical treatment for, actually Siddha medicine have treatment for hemorrhoids, for fistula. So this is without any surgeries. So here is a unique procedure we call Karanul Sigichai for fistula. So this is nothing but a medicated thread is tied over the fistula opening, and it's allowed to heal by itself. So after tying the medicated tool, the patient will be receiving some stitch bath and some outside wash and something like that. 5 minutes, sure, quick it up. So these are integrants. You can say it's a plant-based, and then nothing over that. So just I'll quickly go through the case studies, the clinical trials. So this is how they are sterilizing the thread, medicated thread. And it is stored, and they are tying the medicated thread, and they do a pre-operative. This is the way you can see there for the fistula. The medicated thread is being tied, and it is left for 1 week, and after that it's changed. So you can, while I'm showing this, you can see the difference over there. This is baseline, and that is before treatment. This is after treatment. So various case studies are there. So I'm quickly skipping up since I don't have time. And this is very important case. This is adenomyomas. The patient was advised for surgery. But with a treatment of 3 to 4 months, you can see the report, the adenomyomas is not there. And we have jaundice treatment, very unique jaundice treatment in herbal medicine. So with the bilirubin level 14.7 came down to 2.9 with 15 days of treatment of this plant-based herbal treatment. And coronary artery disease, you can see that. This is only plant-based medications over here. So this heals nearly like 99% of blockage of a CAD of patients. And tonsillitis, you can see there, the difference over there. The patient was scheduled for surgery. It's a conservative treatment. And blood sugar, you can see here within 20 days, the blood sugar from 196 came down to 126. So diabetes, many of them, they're talking on the diabetes. The first thing to prevent diabetes is please stop your sugar-coated or sugar drinks, please. That is a very important thing. And we have herbal medicines for it, and how we can collaborate traditional practices with the modern healthcare systems. So let me quickly go through it. WHO organization have already accepted and agreed with traditional medicines and its effectiveness in chronic disease treatment. This is already repeated. So this is very important thing actually. How many of you heard about this DMD? I don't know. The child, when is affected by this DMD, could not be able to walk, and it becomes wheelchair bound. At the age of 30, automatically their lifespan ends. But with integrated traditional medicine and our modern medicine, we are able to make this child walk. Okay, that's the first thing, and their lifespan is increased. So just there is a video actually. I don't know whether it's able to play there. This hospital actually, it treats CP patients, spinal cord injuries, DMT, muscular dystrophy patients, so everything. So the treatment actually is a traditional treatment. First, they do some, you can see there, a child is allowed to stand with some support, and they do some bandaging. We call it as Kattu therapy actually, and many exercises together with that physiotherapy is done, together with that hydra therapy. That is, the baby or the child is allowed to stand like this with therapy, and then they will be given physiotherapy, that is hydra therapy in the swimming pool to delay the cardiomyopathy, and also they get the help from neurosurgeons, orthosurgeons to treat the patient as per their requirement. So still now, this clinic or this hospital is working, and it started 38 years ago. So it's a long tradition over there. So this is a treatment over there, and hospitals. And as my colleagues mentioned, for cancer also, we always have traditional medicines. The curcumin and these all things, we have integrated medicines. And for cancer treatment, we have direct treatment also with herbal mineral medications, or also herbals also. So this is a live case from the newsletter that this is one of the famous cricketer who treated or who gave his wife with normal diet with turmeric, neem water, apple cider vinegar, lemon water, and with stick diet, she is able to fight stage 4 cancer. And these are regulatory bodies, and these are hospitals and colleges for your reference. And basically, finally, these are some pictures where we do community services for our people with our treatment. And these are our references. And I have to always thank honor my colleagues, my friends, my doctors, who always there serving our people. So hats off to your doctors. And this is Siddha medicine. It is a holistic healing practice which basically concentrates on plant-based medicines rather than like surgery or weed. Yeah. So we treat all the chronic diseases. So I'm here. So anytime you can contact me. And for sure, we are always here to support our society, a healthy society. So thank you all for listening to me patiently. Stay healthy, stay balanced, and stay blessed. Thank you.
All right, thank you, Dr. Crescentia. Now let's talk about the role of AI-powered wearables in making healthcare more accessible to all. Your watch can now monitor your heart rate, detect irregularities, and even protect potential health risks. AI-powered wearables are no longer a luxury. They're revolutionizing preventative healthcare and improving access for underserved communities. Diving further into this topic, we have a panel on how AI-powered wearables are bridging the accessibility gap. Let's quickly invite the moderator, Nishtha Jain, Head of Innovation and Digital Technology at Takata, and panelists to the stage. Welcome.
Hello. Hi. Welcome, everyone. I know this is tough time right after lunch, so hopefully we are going to bring some interesting insights on AI and make this panel interesting. So what I want to do is maybe just start with each one of you, if you can introduce yourself and also talk about how you have been currently leveraging AI in your practice, and especially in the accessibility space.
Absolutely. Thank you so much again. My name is Reza Abduli. I'm the co-founder and the CEO of Pulse GPM. What we are doing, we are bringing the ChatGPT to the healthcare. So talking about the AI, definitely it's been my passion last 2-3 years, and I'm enjoying these conversations. Implementing AI into the healthcare is crucial these days. It's going to help us, the providers, doctors, nurses, and also the patients. So many benefits we are gathering for them. I'm happy to be here and would like to share more thoughts on that.
So I'm Sam Saman. I'm serial entrepreneur, 5-time TEDx speaker, best-selling author for my book, The Singularity of Hope. And the book is about AI. And we are leveraging AI in a lot of forms. First of all, we have an AI company, but as well, I have a group of laboratories that does pharmaceutical testing. And we are using AI at all levels for quality assurance, for customer service, but also as what we call a special product, we have the co-analyst to help analysts do their job.
So hi everyone, my name is Dr. Thelma Zono, so I'm the CEO of Zips Medical Group. What we do in my company, we have clinics scattered all over in different states, and we basically see just veterans for their disability examinations. And with AI currently right now, it's really going a long way for us. So what we're trying to do with AI right now is try to get most data where we have something up to date, because we are seeing a lot of climb in different conditions. We're using AI to monitor those right now, and so over time we will have very accurate data to help us. Thank you.
Hello everyone, good afternoon. My name is Raj. I'm a co-founder of Vital Friend. Let me ask you a question, like how many of you are your parents living independently or living in assisted living facilities? So I see quite a few hands there. So what we offer is we provide a continuous remote monitoring service using Vital Friend. So it's an AI care companion platform. So imagine, like, in my case, me and my brother, we live, I live in US and my brother lives in Australia. My parents are back in India. So it's always challenging to know how they are doing with their health, and it is very difficult to monitor remotely. So what we offer is like, with the AI wearable devices, we can track their vitals instantly, remotely, and if anything that goes, like in case, like let's say heart rate goes up to 180, then immediately I get notified saying that there is something going on with their health. So we are using AI mainly to track their vitals, as well as to detect if there are any faults that are happening, to understand whether, if they require immediate attention. So there are a lot of AI in the we are using in our product, and I would like to talk more about it. Yeah.
Hello, everyone. My name is Dr. Alicia Jones. I am a geriatrician by training. I have started an organization called Vitus Health. What we do is transition healthcare to be patient-centric. And we do that in a dynamic way by utilizing AI integration. Because these are tools that, regardless of where you are or how much you earn, we can start providing quality healthcare to all of those within the country. We've seen AI transition the stage of healthcare. Right now, we have the capabilities, regardless of how much you earn, to start transitioning your quality of care. And it has leveled the playing field right now for all of those who are chronically ill, and by providing preventative health care for all. I am trained as a geriatrician, but I have recognized now, all of us are getting old. So as we age, we can age in place. We can age with dignity. And we can age in a way that we want to with AI tools.
Thank you so much for amazing introductions, and also sharing how you have been leveraging AI and what are your expert areas. Now, I was curious, what are the key advancements in AI and wearable technology that have made major impact in the accessibility area in the last 2 years? So if there are any real-world examples that you can share with us, and anybody can go first. I am not sure who would like to start.
I think I can go on that.
Okay, perfect.
So there have been a lot of things going on over the past. The most common one I'm sure everybody knows is about the AI wearables, so the watches that tells about the heart rate. It's a big deal. We do have a lot of cases of patients who do have AFib. We have a lot of cases of patients who have monitors on. But what happens, how does your mother know even if something goes wrong? It might beep on her phone, but the point is most people have access, just like my panelists had said. His mom could be in India, but he gets the alert once something happens. And we all have parents, and we know how they are, especially the older generation. So even if she feels a flutter, she just thinks it's one of those things that happens and just feel they'll be okay. But he can get on it to address it immediately and say, hey, you know what? We're going to have to call your doctor. We're going to have to do X, Y, and Z. So that's a big thing. I know at least from the millennials up, most people are a little bit iffy about AI, but the point is it's here to stay. So the earlier we get on it, the better. Let's look at everything. People have all the disadvantages they want to run about it, but there's problem everywhere. The fact that you drive a car, you could have an accident. But that doesn't stop us from driving. Just like any other thing, we can argue this all day long. I know someone who can swear by it that AI is probably saving something somewhere, and probably will have something that will happen tomorrow. But in the healthcare space, we need it. First of all, timing is important for us, the healthcare provider. Then you want to also monitor people. So who's going to be checking heart rates every hour? Depending on what condition you have. There's some conditions where you really want to, we send people home with Holter monitors. So we want to monitor things, so we want to get things real time. So those are like very critical examples that we can use in today's healthcare that we all need. Thank you.
Thank you for sharing that. So I'm curious, is that sending alert of some sort to kind of update on whenever there is any sort of intervening point?
Oh, yes, exactly. So if somebody who has an AFib and then gets like a real fat beat that is above normal, it's been set to a particular what is normal for you and what is abnormal, what is something that we need to raise an alarm for. So things like that will show. So that's why he has it set up where he can actually get an alert. And I'm sure maybe her doctor also has that. But at least they can come to him first, who's the son, and then he can contact the doctor depending on what. Some ones even give just the actual reading. So when you go for your doctor's appointment, we're not getting any false positive or false negative. So we can see your track within the past 3 months, for example. So we can see the trend of things like somebody showing up at the doctor's office without eating, and then we do a blood sugar, and it's normal. And then when you go back and really look, you find out that they've been running at 200s or 300s before that day. So it helps to keep data and helps not just the patient, but also the providers. So at the end of the day, it's a win-win for everyone.
Thank you for sharing that.
Another way that AI is transforming the healthcare platform is even in behavioral health and mental health. Something that is being used is like VR headsets and using integrative health in allowing people who are usually being screened for low-grade depression and anxiety, allowing them to utilize it for yoga and meditation, and having an integrative health sessions that are either utilized with a physician, a psychologist, a psychiatrist, or even at home if they are low-grade anxiety and depression. And these AI wearables are very useful in care and even billable with the insurer.
That's great to know.
Yeah, add to my panelists what mentioned. So many tools right now we are using them right now, like a glucose tracking. They're gonna track your insulin, and what she said, it's not gonna just happen about right now. It's gonna track you and send the information to the provider last 3 months, for example. They're gonna adjust their determination and doing the treatment we're gonna provide in because they have more reliable information related to that patient. So these tools are like other Apple Watches are gonna track your heartbeat and provide the feedback for the providers because there's sometimes there's just gonna be bad days for you. There's gonna be hard rates, and they're not gonna decide what type of treatment gonna provide for you based on that because they have all of the last 3 months data from you. So these gonna give better decision for the providers as well.
And another advancement I could see is the predictive analysis, because you are getting data from different devices, and with that data, you can predict what's going to happen. Like based on the past history, you can recommend saying, oh, you need to take these steps to avoid any abnormal, situations. Mm-hmm. And also with the technology now with the AI. So imagine like, you need to go to particular doctor visit. You have the complete health profile of your patient, including not just the point of data. You have the continuous history of last 1 month or how long they're using the device. You can create those benchmark profiles, and that will help the physicians to give right guidance to the patients to address any chronic conditions.
I will add something else that the same systems, these are amazing systems indeed for healthcare, but there is the aspect of how AI and wearable device can do what we call the physical human augmentation. Like imagine having 4 arms and an interface in your brain to control that with AI, of course. And this is not science fiction anymore. There is startups doing that right now. And in terms of wearable, I think the next leap will be somehow wireless control of other devices using a headset. We have the approach, of course, of Elon Musk that is with implant, but there are a lot of companies trying to do the same thing right now without implant, without surgery. And they are succeeding. Not the same level of application, of course, because they are going very hardcore in terms of Neuralink. But other companies, I will not name some of them, are trying to give blind people vision by using AI, by giving real-time description, by another form of augmentation as well is improving hearing and giving you even superpowers, like
Wow.
Iron Man.
Wow, that sounds fascinating. So just along those lines, I was curious, and if you have any insights into how these are being integrated with, assistive technology such as the smart home devices, voice assistants, if there is any examples.
Yeah, of course, we can integrate them in all kinds of devices. That's the concept. But it will be better if you develop them as autonomous things, because I don't think our human brain is programmed to have 4 arms, right? So you need somehow some autonomy. And connecting to other connectivity is amazing. And I think it will looks like we'll soon be all connected to the cloud, right? And maybe we can communicate telepathically.
Absolutely. I believe these days we can find the Alexa or Google Home in all of the homes that we have. And with connecting these devices to them, it's going to make it beneficial for us. So imagine your smartwatch going to detect your blood pressure going high. It's going to lower the light. It's going to lower the music. Call the 911, and they're going to send away for you. That's the goal. You're using all of this technology together, integrate them together to better output for patients.
That sounds fascinating.
Yeah. So another thing is like with the devices, smartwatches, you can integrate with, like as you know, these guys said, like you can integrate with Alexa, Google Home. Imagine like as a senior, you wanted to, it can remind you about your medications that you need to take regularly. And it can say, hey, Raj, this is the time for you to take a medication. If you forget, it can remind you. And you say, no, I wanted to take it after half an hour. So it should automatically record it. And then it will remind you after 4 hours, you know, from the time onwards, and say, hey, this is the time due. So it can add a lot more value, especially for seniors living independently. They can be, you know, they don't need to depend on anyone. They can use this technology to be self-service.
Thank you for sharing. So I know we have been talking about a lot of possibilities, what can be done and what have been done. Now I'm curious, you know, with all this happening, there might be a lot of challenges, which I can imagine, you know, challenges from the design to privacy, like data privacy issues, you know, utilizing the data. So I'm curious if, you know, there are any examples that essentially you can share in that space, like what are the challenges that you have seen or come across while trying to implement?
I would say one of the pushbacks that I've seen is the provider pushback, the concern of how is this replacing that hand-to-hand touching of me. As a provider, I continually tell my providers, it doesn't replace the provider, it adds the tool. It helps us. It helps engage your patient more. And I continually to tell my providers, all clinicians, it will engage us further and it extends our reach. So please understand the AI tools, as we provide good information in, the breadth and the depth of which it will allow us it will extend further than we can imagine.
I'll also support her too, because most times the problem is even us, the physicians, you know, trying to, how we able to be open-minded to see how it works. The fact that we've been doing it this way doesn't mean it has to be that way all the time. I'll use for us with the veteran population, we do have people who have things like PTSD, so getting into an audio booth is a big deal. I've had people come in, and it's a big deal. They can't get into there, they're claustrophobic. It's a real condition. So why would you, somebody who can't even back a door, you want them to go into an audio booth and you shut down the door? That's almost impossible. So it's been going, and then with the VA, it's this way. So if we can't get this reading, then we can't do this, then we can't do that. So you have to do it. So now if they're unable to do it, then we can't get any kind of disability for them. So now the VA, they came up with the whole kudu wave thing. So good thing, we don't need an audio booth now. But we still have problems with the older providers saying, how are we sure this is accurate? We've even had to do some examples where we get somebody in the booth to do the test and get them out and use the kudu wave, and they can see that it's almost the same thing, but some people are still flat out. So that's really a big push for us sometimes. Yeah, I mean, one of the challenges I see was the data, because you are getting from all these different devices, and to aggregate and making it meaningful insights out of the data is one of the biggest challenge I see, because it's not just your wearables, you're also looking at the physical devices that are used at the hospitals. So there is data coming from all different angles. So you need to use AI in a way that will make it more effective for consuming the data.
And also, are there any privacy challenges that you want to highlight?
Absolutely. There are privacy and compliance constraints. Both are applicable to the, especially because we are looking at the regulated environment where the privacy is the key, and the environments where we use, whether, what kind of cloud environments you wanted to store the data, and on top of it, the compliance issues will also we need to look at. how we utilize the data effectively.
I will add the regulation challenges. What's the point if we have the best invention in terms of healthcare, and then the FDA comes and tell you, hey, you cannot use it? And then this will somehow delay the adaptation and increase also the price, because more and more regulations coming. And it's really a big challenge how you can explain to people who are used, let's call it, to dinosaur regulations, that this is a new technology and they need to make it fast. Otherwise, there is no point, right?
Definitely. I just want to add to what Doctor was mentioning. AI, these technology are here to empowering provider, physician. They are not replacing anyone. Yep. But one other issue I found it with other clients I was working with, the user faces of the devices. So for example, so many of devices these days are touch screen, but we do have patients that are blind. They are not able to use these devices. So one of the keys we have to implement these devices is to be voice control, be haptic feedback on them, and the other concerns come to the batteries because AI's engines are consuming so much energy. These devices are dying so fast. So providing a better battery for these devices is going to be another crucial. It's going to be easier for patient and people, the users, to use them regularly, not just a couple of hours of using them. They are there, they are not feeling good, or they're lazy to put them back on the charger. So these two, I found it with the clients we are working on, the crucial touch screen issues on the batteries.
Thank you for that. And I know we have been talking about all the different angles now. One thing I do want to mention is like accessibility, and AI is not only about technology, but it's actually about making sure that these can reach the underserved communities. So again, there is, I've seen a lot of these devices are not that cheap. They come out like really, and just to give some examples, so for example, Aura Ring and some of the new devices that are coming, there's not only cost associated with purchasing them, but also with the subscription. So I think my question to you would be if any of you have any insights to share on how these can be made affordable, not only accessible.
I think it's going to take all of us working together, both the technologists as well as the clinicians, both working together to try then to say to the insurers, this is going to serve us all better. It's going to bring down the cost of healthcare. It's going to assist the patient. We need the provider, the payer, and the patients all working together to serve this ultimate goal in making our health system better. Right now, the costs in utilizing some of these wearables, not all of them, because some of them are actually very cheap, but some of these wearables, if we bring down that cost delivery model, we can serve a greater population, and then then their costs can be utilized for more people.
Just want to mention that I believe we all need to change the view we do have to these tools. These are not gadgets. These are life-saving tools we are providing for the patients. I believe the next step is to healthcare is going to bring it up to the insurances. They're going to provide some of the cost, because it's helping the patient like a medicine. Why not we are providing some sort of insurance services for them and provide some of the cost for the patient?
I think the government needs to step in. This is like a one-in-a-time opportunity in terms of our lifetime. AI is our lifetime opportunity, and it's unavoidable that we cannot do this revolution relying only on patients. It's even impossible.
So again, I continue to think about it, and at corporate level, what I have seen is, and this is not just my I work for a pharmaceutical company, not just my company, a lot of other companies, they're offering, say, every year some reimbursement towards purchasing wellness devices. Again, it could be any of the device of your choice, but then they reimburse you the money to be able to, at least start using it. So because it's more about empowerment, that way you can have your own health data, and you can like understand how things are. But then I'm just wondering, is there any sort of like, if say there would be a message that you want to share to say, like what would be the message that you would want to share in terms of educating people about like that it should be something that people should start thinking about, not only the ones with accessibility issues, but in general to take charge of your own health, so to speak. So is there, I'm just curious, like what can be simplified? Because I know a lot of people think, I'm going to wear this, it's hearing me, it's taking my information away. So how can we change that sort of mindset, or have people adapt to these devices? So that way one step is already done where, people from a very early age have started to use these, and they're looking at their own health data and have that empowerment.
I would think, generally speaking, if you remember when Amazon just came in, a lot of people had problem putting in their credit card, where you have to put in your credit card on Amazon and save it. It was a problem initially. But right now, everybody's card is on Amazon. Some have all their 5 credit cards on there. So it's only just going to be a matter of time. So we have to keep talking to people. So when you come from the corporate world, we want to also let them know. So let's say flexible spending. Like you said, let's not look at it as a gadget, more like a life-saving. You know what I mean? Like a medical equipment, more so. So flexible spending should be able to be used to buy that, for example. So we have to start from that standpoint. At least for those of us in America, we know that flexible spending you can use for a medical device. So it should be seen at that point, other than looking at it as just a watch. It will tell you your time, but it has other things too that it's doing. So education from our standpoint is going to be a big deal to let people, and there'll have to be like a serious campaign about people taking charge of their own health, kind of figuring out what is going on. Because we're in the healthcare field and we think it's normal. If you go ahead and do a survey somewhere and you realize that a lot of people do not have a blood pressure machine at home. A lot of people, you will be shocked. I'm talking about educated people. It's not a financial problem, but they just don't have it. They just don't think they need it. You understand? So it goes back to the grassroots. We have to educate people. Let them take charge of that. That's the first step first.
Yeah, I echo with that. Education is the key. We need to educate, about the benefits of using these devices. Mm-hmm. And also another thing I could think of is mainly focus on, it's not like a cost that you're putting towards like, expensive watch. It's more about your health, your data. You are in control. It will help you avoid any abnormal things that could happen in the future. So it's more about the education, and also we need to work with the government bodies to help from Medicaid and Medicare. They can also come in and help these, especially underserved communities, to provide these kind of devices for free so that, they can monitor their health remotely.
I think the economics of health is very complicated, as all of us, I'm sure, would agree. But I think when we start with prevention, and I believe these AI tools allow us that preventative tool. When we start with prevention, we save money. As opposed to working on the acuity in pharmaceuticals, a lot of times if we start with the preventative care, we start at a different role model. And we can do both. We can do both consecutively. But as a clinician, I believe using AI tools is a better or is an easier way to start. And we start there, AI tools, start that journey, continue that journey, assist again with the provider, the payer, as well as the patient, because the patient also needs to be educated in utilizing these AI tools because it's new and it's different. It's been around now for about 15, 20 years, quite frankly. It's really not that new. But educating the patient to accept it also, as well as the provider, and then the payers to pay for it. These are all tasks that all of us need to engage and take up.
Thank you for sharing. And this would be something I think once we open to audience questions, this would be great to hear from audience as to how we can educate people more. So I have one last question, and then I guess we'll open to the audience question. And because, we have talked about, possibilities, challenges. Now, if we don't talk about the future, which is, the innovation, then, this is not going to be a great topic. So I'm curious, and maybe we start from you. I want you to share like what you think your vision is for that 5 to 10 years, where this space, how it would look like, what these wearable devices could be, and how can they change?
I do believe that the AI wearables will transition primary care. I believe it will be reducing of provider burden. I believe that for my seniors, for my women who are experiencing high maternal death rates, I believe it will be a transition point to why and how we see within the United States us being one of the worst case delivery models of healthcare. I believe if we start identifying where within our health deserts to start engaging and delivering these AI deliverables that are really not that expensive, if we start identifying these deserts and start providing access to these wearables within these communities and these neighborhoods, we're going to see transitions of care. And people are going to start asking, well, why is my hemoglobin A1C elevated? We're going to start educating people to be advocates for themselves. And as they're advocates for themselves, we're going to see a transition of that we're not going to see as many diabetics, as many CHFs, as many people with liver failures. So we're going to see a transition in our healthcare platform.
So AI wearables is going to become as a commodity, and everybody will have one. And it's not just monitoring, it also enables you to, it's like, did you go to school? Did you have your band, right? wear a band and go to school so that we can monitor remotely. So, and with the technology advancements that's going on, we can not only just monitor it, we can also do advanced things like geofencing, fault detections with the accuracy. As the technology is evolving, the dependency and the trust on the devices will also increase. That's, I think, in the next 5 to 10 years, what I would like to see is everybody is having their own health profile and they maintain it themselves. And for the physicians, it's a less burden, as you said, because they have the data in hand as and when needed.
Yeah, so that's a great vision. So I think what I'm hearing you say is that it's going to be part of our life. So it's not like exception or just a population. Everybody will have their own device, and it's like kind of how you wear clothes, you will be wearing one of those.
So for me, I think with the AI, in another 5 to 10 years, I think when it comes to research, it's really going to help us a lot because we're going to have the data available. We're not looking for people who are we need 20 black men that are on Lipitor and what their liver functions have been. For example, we have that right there. So when it comes to the research part of medicine, it's going to be a game changer. I can say that for free. Every data will be in there. All we are asking AI is to pull out young Caucasian men between the age of 30 and 50 that have been on insulin for this amount of years. And that's all what the researchers need to give us the results. We're not trying to recruit new people. We're not trying to pay people off. It's just going to be a normal thing. So now it's not going to be we have research where we're looking for 20,000 Asian men, or we're looking for 20,000 black females. Everything is just going to be in there. So let's look at it from that standpoint. That's where I see all this going in the next 5 to 10 years.
Yes, it's ambitious today to say what will happen 5 to 10 years. I think 2 to 3 is enough. So whatever you said, I think it will happen much faster than we thought. It's very, very accelerating. We can see it in the AI landscape. Like you have an invention tomorrow, and in 2 months it's absolute. And we never seen that in our lifetime. It's something new for all humanity. So I think if you need to think about the future, not only wearable device, all the AI revolution. So you mentioned the data. I agree 100%. But also, what about robots? Maybe in 5, 10 years, if I'm not mistaken, Elon Musk said everyone will have a robot at home. Maybe we don't need to have wearable anymore. They will be our companions that are wearing everything for us and taking care of us.
Yeah.
So 5, 10 years, it's a big time in our lifetime. This is what we call the singularity somehow. When things are accelerating, we reach a point, maybe we have an invention every week. And maybe the big question, can we go with this as a human, you know? We have like spent, I don't know, 30, 40 years with compact disc, and now we have the cloud, right? So what will happen with wearable? I think 2, 3 years is enough. I think in 5 years we'll have the robot taking care of us.
That's true, 100%. I agree with you. I believe at any changes happening in the period of the mankind, it's been some tough days, like internet comes in. You know, then was like credit cards, everything at the first acceptance of it, it's so hard for people are ignoring them. But when they see the benefit of it, everybody gonna be more willing to accept that changes. I mean, like a few years ago when the ChatGPT came out, everybody was like, oh, what AI is helping us. AI, how can solve our problems? And bringing AI and machine learning models to our life, it's going to happen in super faster. I believe I do agree with you. Next 2, 3 years, it's going to happen to all of our lives. And even the hospitals, clinics, they can use these models to provide better services for the patient as well. It's already has been happening, integrated to the hospitals, using the models to predict better services for the patients they do have. And I believe when we had to need to change a point of view to these devices, and we bring it up to the insurances. If you spend few $100s now, you could save thousands of dollars in the near future, because the patient's gonna give us the information related to their health so we can better service them. It's gonna less cost you. I believe if you bring up this type of subject with insurances, they're gonna be willing to accept these differences. So they're all talking about the monies, that's the only concern they do have, but I believe just few $100 spending now, it's gonna save them so much money in the future.
So firstly, thank you so much for sharing these amazing insights. Again, you know, I love probably we'll have robots and replacing these companions. So I know we have some time left, so I do want to open now to our audience for any questions. And I see one hand raised. Yeah, right there.
Right here's the mic.
So, AI is exciting and fast-moving and so on, but we have a lot of people, young and old, who are very reticent and fearful of it. And you're going to have them put a device on their body that they don't want to wear or they're afraid of. Like, how do you handle that? What, you know, because we're having a lot of pushback. And fear is a big non-motivator. So if you're wanting somebody who's afraid of it to wear it, they're just not going to do it.
I can tell you I've dealt with that. I've dealt and engaged with both physicians and patients who have said just that. You meet them where they are. You ask them, what is the fear? What are you dealing with? And give them what they're asking for. That's whatever clinical environment you're dealing with, whether it's in mental health, whether it's dealing with cardiac issues. But this is just a tool to help you and to engage you to make your situation, your chronicity better. We're just here, we're just an advocate advocating for you. And this is a tool to help you. Just like a stethoscope is gonna listen to your heart, this is another tool to assist you in monitoring you all day long and let us know and give us feedback. It's not going to enter anywhere else. It's not going to give us any more feedback than what we allow it to do, because it's a tool that is assisting us to make you better, and it's advocating for you with us.
I love that. Thank you for sharing.
Definitely, I believe we're providing real-life scenarios for the patient. They can see how it's going to be improve their life. And I believe so many of clients I have, they are just concerned about the AI, what the AI is. AI is not a robot, it's not a huge thing. AI, it's a model with so millions of rows of data can help you in a specific user cases you are using that. It's just a model, it's just a robot, and it's all handled with the humans. It's not gonna eat us or anything. It's just a simple thing. We're not gonna be so much concerned about the AI. We just wanna see it as a model. We provide the related data to it, and it gives us the feedback. That's it, it's all it has.
Thank you for helping with some of the fear. I know there was another question right there. Okay.
Great discussion. Thank you for the insights. Just wanted to ask a question about post-surgical care. We've been talking about accessible healthcare, preventive, and things like that, right? But it's inevitable that things happen. I'll give you a real-time incident. A couple of years back, I was consulting with the government of India. I was the chairman of the 5G Standards Committee. And this is where technology is evolving, right? And with the help of a physician in London, they were able to perform a very complicated surgery in a remote village in India using 5G. That was one of the pilot projects. And it was a successful surgery. But what next? Now, when you think of the fusion of technologies, you see that happening, you see wearables coming into picture. Now, if you're able to give those people who otherwise can't afford a device so that the patient's health can be monitored subsequent to that. So what are your thoughts on that in terms of using these wearables in the context of post-surgical care?
So yeah, that would be a good idea, generally speaking. So like we said, with AI, they're just starting. So it's a good thing you guys have been able to do that in India. So that's an example. So I don't think people within that community have been able to see what that happened. You know what I mean? What happened in that situation? So that's even going to be, for lack of a better word, like a selling point for them to see the importance of those things. And like I said, with anything, it's all going to be all about educating people. The problem is some people just don't, because I'm a provider and I think this watch should help you, I shouldn't come and try to sell it to you. I don't own the watch, so why am I doing all the marketing? But we do, whether we like it or not as providers. We need to explain, and the fears are genuine. I was one of those people that I didn't want my credit card on Amazon, period, as educated as I was. Because I don't know who's going to charge something. And then I don't have the time to call Amazon and be on the phone for 3 hours. So my fears were really genuine, right? So all it needed was someone to make me feel okay and make me understand that it's okay for me to do that. So once we accept that and we understand with people and we go out of our way to explain to them and understand that their concerns are really genuine, most people will do it. You will still have people who don't use a cell phone up to date. They still exist. But you would be shocked that most people who are worried about AIs have cell phones. That's what I'm saying. So that's where the education comes in. You're worried about AI. You have a cell phone that's recording everything you're doing anyways. You might as well drop the cell phone. So that's where the education comes in, and it's going to be something for all of us. I'm going to educate your mom when she comes into the clinic. You also have to educate her when she goes home. So if we're all on it, everybody gets comfortable at some point. It's really going to be a game changer for everybody. That's the truth.
So any more questions in the audience? We have one more.
Thank you for the insightful conversation so far. So I have questions in 3 areas. Okay, the first one is, as you rightly said, AI has been evolving at breakneck speed, and as we are so excited about all the great stuff it is doing or it will do, there are some challenges and fears also which are there. So my first question goes into the area of AI bias. What challenges or what steps you think of or you're already taking to reduce the AI biasing as much as possible? I know it cannot be made to zero. I mean, nothing can be, it can not be made to 100%, but at least what are the steps, what you can share that would be very insightful. And then I have 2 more questions after this.
Okay. The fact that you have AI bias comes from how we developed AI, right? And the solution is to develop your own AI. And here when I mean your own AI as an organization. Mm-hmm. For example, for historical reasons, most of the data we have is based on white people. That's what we have on the internet, that's what you have generically. But honestly, in all other countries, and if you talk India or China, they have their own data. And they can develop their own models with their own, let's call it rules, without the bias or relatively with a different bias, because always we will have bias. I have seen some people who are funny, think if we ask AI, we'll have an independent answer. It's not. And you mentioned something that was very nice. In fact, Google search is AI generation 2. And ChatGPT was generation 4, right? Mm-hmm. So it's all about the same kind of algorithm. It's about models. So the solution, we need to develop your own custom model. And I don't mean adding a file to ChatGPT and still using OpenAI. No, your own model running in your own servers.
Yeah, and I just want to add one thing to it. So at the grassroots level, and again, I know it's now a very sensitive word, DE&I, so I'll be very careful in what I say. But I think it's at the grassroots level, having the diversity in people who are writing these codes. I know now it's beyond that point. So now it's pretty much the prompts you ask. So again, you can certainly mitigate a lot of bias when you are asking and this is for Gen AI, that you can ask certain prompts and you can then prompt and confirm that, is this biased data, do you think? So again, I think that's one way, but I think at the grassroots level, it's definitely having more diverse people, which is like women, which is, not just because if you think about people who are coding in the back end, it's mostly males and it's like certain gender type or stereotype. So I think that's probably the place to solve for it, which again, I know there had been a lot of work done. Now I don't know what the future of that would be. But yeah, just wanted to share that. But then on the Gen AI, on the front end user side, it can be the way you prompt or you ask the question. You can certainly at least get the best out of what it is in the back end.
Just to add one thought, organizations has to follow the ethical AI practices. Like they need to not focus on one particular data set. They should look at the diverse data, and then with the diverse age groups, and also organizations has to set the accuracy levels. How much is acceptable within the organization? Is it 80% accuracy from the model or 90%? So that's where, it's about the organization, how they accept these AI standards and put the, boundaries around and compliance requirements on how they wanted to use this data for the good.
As you can see, the concern we all have here is a major concern is all data, and the privacy behind it. That's a major problem we do have right now.
Exactly. Although I can go more on that one, knowing that what happened with the United Health Group rejecting all the Medicare claims and things like that. But I get it. I think the second follow-up question on that one is which is one of the major challenges in the healthcare is interoperability. Now, you are trying to get data from, and if I talk just the medical wearable devices right now, again, I'm not talking EHR, EMRs, everything right now. Of course, they will all have their different APIs, different formats, different structures. How you are coping up with that? What are the challenges your data engineering team might be facing? How you are keeping up with that? Because that's not easy. And as you scale further, let's say today you have 1 million people using it, tomorrow you have 10 million people using it, which is a good problem to have, but that brings more challenges too, okay? Because then your data is increasing, and again increasing in structured, semi-structured, unstructured data coming in, okay? How you are, and what is the plan of attack for addressing those challenges?
I believe one of the concerns is we do not yet have the standardized data format. And so many of the providers and the small wearables, they are the small private companies. They're not willing to share the data they have gathering from their users. These are the two issues we do have so far. I believe we need to get to the point we standardize all of these, and when we see these type of smart wearables as tools to help the patient and the providers, we need to ask them to provide the data, because so many, like for example, the big one, the Apple, they keep the data. They're not sharing the data they're gathering from the user because they just want to do providing and make the tools better for them and make more money for them. And these are the concerns I believe we need to be more willing to share the data from the user. So other companies, other tools, they can be provided for the patient as well.
I will give you add to this 2 organizations when you can get data, Epic and Amazon.
And sorry, he just had one last question, and that's, yeah, we'll let him finish. Okay, got it. Okay, thank you so much, everyone. Thank you.
Thank you.
Thank you.
Excellent. Thank you to our panelists. Now, moving on, we often blame patients for not following their treatments, not making better choices, or not seeking help early enough. But what if the real issue isn't them and it's the system itself? Gaps in affordability, accessibility, and equity leave many behind, making even the best medical advancements meaningless if they aren't reaching those who need them. In this powerful keynote, Brian J. Bauer, the founder and executive director of Abundance Foundation, Inc., and a seasoned recovery advocate, will challenge the current healthcare model, shedding light on the systemic flaws and how we can create a more patient-centered, equitable system that works for all. So without further ado, let's make a big round of applause for Brian.
Good afternoon. I'm Brian Bauer. I am the founder and executive director of the Abundance Foundation. Show of hands, who in here knows somebody that's been impacted by addiction? So majority of the room, that's about what I'd expect. Now the information that I'm going to reveal to you today is going to seem overwhelming, hopeless, depressing, but what we're going to get to is actually a very simple solution to this complex problem. So just bear with me and buckle up. There were 48.5 million people aged 12 or older in the United States in 2023 that were struggling with a substance use disorder and therefore in need of treatment. That's the same as the total population of Oregon, Minnesota, Tennessee, Nevada, Colorado, Oklahoma, and New York combined. So the odds are that everybody probably knows somebody. Now, I'm one of those people. I've been sober since August 5th of 2012, but thank you. Just prior to that, though, I woke up one morning and I was coming out of another alcoholic seizure. I was shaking from the DTs. I had sweat pouring out of every pore in my body. I could barely move. I glanced around. I was dry heaving and all of that. But I glanced around the room, and it was covered in the empty vodka bottles, the overflowing ashtrays, the piss-stained mattress on the ground. I knew that something had to change. I was suicidal, but I was so low and defeated at the time that I figured that I'd probably find a way to mess that up too, just like I had everything else in my life up to that point. So that's when I kept just repeating that cycle, though, day after day, night after night, thinking that something would change. But I finally reached out for help, and my family helped me get into a treatment center out in California. I figured I'd go do 30 days of treatment, and then I'd be fixed. Right? We've all seen the commercial. I was an addict. Now I'm not. So 30 days at the time seemed like an eternity when I could barely stay sober for longer than 2 hours. So I go to California, I go to rehab, I do 30 days there, but I'm barely detoxed at that point. I mean, 30 days isn't very long. And I get out and I continue some outpatient groups and whatnot, but I got into a sober living house. And the thing was, in those early days at the sober living house, I actually hated myself more than I did in my active addiction because I couldn't numb the pain anymore of feeling uncomfortable in my own skin. And that's about the time that this group of men in recovery took me in. And this group of men, we did 12-step work together, and I learned how to be vulnerable in front of a group of men. But the biggest thing that they did for me was they showed me a new way of living. They taught me how to show up, how to be a man of integrity and accountability, how to better myself physically, mentally, emotionally, spiritually, financially. And we had a lot of fun in the process. You know, they kept telling me that we didn't get sober to live these small, boring lives, and so we had a good time when we were doing it. The thing was, though, that a lot of the majority of the people that I went to treatment with and that I got sober with at the time, I saw a relapse. They'd be back out on the streets, they'd be in active addiction, they'd be overdosing and dying. But in my circle of influence, it wasn't happening, and I didn't know why. So I just buried myself in closer to the safety of the pack. But what happened was, over the next 8 years of my recovery, I saw that same cycle play out repeatedly, both in my personal life and professional life. And I kept seeing these gaps repeated in the system. Eventually, that led me to establish the nonprofit, the Abundance Foundation, in 2020 to address the gaps that I was seeing. Now, a lot of the statistics that I'm going to give you today are going to come from Colorado, because that's where I'm from. But I would dare to say that these probably apply to states across the board. 51% of Coloradans struggling with a substance use disorder said that the fear of what would happen if someone found out was the leading reason that they didn't ask for help. So just getting somebody past the barrier of reaching out for help and letting them know that there's resources available, that's more than half of that 48 million right there. And then we run into the problems with the access to treatment. I mean, I did have PowerPoint here, but I keep forgetting. So then we run into problems with the access to treatment. So what we have here, I made this wonderfully constructed graph for you guys today. So, oh, wrong way. I don't know how to use this thing. There we go. There's my graphic design skills for you guys. But it's going to be better than me throwing numbers at you. So on the left side, so we have the Medicaid population. So this group of people has very little access to resources. They have some detox centers, some treatment, some outpatient groups, but not a lot of access. Then the next group of people is actually a really significant group. So this group is still low income, but they're not low enough income for Medicaid and not making enough money to afford high-level treatment centers or have private insurance that covers treatment. So between that group of people and the Medicaid population, you have millions of people in this group, in this demographic, that have the highest needs demographic and also the lowest access to resources. And so that's where we're at. The gap is the financial gap. So they are part of the 49% that has reached out and wants help, but they just can't get access to it for financial reasons. So now let's say, though, that somebody does get access to treatment, which only 14% of the 48 million people actually get access to. So maybe like a 30, 60, 90-day program, and then they're released back out into the world. So that's typically the same toxic environment that they came from, and it's with very little follow-up, maybe some suggestions for 12-step meetings, maybe some IOP, intensive outpatient groups, maybe a therapist referral, but no real accountability, support, or guidance on how to rebuild a life from ground zero. You know, it sounds really cool on paper to get a second chance, to get a chance to start over. And it's another thing to actually start over. Anybody who's ever been at a place where they've started over in life understands how true that is. So what happens? Well, we're creatures of habit. We go back to what's comfortable, even if it's what got us to rock bottom in the first place. 85% of those people that go to treatment relapse within the first year, and the majority of those is within the first 90 days, which is one of the leading contributing factors to the 800,000 plus overdose deaths in the last decade. So when we do the math out, that means that approximately only 2%, or 960,000 out of the 48 million people, are successful in their recovery beyond 1 year. So if that seems grim, it's because it is. This isn't the people failing the system, it's the system failing the people. Now let's see what happens if, so let's just say, for example, though, that somebody does get over a year of sobriety. They make it past that year, they're doing well, they're probably employed, but they're still living in sober living. They have some sober community. They're kind of connected. They managed to get a year behind them. Well, this ends up being a place where a lot of the times you hear things like, they were doing so well, and then I don't know what happened. Well, what happened is we get to this place of complacency. Like, I didn't become an addict and an alcoholic in 30, 60, or 90 days. I put a lot of hard work into that over a long period of time. Recovery is the same thing. We can't fix it in 3 months or 6 months or a year. It's a long-term process, so we need a process that goes for the long term. Right? So you see people that let me get past this. They get complacent with it, and that was the analogy I was going to use. Anybody that's ever worked in sales has heard the term, the fortune is in the follow-up. Well, we're not following up with this group of people, and we're seeing the consequences on the back end of that. So these front-end gaps here are the culmination of the things. What I want to go back to is that 800,000 overdose deaths right here, because I don't want to skip over this. So the culmination of those 3 gaps right there leads to this. Now, I didn't make this graph. This one came from the CDC. So the thing is, though, you see that little downturn there at the top on the right? Well, then the current narrative of that downturn is that now we're on the right track. We've turned a corner. I don't know. We turned a corner and somehow, and now we're improving according to what that downturn is there from 2023. How about this for a narrative? When nearly 1 million people are dead, the curve comes down. That's math. Then we throw in, we can add, and what this graph doesn't reflect is the other CDC fun fact of the day. 50% of suicides are associated with dependence on drugs, and 25% of people with addiction to drugs and alcohol commit suicide. So when we factor in suicides and alcohol deaths, that 800,000 number, it nearly doubles to 1.5 million in the same 10 years. That right there is, now we're starting to see the big picture. We're starting to see the big picture of what this is becoming. I want to shift gears here for a second, though, because I don't want to overlook the economics of this situation. There's that mental health statistic. The economics 101. Economics 101 tells us what? Supply and demand. If there is a demand for a product or a service, there will always be a supply. And without the demand for a product or a service, there will be no need for a supply. So first of all, why the demand for drugs and alcohol in our culture? Well, you see, this is a cultural issue. And I don't mean a specific culture, I mean the overall American culture. Remember how I said I felt painfully uncomfortable in my own skin? Well, as much problems as the drugs and alcohol caused, they were also the best solution that I had to the pain points. They worked. It was temporary. I knew it wasn't going to be a long-term solution. I knew I wasn't going to be able to ride that train out forever, but it worked in the moment. And that became the comfortable known, right? I had a comfort zone of knowing that was going to be a fix for me at the time versus the uncomfortable unknown. If I didn't get that fix, I didn't know what a better solution to that was at the time because I knew at least what I could get by to make it work. And I, like most people in our society, have developed this behavior pattern over time of reaching for an external solution to fix an internal problem so that I didn't have to address the underlying feelings of the internal problem. That's the society that we live in. That's the product of living in an instant gratification culture. And we've been indoctrinated into that from a young age, to band-aid our problems, right? Feeling anxious, take this. Feeling sad, take that. All you got to do is turn on the TV to see Big Pharma's commercials. Wanting to celebrate, drink this. Use this. Do anything to escape what you're trying to do right now. And that's just been what we've had as a culture from the beginning. Then we introduce a drug like fentanyl, which is the cheapest, fastest, most potent way to absolve the pain points instantly, and we wonder why there's an epidemic on our hands? It's the best solution to the problem. We can call it the problem, but it's actually the solution for the people that are using it. Even in Big Pharma's current solution, MAT programs, medicated assisted treatment programs, like Suboxone and Methadone, are just being used to band-aid addictions. They're not addressing the underlying root causes of the addiction. They're keeping people stuck in a cycle. We have this demographic of overly medicated zombies that are stuck in survival mode and calling it a solution. Has anybody ever seen somebody that misses their Suboxone medication for 48 hours? They're back out on the streets in 24, using the same drugs that they're taking the Suboxone for. So they're either back in active addiction or they're part of the 800,000 number. That's where they end up. There is a difference between keeping someone alive on a medication and saving a life. But now let's talk supply, because I do not want to overlook the supply chain of this. I don't know if you guys know much about fentanyl, but it is a synthetic opiate, meaning that it's manufactured in a lab. It doesn't come from a naturally occurring substance. So the precursors for fentanyl are manufactured in China, and they're sent to Mexico, where cartels manufacture it in a pill form or keep it in powder form, and they cut it into other drugs like cocaine, MDMA, methamphetamines, heroin, all those things. You say, well, let's pause there. Why would they cut cocaine, which is a stimulant, with such an intense downer like fentanyl? Well, fentanyl is highly addictive. And so if you cut the right amount into it, it makes the cocaine highly addictive. It's a pretty good marketing plan by the cartel. But when somebody overdoses on cocaine that's laced with fentanyl, they just cut too much. We're not talking about FDA-approved labs that they're cutting fentanyl into cocaine at. They just make mistakes sometimes. And then what happens? So then they transport it over the borders to the U.S. A lot of people think that transport is just taking place in these like big undercover operations and whatnot, which it's not. Most of the transport is actually taking place at legitimate ports of entry. And you say, well, how can that happen? I thought we had Border Patrol and Homeland Security and DEA. Yeah, we do. And they're understaffed, underfunded, and they're just getting flooded at the border. If you put enough vehicles and enough people in one place, they can't check everything all the time. The cartels know this. They're not stupid. People think we have stupid drug dealers, and they're not. Cartels are run the same way that Fortune 500 companies are run. They factor all of this stuff into the business plan. It's not, they're not idiots. So and a lot of it's actually they're utilizing American citizens too. A lot of it's not even people from Mexico coming across the border. They find people in America that are in pretty desperate situations that are willing to work for them to transport it over. So say they have 10 trucks, and then they send all 10 to the border, that bust 5, but 5 make it through. So even when the DEA sees, what were the numbers on it? The DEA sees 29,048 pounds of fentanyl, 79 million pounds of fentanyl pills, and 430 kilograms of methamphetamine. It's just a drop in the bucket as to what's coming over. That was just 2023. That's how we end up with enough fentanyl in the country to kill every American more than once. We're not actually making a difference there. They can put the bus on the news to make it look like there's something happening, but it's not. So you say, okay, well, then the ones that do get busted, there's probably severe punishments for it. So let's look at the legislation and punishments for it. Now we're talking about, I remind you, we're talking about drug trafficking here. When I start talking about punishments, people start to get confused and think that I'm saying punish people that are using drugs. It's not the same thing. Traffickers versus users. Current legislation in Colorado House Bill 1326, says that possessing between 4 and 50 grams of fentanyl or a fentanyl compound with an intent to distribute will become a level 2 drug felony punishable by a prison term of 4 to 16 years. So, how much is 4 grams? Let's stop there. 4 grams is about the amount of a sugar packet. The perception is what we need to start changing. 4 grams doesn't seem like much, but I don't know if I can go back. Yep, there it is. But 2 milligrams, which is there on that pencil, is enough to kill someone, meaning that 4 grams has the potential to kill 2,000 people. So now is the sugar packet a lot of fentanyl? Let's take the analogy. If I came up here and I'm strapped with enough C4 to kill 2,000 people, would somebody ask questions? Would I maybe get detained? Would I maybe make the news? Now let's say that I did kill 2,000. Say I did something like that and I killed 2,000 people. What would be the punishment? Would I get a life sentence? Would I get the death penalty? Would I be a terrorist? Would I go down in history as something like one of the worst humans in history? But we're not looking at it the same way. 800,000 people dead, somebody's responsible on the front end of that, but it's not happening. Other offenses become a level 1 drug felony punishable by a prison term of up to 32 years. If it leads to someone's death, if the drugs originated from outside of Colorado, or if the person possessed a pill press or other manufacturing equipment. Now stay with me. Pursuant to Title 21, United States Section Code 841, the distribution of a controlled substance resulting in death is a prison sentence upon conviction that is punishable by a minimum prison sentence of 20 years in prison and a maximum life sentence. I can get behind that. Seems reasonable. Here's the catch. How many people have actually been charged, convicted, and sentenced to it? Only a handful. And typically only high-profile cases. Why is that? Because it is because here's the thing. The way our justice system is set up. It is on the prosecution to prove beyond a reasonable doubt that the person that was trafficking the drugs knew that it was going to lead directly to someone's death, which even with an overwhelming amount of evidence is incredibly difficult to prove in court. So unless you have an overwhelming amount of evidence and a really good lawyer, people are getting off with one of the lesser charges, meaning that the average sentence for fentanyl trafficking from the DEA is 74 months and 64 months in Colorado. Which means after time served, good behavior, early release, people are doing less than 2 years before they're back out for any trafficking charge. So let me ask you this then. If I'm a drug trafficker, why would I stop? What's any motivation to stop? I go do less than 2 years in prison, when I'm back out, the money's coming in, I got an unlimited customer base. Me and anybody in my organization can do 2 years of prison time before we're back out. Why would I stop? So what is it going to take? What's it going to take punishment-wise before we actually start paying attention and making punishments that are deterrent enough where people actually think twice? Because if I'm one of those guys, I would do 2 years for that. The amount of money that's pouring in for that. All right. I did tell you that we were going to get to solutions, so let's start landing this plane. The solution is simple, but it's not easy. In 2020, I established the Abundance Foundation, which is a nonprofit aimed, like I said, at filling those gaps in the system. We take people through the hierarchy of needs, meaning that we first establish a safe, stable, sober place for somebody to land, and then we build from there. Sometimes this means that we get them into a detox or a treatment center. Sometimes this means that we're just getting somebody past the barrier of reaching out for help and letting us know that they need resources. Then we bring in a recovery coach, or sometimes called a peer support specialist. This is somebody who is in long-term recovery themselves and is now certified but not at a clinical level to help guide somebody through that early minefield of early recovery long enough for that person to be able to do it on their own. These recovery coaches provide that exposure to the new way of living the same way that that group of men did for me early on. They hold accountability, affirm people's wins, they provide advocacy and support. I got a bunch of my team here today. They can tell you how many hats they wear. They're role models, mentors, resource navigators, connectors to supportive community, and one of those main pillars for rebuilding that life of purpose and hope. And this isn't a quick fix either. Like I said, like I've been saying, this is a long-term thing. It's about walking with someone for as long as it takes to get them back to self-sufficiency. They help people begin to develop their why, because when they figure out their why, the how we do it is easy. And the biggest piece of this is that we've been able to create this sober community of people that we can just plug people into now. So in addition to really doing like the counseling and the groups and the one-on-one sessions and all of these logistical things, we have fun. We do camping trips and bowling and laser tag and movie nights and dance classes and fitness and all of these life skills things, and where we just are bringing people together. That includes these dinners that we run once a week on Friday nights, where we get between 80 and 100 people in the recovery community together to have dinner. I'll tell you where the miracles in recovery happen. It's not doing a worksheet in a treatment center. It's when you get 100 addicts together in a room to break bread and have fellowship and build relationships. And this isn't just like a kumbaya moment for me. Our statistics and our data that we've been tracking since October, we're only 3 years in, but we've only been tracking data since October, show this. Over 80% sobriety rate, over 90% reporting high quality of life in terms of physical, mental, and emotional health, nearly 90% reporting having strong support systems, nearly 90% reporting having a positive outlook over the next 6 to 12 months, and over half of the people since October are now what we consider successful, where they're employed, living in self-sufficient housing, and still sober. So, there is one last gap to this, though. I didn't want to miss this. We're only able to work with the Medicaid population right now. So anybody that's outside of that, we haven't been able to work with. To change this, we've been trying to start having talking about overall health care and getting rid of the separations of physical, mental, and behavioral health and start talking about wraparound levels of health care. The more that we can get people behind this idea, the more population we'll be able to serve. Because what happens, so here's what happens, because what happens if it doesn't change? Well, right now it costs the state of Colorado $4.5 billion annually and $740 billion to the country in terms of loss of productivity, crime, and health care related to substance abuse. That means that the system is strained. Medical system is strained, emergency services are strained, taxes and insurance costs go up, but more so than the financial side is the social fallout that we haven't even seen the full impact of yet. Johns Hopkins University in 2022 reported that the average lifespan of an American citizen went down by 0.67 years, which is over 8 months, because of the overdose deaths in the country. That means that we are going to have an entire missing generation of people. This is people that will never grow up to have families, build careers, build businesses like many people here, potentially world-changing ideas like AI, which so much of this has been about. We're going to miss out on that. We haven't seen the fallout of it yet, but over the next 20 to 30 years, you're going to see it, and if something doesn't change, we're going to see what the actual impact of that is. So what can you do to help? I just need I need you to leave here with 3 things today. Number 1, support local organizations. I talked a lot about state and federal levels. If there's something going on in your community, look for organizations that are already doing something there. If you don't have anything, reach out to me and my team. We're figuring out a way to expand what we're doing to other states, and so we can make something happen there. But whether that's your time, your resources, your finances, whatever that looks like, reach out to them and support them in that way. Number 2, your vote matters. Your vote matters when it comes to local issues, on ballot issues for treatment centers, treatment programs, specifically mental health facilities. There's a very large shortage of mental health facilities everywhere, including Colorado, that we've been able to find. Your vote matters when it comes to those issues. Your vote matters when it comes to funding for those places. And number 3, the last thing that I want you to leave with here today, clean up your own house first. What I mean by that is have a willingness and an openness to discuss it. You know, pick up that person that you raised your hand about earlier, pick up the phone and call that person. You don't have to have an answer. You don't have to have the solution. You just need to say, hey, I care about you. I want to see you get well, and I'm here to listen when you're ready. I thought I was anonymous in my addiction, but I wasn't. The damage was loud, and so I've chosen not to be anonymous in my recovery as well. You never know who needs to hear what you've been through and overcome, whether that's addiction related or not. Your story has the potential to help people, more so than you know. This is what being the change you want to see actually looks like in practice. We change the culture and we change the country by changing one person at a time, starting with the person 6 inches from the mirror. I'll leave you with one of my favorite scriptures. The light shines in the darkness, and the darkness has not overcome it. John 1:5. I hope I've been able to be that light today. Thank you.
All right, thank you so much for that topic there. Now, nicotine addiction isn't just an individual struggle, it's a public health crisis. While smoking rates have declined, new nicotine delivery systems like vapes and e-cigarettes are fueling future concerns, especially among younger populations. Is harm reduction the way forward, or are we simply replacing one addiction with another? In this fireside chat, understanding and mitigating the impact of nicotine on public health, our speakers will explore how we can curb nicotine dependence, address misinformation, and implement policies that are truly protect the public health. Joining us for this next session is Dr. Edward Anslem, a consultant and public health advocate. Welcome them to the stage.
We'll just pretend that there's a little fireplace between us. Well, thank you. I just want to say that that was a very inspiring presentation and creates a very important context for what we can talk about. What I'd like to do today is just introduce ourselves first by way of background and experience, and then launch into a conversation about nicotine. So my name is Ed Anselm, and I'm a clinical assistant professor of medicine at Mount Sinai in New York. I have over 40 years experience in tobacco cessation, and I now work almost exclusively in systems change for tobacco cessation. My prior career also includes years working in the managed care environment.
Hello, my name is Dr. Arcella Burton. I am Vice President of HealthX, one of the largest health information exchanges, and I am in New York State. And I'm here today to discuss one of my greatest fears, because nicotine is one of the leading addiction crises that no one talks about. And today we're going to have a conversation, and I hope it enlightens each and every one of you how dangerous this drug is. And I'm saying, yes, it's a drug. And I have some questions that I'm going to start this conversation out with. And I want to let you guys know, if you go online, you can see his article that was dated January 22nd, 2025 on nicotine. And I'm going to give you the correct title of the article because it's very, very informative. It's called Reimbursement for Tobacco Cessation, New Models for Fee for Service, ACO, and Capitation. I'm going to talk because I come from the world of managed care and capitation and value-based payment. Had the I have to say this, had the #1 value-based contract in the state of New York with Mount Sinai that was $8 million in savings after the second year. So I want to talk to you about your article. One of the things that you raised is that 1/3 of the people that seek smoking, they want to quit smoking, 1/3 of them tend not to do it, or they don't believe in evidence-based therapies. Why do you think that is?
Well, let me just restate the statistics. About 55% of people who use cigarettes want to stop. When they try to stop, they don't use evidence-based treatments. And this is my deepest concern, that people are not, patients, people who use tobacco, are not getting good advice. We know that they're not getting the advice from their doctors. How do we know that? We know that when they try to quit smoking, they don't use the medications that are available at no charge if you have health insurance. They don't use the counseling, which is available by telephone at no charge, whether you have health insurance or not. And they don't use the counseling that's provided by their health plan. They're not using the services. So even when they get advice to quit, even when they're motivated to quit, they don't make an effective quit attempt. And that's just the beginning of the story, because what I study is why doctors don't give good advice. But it's a larger universe. We don't talk about tobacco at all. The only place where we're good about tobacco is in addressing the issue of kids using vapes. This is a tremendous public health success, right? For the last 10 years, there's been major effort to help young people avoid vaping. And we had a big scare a couple of years back with a lot of, literally an epidemic of vaping by kids, and some harmful effects when they were playing with the vapes themselves, causing serious lung injury, all right? But today, the prevalence of tobacco use among people, among teenagers, is extremely low. It's the lowest it's ever been. And vaping is actually less and less common. So the public health strategy directed at young people has been very effective. However, when you're talking about adults, the older you get, the less likely you are to get advice to change your behavior, all right? And by the way, when I talk about behavior change, I'm not just talking about using effective using effective strategies to change your tobacco use pattern. I'm interested in helping people lower their risk of disease. It amazes me that we're not talking, just as the last conversation before us gave us a chance to understand how we have a broken system for treatment of substance abuse. Well, we have a broken system for the treatment of tobacco abuse.
And I want to address this, the broken system for tobacco use. I think some of the problem here is that most people don't consider it a drug. How do we get this out to the public that it's really a drug and it needs to be, because like you said, we do it for the children, and I know it's changed, especially in New York, but I know in New York we still see these big ads of people, young adults, 36, 40, having a heart attack. You've probably seen the commercials yourselves where it's like, I'm 42 and I had a heart attack at 36 from smoking. How do we get this so that everyone knows about this and that you see the commercials, but it's not stopping anything?
Well,
so what's going on?
So I think that the barn door is open on using things. I had if anyone sat at my table, so I had 6 cups of coffee. And so that's how I manage my mood. And lots of people use things, substances, chocolate, alcohol, pills. People use a variety of techniques to, manage their mood. So I don't believe that calling it a drug is going to be an effective strategy when that barn door has been open for decades, for decades. I suggest that we take it in a different direction. That is, if you're using nicotine, you should know your choices. And if you're treating someone with nicotine, you should help inform your patients about their choices. And their choices involve quitting, and there are many techniques for quitting that are underutilized, and there are methods for harm reduction. You know, we have opened new territories in understanding for the treatment of people who have substance abuse, and one of them is harm reduction. We have needle exchange programs, methadone, heroin. These aren't fully effective treatments, but they're harm-reducing treatments, all right? So I think we need to have a conversation about harm reduction for the many tobacco users who continue to smoke. We know that people who smoke cigarettes are going to live 10 years less on average. That's pretty remarkable, really, if you know the future. Why not help that individual lower their risk? They could go to vape, or they could go to Zyn, they can go to snus, and we could talk about any of these different products, but you can go to the FDA website where they have detailed a continuum of nicotine-containing products that allows individuals to choose the level of risk. And let me emphasize the point you made. Nicotine is a drug. There is no safe, the nicotine products that are not FDA approved are not safe, all right? So there are harms for using nicotine. But my message is that we should engage our patients and our communities in understanding the continuum of risk and helping them move down that continuum. And here's a surprise. When people move down that continuum of risk, what they learn is something called self-efficacy. Self-efficacy is the concept that you can do something about your situation, all right? I'm capable of losing weight. I'm capable of exercising more. Now it's just a question of doing it and sustaining it. But still, I have a sense of self-efficacy regarding these personal changes. So the interesting thing is to teach people that they are not addicted, that they can change. When you label someone as an addict, as we heard in the last talk, what does it do? It disempowers them. It shuts down communication. Why not tell people that they have choices? Oh, will you use nicotine? Well, why are you smoking? All the younger people have moved to vaping. All right, so why not vape? You know what happens when they vape? They found out that they can change their behavior. They develop a sense of self-efficacy. It's really interesting. What we do now at Mount Sinai is they try to give every patient varenicline, which used to be called Chantix, but it's now available in generic form. And they say, why don't you engage in a trial of quitting? See, a lot of people don't think that they can change their behavior. So why not give them a trial? There's no harm, there's no judgment. I just want you to try. See if you like it. What you may find out is that you can control your behavior. So why not give it a try? And it's a surprising thing in healthcare. We used to use something called stages of change. How many people know about stages of change here, right? So stages of change, this is, as a psychology major, so I love to cite the authors. Prochaska and Di Clemente wrote the trans-theoretical stage change model, which said that we don't want to know a psychodynamic explanation. We don't want to know a behavioral explanation. When we want to find out what's in a person's mind, we ask them if they're ready to change, all right? Everyone's done this. I've taught thousands of doctors about stages of change, and I want that lecture back because I was wrong, okay? The theory is wrong. Because it turns out that I could show you great evidence that even when people say, doctor, I don't believe I'll be able to quit in the next 6 months, all right? If you can engage them in a trial of quitting, guess what happens? A large proportion of them are able to quit. That's surprising. So we have exciting news to tell people if we could only develop the vehicle to communicate that news.
I have a question for you. So you gave us a lot of information. You're very compassionate. How do we get our doctors, our other doctors, to be compassionate? Most people will go and see a primary care doctor once a year. If they're healthy or they think they're healthy, they only go once a year. So if I had a doctor like you and I know that I could have this choice, how do we motivate other doctors to speak to people about this?
Well, here's another surprise. Doctors aren't as good as we wish. And the reason is that they aren't, right? I mean, yeah, because they don't have enough time. I mean, they have to see 4 patients an hour, 6 patients an hour in some setting. How can they possibly understand all of my psychosocial issues? And boy, do I have issues in 15 minutes. It's not possible. Right? What we need in order to help deliver the message that I just articulated is a change in the system. And that's really what my article is about. Yes. I'm interested in changing the way we provide care, all right? And when you organize a system of delivery, you can send clear, consistent, linguistically and culturally appropriate messages to your patients in an effective manner. And the way you do that is by engaging everybody in the practice. That is, it's not just the doctor in the room, but anyone who's in the medical practice can deliver an effective message to help someone quit smoking. The doctor says, I want you to talk to my office assistant, my nurse, or my secretary about quitting smoking, all right? We're going to refer you to the quit line because we refer everybody to the quit line. We think they're fantastic. By the way, when I think they're fantastic, they really are. But we think they're fantastic in helping people quit smoking, and we want them to call you, all right? Would you be willing to take that call? You see? Wow. So, but that message doesn't come from the doctor. It comes from the office assistant who may or may not have a little bit more time with a little bit of training. There's all sorts of training programs available. It's in the CDC website. It's called Million Hearts. It's in the American Academy of Practice, Family Practice. It's called Champions. And so we can train the office staff to give the message. And here's the interesting thing for those of you who are running a medical practice. What my article shows is that when you do this consistently, you'll make more money, all right? And that could be a motivator, you know, that could be a change particle, you know, something that transforms and catalyzes the way we think about healthcare, because everything in healthcare has been commodified. There's a price to everything. So historically and culturally, the add-on code for talking to a patient for more than 3 minutes about tobacco cessation. By the way, it's a message that can be given by anyone in a white coat, all right, in the doctor's office. That thing costs $15 under Medicare and around $8 or $9 on Medicaid, and someplace in between for the commercial plans, depending on what the fee schedule is. So you see, but doctors don't do it because it's so low. But we have treatments that are available for every patient regardless of their readiness to change. I told you before that readiness to change is a trap. It's an intellectual cul-de-sac where you're going to get lost. Stop asking. Start working with your patient. Develop a system in your practice, and you know, you can just go to my website and see how to do that. And develop a system whereby every clinician in your office now engages in a clear, consistent message, and you track and measure the outcomes. So you ask how you manage change. It's not just by, you know, plugging in this module. It's about saying that we as a medical practice, we as a health system, are committed to changing the tobacco use continuum in our practices, all right? Very few practices measure their performance in tobacco cessation, neither the process nor the outcome. Google it, you know, and see what literature is out there on measuring process in tobacco cessation on a practice or health plan level. What you'll find out is the article from Kaiser Permanente of North Carolina and nobody else. University of Wisconsin has another paper. Okay, that's 2 articles. I'll give you the citations. But there's a gap there. If you don't measure it, how could you manage it? So if you really want to change, if you want to capture the revenue, if you want to help your patients, all right, if you want to install a new choice architecture, isn't that a fancy phrase? A new choice architecture for tobacco cessation and harm reduction in your practice, it has to start with leadership.
So I have a question for you. This is a segue to it. So leadership says, we know that we can bill for this, but the documentation, CMS puts too much information for documentation. I don't have time for that. What do you say to a practitioner or an office system that says they don't have enough time to put that in there? I know what I see from the data we collect. We hardly ever get any data in New York from systems unless it's a behavioral health organization that will do some smoking cessation or an FQHC, because as we know with FQHCs, the reimbursement is bundled under prospective payment system. And there's some organization that have some VBP, but how do you get them to change and to go into the system knowing that they have to put documentation, and people don't want to put all that documentation for such a little bit of money? What do you say to it?
Well, I don't know that it's a little bit of money. If you look at the article that I published, it was $6 million over 3 years for an 8-hospital system. So I think we could get the attention of any CEO with that kind of scale of dollars. We're talking about millions of dollars for a hospital system, and tens of thousands or hundreds of thousands of dollars depending on the size of your practice. But it starts with how you manage change within your system. And the first thing is to understand that the electronic medical record has to capture that system. The majority of the clinicians I know use NextGen. You have to take their tobacco module and plug it in. There's some imperfections because the tobacco module doesn't quite capture all of the nuances of tobacco use because it doesn't differentiate between vaping and smoking. Right. Interestingly, on the billing side, vaping and smoking, they're still tobacco, they're still billable, and they're still actionable. You can help the health of that patient by helping them quit vaping too. So why not do that? But then first is the EMR. Then there's the tobacco use identification process. And there is a literature about this. The idea is when someone comes to a practice, someone has to ask them if they smoke. I used to laugh because my primary care physician at NYU would ask me every time I went if I smoke. And why did he do that? Not to needle me because this is my whole career, but rather because he asks every patient every time. It's the system. By the way, Kaiser Permanente, they don't have the doctor ask the tobacco use status. They have the office assistant or the medical assistant ask. And they have an algorithm so that they don't waste their time asking all the previous people who never smoked every single time they come in, because it's very uncommon that an adult will start smoking, right? So why ask them, right? Why waste time doing it, you see? So there's an algorithm that there's a process for applying a change model. EMR, tobacco use identification, managing the flow in the office. I mean, you have to know how your patients are going to flow through the office and who's going to do this. And you want to make sure that the clinicians understand what it is that you're trying to change. And then you need to measure them. Right? This is really amazing. So much of healthcare, we had this great session yesterday about diabetes. And everyone is talking about how we measure and manage A1C. Isn't it fabulous? And the reason is for the last 15 years, the National Commission for Quality Assurance has been asking every doctor to report to every health plan about how they're doing on managing A1C, right? We're not doing that for tobacco, all right? I sat on the National Quality Forum. They have a metric that could be used, but they're not doing it. So what happens when you don't measure it? You can't manage it, okay? So we've allowed this. We've acquiesced. Broken system, anyone? Right? So,
Broken system.
Broken system. So you ask, so if the leadership decides, they need to delegate to a number of champions within the system. The cookbook is there. It's the CDC cookbook. There's a few other cookbooks available. You can decide which one fits your institution and your change process. And you need to measure it. That's how you do it.
So this is very interesting, and I like the way that you're thinking and you're putting the system. So when we think about a system, and we're thinking about the person that's in the system, and let's just say they go to your system, but they also have some outside doctors, and the outside doctor says to them, don't worry about it. You've cut down on your smoking. You don't need that. So you don't need to go back there anymore. How do you get that person to re-engage?
Well, so people nowadays do seek medical care at multiple locations, and that's true. I think you can engage people best by helping them see the change. So if people understood that within several days they can see good physiologic effects of their tobacco cessation, within several weeks or months, they can be through the challenges, most of the challenges with relapse if they understand and can see the change. But I have no answer to mixed messages from other people. I don't know the answer to that. I don't want to lose the opportunity to identify the continuum of choices that people have, because the clinicians need to empower individuals to make choices. And this is a key message. It's not just that we focus on the leadership level, but I really think that the message needs to be trickled down to the individual communication. All right? And I think that that's a key issue from my perspective. Because if we don't give people choices, we're going to fail. We're going to fail.
And I think that's where it comes to what I've seen, and I see it a lot, especially when someone's really trying to quit and they're trying to have, they get a choice from you, but then they go somewhere else and their choice is, well, this is my choice. So you get the mixed message and you say, I don't need it. I'm just not going to quit. You know, I see my mother smoked for 40 years and she's still alive. You know, even though I have my choice is to stay. No, I'm not going to quit.
So my typical answer for that is to reframe the question. So people are choosing their immediate gratification because they really like smoking. They like what smoking does for them. It helps them manage their mood. One of the moods that's being managed is their incipient withdrawal, because if you smoke at a certain level and you stop smoking, well, you're going to feel bad, right? The medications are really helpful. But what I try to do is reframe the question. We're from New York State, where it costs $10.75, to buy a pack of cigarettes, all right? I help them do the math, okay? I say, well, how much do you spend in a week, in a month, in a year? What would you do with that money? And I write it down in a chart. And when they come back next time, because, they really were kind of ambivalent about it, when they come back next time, have you thought about that trip to Las Vegas? Luxor. You could be at the Luxor a year from now, and I usually use Orlando because that's a much more favorite thing. You can bring the grandchildren. But when you do the math, you give people other choices, and the other choices includes being with their kids and their grandchildren, because a lot of households have gone tobacco-free. Why be an outcast outside in the hallway when, in fact, you can come into the house and be greeted, and not saying you smoke like tobacco, you smell like tobacco, Granny. You know, you've been smoking again? You know, no one wants that message. Well, that's preventable. So my message to individuals who, people who don't really want to have that conversation is to reframe it for them in the way that matters. The immediate gratifications, you have to ask and acknowledge. Some people like smoking, all right? Some people really like smoking and they enjoy the hit of nicotine and that harshness in the back of their throat, okay? Let's acknowledge that as being true. But why do you have to get that from a cigarette? Have you tried vaping? Have you tried IQOS? There's a new product out there that feels, it's a plastic tube, it looks like a cigarette, but it doesn't burn anything. The thing that'll kill you from tobacco is the tar, all right? So why not get the nicotine you need, the flavor, and that hit in the back of your throat, which you seem to like, from a product that's not going to kill you, right? So I think there are options, and people should be informed about options. You know who's great at exploring the options? The Quit line. It's 1-800-QUIT-NOW is the number for the United States, and they'll tie you into the state quit line. And I have to say, I have run teaching programs for those counselors. They are better than I am. Okay, I'd rather have you talk to them than talk to me, because they do it all day, all the time, and they really know what they're doing. And they understand how to take someone on a journey through vaping. 1 out of 3 people who calls the Quit line is trying to either quit smoking with vaping or quit vaping, right? So they really have a lot of experience in talking to people in the details, the day-to-day operational details of changing their behavior. So more about choices. In quitting smoking, for people who have difficulty in quitting smoking, the #1 factor is counseling. And people are just giving a medication. There are 3 to 1 ratio where doctors give medications and don't give counseling, and the patient never goes for counseling. Counseling, to one of my Quit line colleagues, doubles the effectiveness of any intervention that you do. So the medications really prevent withdrawal symptoms, but there are times, weeks and months later, where the behavioral strategies that they could teach you on the phone are really, really helpful. And if you relapse, and relapse is common, people who are successful in quitting smoking can make up to 20 quit attempts before they're successful. That's a lot of effort, and I give them credit. But I bet you they would have fewer quit attempts if they use medication and counseling. But you can also use 2 medications together. And remember, if you have insurance, these medications are free. There's no cost share whatsoever to get 2 medications to help you quit smoking, and the counseling is, of course, free. So why are people not doing it? Because we're not telling them to do it, all right?
And I have a question. So if I have commercial insurance, we know, and so does Medicare does this too. Counseling for smoking cessation, they have a limit. So what if you reach your limit? Because we know, we're from New York, Medicaid gives 20 visits a year for counseling. Medicare does 8. So what happens? Can I go to Quit line even though my insurance is not going to pay for it?
Okay, so the quit lines don't get paid by insurance. The
Right.
quit lines are paid for based by several mechanisms on a state-by-state level, okay? So it's true that there are 8 sessions. Very few people go for 8 sessions, okay? The 8-session limit is for medical office-based tobacco cessation services. When I was at Aetna and I did study the entire health plan data on tobacco cessation counseling, the average number of counseling sessions per tobacco user was 1.1. So the doctor never gave more than 1 session, all right? And very, very rarely they gave a second session, all right? And I found the same thing at Mount Sinai. We could go over that data. Vanderbilt, what was the other? UCLA, and I bet you any other health system that I test, doctors are not counseling, they're not billing for counseling, and we already know that the many, many instances in which they're prescribing medications but they're not billing. So those visits are certainly reimbursable, all right? So
a lot of miss opportunities,
yeah, so
I find.
I would not say that the CMS limit which is adopted by most commercial health plans, adopt the CMS rules, never has been a threshold, and never has been a problem. It could be that some people get cessation advice in multiple clinical locations, and that some of those claims might be denied when everyone does what we're talking about here.
Right.
But I don't think that's going to happen.
Well, I just see, when I see the data and I see where it's missed, where they're not putting it in, and you're like, okay, well, how did they get this medication if you didn't counsel them?
Exactly
so I
my
find,
point.
I do find that, and from speaking to some BHOs, behavioral health organizations, they say, well, we don't put it in for billing because we don't get paid for it. And I said, why not? Have you even tried? Do you know if you meet the threshold? And if you don't meet the threshold, put it in for billing and get paid for it.
Well, so I think there's a cognitive barrier against treatment of certain conditions. We learned that in the last session, all right? We never, by the way, we never went upstream, and I'm sorry there wasn't any time to comment on it, but I think it's appropriate to understand that there's a role for prevention, not just in educating people, but understanding that if you're talking about the major public health challenges that we have, that is, we're talking about profound substance abuse, tobacco, obesity, they have a common thread, right? And that's adverse child events. And if you understand what happens in people's childhoods, then you realize that divorce, frequent relocation, homelessness for a kid, a parent in prison, these are adverse childhood events that have a profound impact on someone's future health. All right, so if you really want to prevent the social, medical problems that we've discussed, we need to address the underlying issue behind adverse childhood events, which is poverty. All right, if you want to do one thing to improve public health, then look at poverty, understand it, think minimum wage, think housing, all right? You really want to solve these problems, but we can't solve that in this session. What we're talking about today is something that's extremely actionable with you as a clinician in your office tomorrow, with your billing system over the next couple of weeks. You can make a difference for your patients. You can make a difference for yourselves, all right, in your own sense of organizational self-efficacy. And that's a real message for everyone here today. And that's the message, the empowering message of this entire conference, is that you take the information you get here, you put it into practice, you watch it make a difference for your patients, for your revenue stream, and then you do better. You use that knowledge and feedback to continuously improve.
I see we're running out of time. Does anyone have any questions? Yes.
Hey,
Reg.
so this is a kind of a far-fetched question, but it just popped in my head while you were talking about the nicotine and how as far as needing counseling through the quitting aspect of it. And I was wondering, could quitting cigarettes be a form of postpartum disorder? Because, you know, we say postpartum with babies, you know, stuff like that, but something physical, but what if it's also something mental, where when my mom used to quit or smoke and everything, she used to say that she's used to always just doing something with her hands. And so she had to find something to do with her hands, but when she couldn't, then she'd go right back to the whole hand, you know, just the motion of it. So could it be more of a postpartum mental thing as well? And could there be counseling in that form to help them break that?
Well, you know, this is the problem when we have, thank you, that's a great question, because when we think about tobacco use, what we don't realize is that there's a physical and cultural dimension to tobacco use. A lot of tobacco use is social. A lot of tobacco use is ritualistic. Look, some people curl their hair when they think deeply, okay? Or pull their beards. These ritualistic behaviors help in concentration. Other people chew gum or suck on a straw or use their tobacco as a form of ritualistic behavior. But you touched on another important issue. We never talked about the demographics of tobacco use, right? Increasingly, it correlates with socioeconomic status, mental health, all right? Rural areas. So it turns out that tobacco users not infrequently have mental illnesses, and that nicotine is a form of self-medication. If you think about it, nicotine is an antidepressant. If you have some low-level depression, would you really want to stop your antidepressant? Wouldn't it be difficult? Think about it. That's another way I've been able to help people get into behavioral health treatment over the years. You have such difficulty quitting smoking. You know, nicotine is an antidepressant. I know you have these issues. Why don't you talk to someone about it? So it's an interesting hook, and I'm sorry I didn't mention it earlier.
Thank you all. It was a pleasure speaking.
Thank you. Thank you all.
Thank you for that fireside chat. Now let's tackle another major issue for our next panel. Is wellness only for the privileged? Debunking myths. From organic superfoods and boutique fitness studios to luxury meditation retreats, the wellness industry often feels that it caters to those who can afford it. But is health and wellness truly out of reach for the average person, or is it that it's just a misconception? We are diving deep into this subject, inviting experts who will break down barriers in holistic health, discuss affordability concerns, and explore how wellness can be made more inclusive and accessible to all. Please give a warm round of applause to our moderator, Dr. Noreen Gallarara, MD, FFAD, CEO and founder of the Inner Glow, and the rest of the panelists. Welcome them to the stage.
We're just waiting for one more panelist. Good afternoon, everyone. I'm Dr. Noreen Gallarara. Welcome to today's discussion on the important question, is wellness only for the privileged? This is a topic that affects us all, and I'm so fortunate to be part of this diverse and really remarkable panel to explore it from multiple perspectives. Our panelists will tackle this issue from a variety of angles. Each of us will offer our own unique lens on how wellness doesn't have to be only for the wealthy, but something that can be achieved more widely through awareness, education, and accessibility. I would like to start the session off by introducing Dier de Caja. He is a mental health provider, an owner, and an operator for the last 23 years, and he has extensive experience in mental health and holistic self-care as a certified SFBT counselor. Dier believes that we must change our minds to change our lives. To start us off, could you please give us a quick overview of the barriers to wellness that you see in mental health, whether it be in Cameroon or in California?
Thank you. Hello, everyone. I picked this panel on purpose because I feel this is one of the biggest problems with the inner city youth that I work with. They don't have the resources that others have. So I feel that when it comes to is wellness only for the privileged, what's the definition of privileged? What does privilege mean? Privilege means you have the ability to get things that others can't get, okay? That's what makes it a privilege, okay? It's not a right. It's not a uniformed ability for someone that's homeless in Washington, D.C., and they're not worried about their depression. They got a toothache, okay? And I'm like, hey, let's go to the dentist. I haven't been to the dentist in 3 years, okay? But I have a yearly checkup every 6 months with my dentist. So it makes us think, dang, in perspective, everyone doesn't have the same dental care, okay? Now let's talk about, I'm in Cameroon, Africa. I've been in Cameroon for the last 10 years, doing a wealth of things, but to stick to the topic, in the village, there is no running water. So the first thing I realized, I now appreciate water. The government cuts off the power grid. I don't care if you're rich with a mansion or if you have a hut. When the government wants to cut it off and you're paying your bill, that doesn't happen in America. So there is a disparity between the wealthy and the underserved, the underprivileged. So what 7P Healthcare does, I meet the clients where they are, okay? I invested in 2 15-passenger vans so I can go pick up the homeless. I feed the homeless. I bring them to my office. What's the catch? My therapist can now pick them out after they eat and do their therapy session, okay? We now have the ability to have our 12 therapy group sessions, and then I provide them transportation back home. Because what did I find? Mr. D, I would have loved to come to the session, but I didn't have any gas, or I don't have transportation. So I try to take the excuse away from my clients by meeting them where they are. But why do I have to meet them where they are? Because they're underserved and they don't have the same privileges as the client that comes at 5 o'clock to 6 o'clock after they get off work and they meet with me. So I think that's the big disparity that we have to understand. It is for the privileged, and how can we as a panel and as a group and as a village, because it takes a village, figure out how we can bridge the gap. So thank you. And what I would like to do now is take the time to introduce another extreme panelist, Mrs. Sherry Tismel, and she holds a master's degree from Harvard, and she is a multi-award winner entrepreneur and is a passionate health coach. As the founder of CEO of Optimum Health Pro, she specializes in the cutting-edge health and wellness technologies. So what I would like to ask her, Sherry, as someone that is deeply involved in premium health innovations, is it truly for the wealthy?
Thank you for that introduction, dear, and thank you so much for what you've shared. I just want to jump on from there, because now I just want to say that, you know, this question is so relevant to answer today, especially that, you know, some longevity clubs and wellness centers actually charge upwards of $20,000 a month just for access to the latest and greatest health technologies. And, you know, these exclusive spaces promises the cutting edge solutions for health optimizations, for example, with modalities like hyperbaric chambers, PMF devices, contrast therapy, and there's so much more. But the truth is, you know, the benefits of using these technologies are not really that out of reach, as it may seem. These technologies are often inspired by or mimic actually the benefits that nature has already been giving us. So for example, I mean, in Optimal Health Pro, we specialize in premium and advanced wellness technologies. But the thing is, it doesn't give or creates anything new. These are all that we can all get from nature. And just to break it down as an example, let me start with PEMF, or pulse electromagnetic field, if you've heard about it. This is one of my favorites for recovery. So basically, this technology uses electromagnetic waves to recharge your cells. But then we can actually replicate this benefit by just grounding, by walking barefoot on the soil or on the sand. We could connect to nature's natural electromagnetic fields. You know, it's really ancient wisdom. It's just magnified or amplified by technology. Next is hyperbaric chambers. So inside the hyperbaric chamber, we increase the oxygen levels inside our body. But truly, again, you know, if we get into nature, have deep intentional breaths, and the ocean, and the mountain, and the forest, it's very similar benefits. Next is the theta chamber. If you haven't heard about it, it's this big equipment. It spins you around to get you into a theta state. But again, truly, we all get into a theta state upon waking up. We get into there. And if we meditate first thing in the morning, we also reap that benefit of tapping into the healing state, restorative state of the theta. Last example would be the vibration machines. You know, these could go upwards of $15,000. But then really,
what is this? It stimulates lymphatic drainage from better circulation. And we could do this by manual lymphatic drainage, by jumping in a rebounder, by dancing, by exercising. And truly, it cannot be overemphasized that exercise, movement, is one of the very best things we can do for our health. And really the key takeaway here is technology, they're remarkable, they're great. They could supercharge, what we already have. They supercharge the innate intelligence of our bodies to heal itself. But it is not the foundation. The foundation is really, again, what is already free and available to us. And again, to answer the question, is wellness only for the privileged? Obviously it's not. It's a no. Because wellness is for the intentional. Wellness is for those who choose it. And it is for those who are willing to prioritize the basics and really tap into the resources that we already have in here. Thank you. So next, let me introduce Dr. Nightness. So Dr. Nightness is a medical doctor from Nigeria who also holds a professional master's degree in clinical genetics and is currently on the path of obtaining her PhD in human genetics at the University of Maryland, Baltimore. So my question for you, Dr. Nightness, is what's your comment on genetic testing becoming more accessible to everyone?
Thank you so much, Sherry, for that introduction. Good evening, everyone. Commenting on genetic testing, we all know that prior or previously, genetic testing was considered luxury, like made accessible and affordable to just a few people who had the money to pay for it. But now, thanks to the likes of 23andMe, Ancestry DNA, we now have genetic testing becoming more available to everyone around us. And now there are also digital health platforms like Habits, which is now Veome, or DNA Fits, which can help combine genetic data to make well-informed health choices regarding habits, diet, exercise, and sleep. So genetic testing is actually becoming more available and more accessible to everyone around.
Can you help us understand how our lifestyle choices intersect with our genetic makeup? And how can we utilize this to live healthier lives?
Okay, so I'll start by saying that our genes, there's usually this misconception that our genes, in a way, determine our destiny. There are some phrases like that, but really, our genes, yes, it informs us, but it doesn't necessarily determine what we become or who we become, because we have genes and we also have environmental factors like diet, exercise, supplements, and stress management. So living healthy is a combination of all these factors. I particularly love this example. So let's take, for instance, a cardiovascular disease. We have two individuals. Both of them have equal genetic risks of having, say, for example, heart attack or high lipid levels. And individual A doesn't eat healthy. Sedentary lifestyle, no exercise, smokes, alcohol, doesn't manage stress properly, right? Compare it to individual B, who makes healthy life choices, a lot of exercise, stress management through mindful practices, and doesn't smoke, doesn't take alcohol, and is conscious about those health choices. Who do you think would live healthy? Or who do you think would not come down with that particular disease? Definitely individual B, who made more healthy choices despite being predisposed to having that diseases. So it's a combination of everything. It's all intertwined. We can't lift one way above the other and the likes. So we need to integrate healthy lifestyle choices and along with genetic testing, which is now becoming more available and more accessible to everyone, to make well-informed and personalized choices. Thank you. So moving on to the next panelist. Okay. So I will be introducing Dr. Gabriel Dikong. He's a U.S. Air Force Iraqi veteran and a leader and pioneer in medicine, healthcare services, and clinical research and AI. He holds a doctorate degree in public health from Walden University and a Master's of Science in Biostats and Epidemiology. He also holds a postgraduate degree in biomedical informatics, and he is a certified public health educator. He wears a lot of caps, you know. And he is also the founder and chairman of CMFIT Global Health Consulting, which is part of the CMFIT Global Group servicing people with disabilities and the elderly. He runs a community clinic and a clinical research program to improve health, community health, and enhance global social change in the US around the globe. So my question for you, Dr. Dikong, how would an average person, or how can an average person keep an overall good health without spending a lot of money?
Thank you very much. Hello? Hello. Okay, thank you very much for the panel, and thank you to the conference and everybody attending. Pretty much it's very easy. Information, education. Regardless of your class in a society, if you're informed and you are educated, you're most likely going to save yourself from a lot of trouble. Preventive care and preventive medicine is the way to go. People should know, everybody in this room, including myself, we have 99.99% of similarity into our genes. Only 0.1% difference between us. I'm talking about female, male. Gender, race, the same. So that difference is biologically and statistically significant, so that each one of us respond to food, drug, pharma in a different way. It's called pharmacogenetics. So when we eat food, our genetics will respond to it differently from one another, only based on that 0.1%. So if somebody knows, people are educated, you don't have to have a lot of money, that every single day you have to have the proper carbohydrate, the proper proteins, the proper lipid, fatty acid, the proper vitamins, the proper minerals, the proper fibers, and water, of course. The difference here is, where are you getting those supplements? That is the issue. You got to come from natural resources. A lot of people, like early today in the panel, people were talking about turmeric. Turmeric, you're getting it from a natural source, a raw source. It will save you from inflammations, including black pepper, they talk about. Carrot, prevention from eye diseases. So you have to have that knowledge to know where to get your food from. Because a lot of us don't know. Benzopyrene, it is a toxin that is found into our food today in the US. And benzopyrene is a toxin, is a chemical found into nicotine that they make cigarettes with. Cisplatin is another chemical toxin found into substance used for chemotherapy. It is found into our food. So if people are informed what type of food they're eating, what is in your food, we will save ourselves from diseases. And that is called preventive care. It is a social ecological model which dictates it starts from self-awareness. Self-awareness, regardless of what you know. You have to be self-determined to know what you want. I want to be healthy. I want to be able to see my grandchildren. I want to be able to live longer, to be an inspiration for other people. So that comes with a sense of try to find how to make it happen. And it comes into education and informations. So, for example, Steve Jobs have a lot of money, but he died from pancreatic cell disease. But he have access to all of the medical supplies and clinic. So money is not really the solution. It's part of it. But knowledge is. Knowledge is. If God come today and ask me, son, I'm talking about the Father of Jesus Christ. Son, do you need $1 billion or you need knowledge? To be honest with you, I would say knowledge. Do you know why? Because with knowledge, Bill Gates, with no degree, is a billionaire. Because of knowledge, Steve Jobs, a billionaire. Because of knowledge, people like Mark Zuckerberg, a billionaire. They don't have all these degrees, but they have knowledge. Jesus Christ also did have knowledge, didn't have degrees. And today, some of us don't even understood his language. So that is how people are able to survive with the lot of money you have, to exercise often. You got to be consistent. Don't exercise Monday and then you wait. You have to be consistent. If it's Monday, stick with Monday. If it's Tuesday, stick with Tuesday. If it's every two days a week, skip those days. It will work. You will see the result. Perseverance. You see the result. You can do meditation and prayer. It's very important. Your mood also plays a very good role into your overall health, because it sends a signal to your body as a sense of frequency, electromagnetic field, because everything is broken down into energy. Everything we eat goes back to energy when it penetrates into the blood to access the cells. It all goes back to energy. So, as somebody said, your spirituality counts. If you believe whatever you believe, meditation or prayer, it will help. You have to practice it. It helps the body. Self-determination. Somebody will say, are you sick? No, I'm not. You already saved yourself. Tough mental. You're sending a signal into your body to start processing an auto-repair mechanism. What we get from outside only supplement what is already in the body. The body itself will self-repair. But over time, like a copy, if you make a copy of a copy, it will be lesser and lesser degraded. So, but that's how our DNA is. Our DNA are. It go over time, it get a little bit older, and then start losing some of its components. With the supplements coming from the right source, from the natural raw alimentations, you will be able to revive faster and to recover faster and prevent yourself from diseases. And that will save you money and time. And you live longer. Without further ado, I would like to introduce to our panel, a minute, Dr. Noren Galeria. She is a board-certified dermatologist with a laser and cosmetic fellowship and has been in practice for more than 20 years. She is also the CEO and founder of Inner Glow Vitamin A, dermatologist and plastic surgeon, developed brand of skin nutraceuticals. Is that what you call it?
Yes, nutraceuticals, yes.
So, yeah, that's good. Thank you. So I have a question for you, Dr. Galeria. I would love to hear about how the average person can improve and maintain skin health without spending a fortune.
Thank you. You know, it's interesting. I think I tend to deal with a bit more of a high-end clientele. And, you know, when I listen to Dier, I think You know, honestly, wellness is for the privileged. Like, let's just be honest. As I'm sitting on this panel, I have like middle class to upper class patients, and you know, everything we've talked about here, right? We talk about you need a good diet, and you need exercise, and you need to sleep 7 to 8 hours a day, and if you take my supplements, you're gonna age better. And we talk about all that, but honestly, you know, what Dier is talking about is, you know, he's in the weeds, right? And I think that in America, do we do a really good job of really making sure that wellness is for everybody? I think we could do a little bit better. And so, you know, when I talk about what is available to my patients, I will say, yes, for the patients that I am treating, who are middle to upper class, you know, these are people who are coming in and they're saying things to me like, well, you know, this is a movie star who just had a great transformation, think Lindsay Lohan, you know, and how do I look like her? And, you know, and when I start recounting like all the stuff these patients are gonna have to do, they will make a comment to me like, well, you know, this is further proof that the stars are not better looking than us. They just have more money. And so when I think about a clientele like that, I think, well, I can take things that I would give to my high-end population and really bring them to a middle-class population. Honestly, a single mother who doesn't have food to feed her child, or you know, somebody who's struggling to make ends meet, I just don't think they're worried about skin health. You know, that's the honest truth. And you know, I think as a physician and a dermatologist who treats a lot of skin cancer, I do a lot of free care. It's part of the ethos of our practice. My husband goes on 3 humanitarian missions a year, and we go to places like, I go to marathons and landscaper conferences, and I will go to summer concerts, and we do free skin checks on whoever wants them. And we have deals with our pathologists where if I see somebody for free and they need a biopsy, then they will see them. You know, they will do the pathology for free, for example. And I think it catches a group of people that I wouldn't otherwise be treating. And I think my husband really catches a group of people. He's been to places like Haiti, the Dominican, Afghanistan, Gaza, you know, places during earthquakes. And he really does, you know, serve a lot of patients that way. But I will say that insurance makes it harder and harder because we're struggling to see our patients. It's harder to get, you know, patients in who are not being charged. And so I'm going to say, yes, healthy, you know, healthy living is something that we can all strive for. But I think in America there is still some privilege. I mean, I think that's the truth. I don't know if you have a comment.
Well, when you were speaking about that, about the middle class, in D.C., 7P Healthcare teamed up with a dentist, Dr. Edward Brown. Mm-hmm. And if you heard my story, there's several of our clients that are homeless that haven't been to the dentist in 4 years.
Right.
That's madness, right? Like, how could you think that? But that's the problem with us as clinicians. We want to put our perception, our ideologies, and our beliefs and values onto our clients, and we can't. We have to really meet them where they are. So let me give you an example. We do a giveaway with a food bank, mm-hmm. and I sit there and watch the people. I'm a 35-year vegan, haven't had flesh since 1995, okay? I don't eat any processed foods, I don't eat any refined sugars. So we have the carrots, we have the broccoli, we have the cauliflower, we have the bag of beans, and I will sit there and watch them take all the canned goods and leave all the vegetables. And I'm like, wow. So even when we try to give them the resources, it's right there on the table for them to grab. They still grab the bad stuff. And Doc, it is about having the knowledge, but I think knowledge is also a privilege. So, thank you.
And I also think it's a little bit about starting young. I don't know how you guys feel. My kids used to do these presidential fitness awards where very early on in elementary school, you know, they're being taught that, you know, these are the milestones you have to hit from a health perspective for exercise. This is what you should be eating. I think they've since taken that away, but I have to say, you know, I used to volunteer a lot at the kids' school. It changed a lot of kids' behavior. So yes, I think knowledge is also a privilege, but if we can get to kids at a place where, you know, many of them are, I do think we can start some of these habits early.
It's true, but then again, just sounding off like with what you said, that here in America, I did not grow up here, so I do see the contrast. Here, it is actually quite expensive to choose the healthy the options. I mean, even if I, you know, try to tell my kid, you know, this is healthier than this, than the processed food, the price of the healthier option is actually more. And again, I just want to also mention that, you know, coming after your talk, it was a little bit like, off, but just because, I mean, you're in the weeds and you're in the, you know, in the real, very real thing. And I guess with what I'm dealing with, you know, again, like these technologies, these wellness clubs, longevity, people who are into longevity, into biohacking, sometimes it honestly, and I've been with a lot of them, you know, and you could actually get out of touch of that reality. It's really because, you know, you get so excited, and I'm, you know, maybe I'm a little bit guilty of this before. You know, you get into all these technologies, what's the latest, what's, you know, what's the best, could this, you know, how do I stimulate my vagus nerve? How do I get all the red light therapy, photobiomodulation, and all that? How do I lengthen my telomeres? Again, these are all for longevity. But truly, somebody could be, you know, investing hundreds of thousands of dollars into all these treatments, but if your nutrition, your sleep, your movement, and your social connections, actually the social connections, it's so important. If those are out of balance, all those investments won't have a return that you're expecting. So it's really the fundamentals are very important. I guess on the free side that I was talking about, it's really just about, you know, checking into, again, our social connections, or just trying into getting into nature, and that's the best thing that we can do, the most accessible thing.
So true.
You know, I can totally relate to what. I can totally relate to what the doctor from what you said. You know, because I grew up in Nigeria and I practiced in Nigeria as a medical doctor for about 3 years before coming in here for my PhD. While he was talking, I actually recounted an episode. I was on call at the O&G department. So a woman came in, she was in labor, and she came in with nothing. She didn't have any material with her. She came in with just 50 naira. Like 50, that's our currency, and that's like less than 0 point something dollars here, maybe like 10 cents here. And I was like, okay, you're having a baby, you're having an emergency, and you don't even have money to buy cannula, like set line, and to give you basic things like fluid. So I totally get it can be really, really bad. And in that regard, I kind of agree with what Dr. Galeria said when he said, well, maybe wellness is for the privileged, but we need to find a middle ground. Yes, not everybody is privileged to have the money to make or to live well or take nice supplements to glow like Dr. Gloria. But I believe, like he said, healthy lifestyle choices. Fruits, as minute as fruits and vegetables are, they do a lot of magic. You can decide to say, oh, I'm just going to eat fruit this week, and your skin will glow, trust me. So you will be healthy, you will feel happy. Just taking a 30 minutes walk every evening, wow, you guys should try it. It's really mind-blowing. You'll feel so happy and just settled. So there are little things that we can actually tell them to do. They don't have to have all the money in the world to be healthy, but meet them where they are. And that's the whole idea of personalized medicine. Let me meet you where you are, based on what you can afford. How best can I help you? How best can I help you lead healthy lives? So I don't know, before he rounds up, do we have any question from the audience? Okay.
just just listening to the whole panel, I appreciate you all having this discussion. From in my point of view, it's kind of more of a comment, whatever. But the privilege, I feel yes, healthcare can be for the privileged, but at the same time, knowledge can be for the privileged too. But I feel that we can tap into our own knowledge, which is better than the money aspect, because we have great grandmamas, great granddaddies that knew knowledge of how to live in longevity, to be able to, they knew about the herbs, they knew about the nutrition, to be able to have longevity of life, to have, I mean, they live a long time, you know. If you want to go into the Bible times, they live hundreds of years, you know what I'm saying? So, I mean, they knew what to do until these days and so forth. So, you know, we do have that the privilege of knowledge. We just got to go back and get it and bring it into today's time. So I just wanted just to make that comment. Appreciate you.
Thank you so much.
Thank you so much. So
Good. That's very good. This work. Pretty much, like I always said, everything refer back to, for me, to the Bible. God, the Creator, started with family. It means He's the knowledge. He's the higher knowledge. Everything He does is perfect. It means He knows. Everything starts with family. You have your children, you raise them well. All of us here are the fabric, the products of a house. We all have mother and a father. They teach us, they show us the way, according to the principle, maybe put, regardless of what they believe in, Jesus Christ or Buddha or Hindu. Everything starts with the family. There's no excuse. The social ecological model is a model who start with self-awareness, then family, then the society, then the entire country and the globes. It is a process of everybody togetherness, to work with the same denominator of improving one another. If one is out, it will affect the entire model. Like she said, you help the person where he's at. Yes, there's a differentiation, privilege and non-privilege. But the gap can be reduced with knowledge and willingness to seek for what we want. Yes, go ahead.
Thank you. Thank you so much.
yeah, thank you so much.
It looks like we have time for a quick 5-minute business card exchange. So get to networking and we'll reconvene at 4:45. All right, welcome back. Up next, we turn our attention to a growing but often overlooked health crisis, the impact of loneliness on senior health. Aging shouldn't mean isolation, yet millions of seniors worldwide suffer from loneliness, leading to higher risks of depression, cognitive decline, and even premature death. With families more dispersed than ever and social structures changing, how do we ensure that our elderly population stays connected, engaged, and healthy? Let's dissect this critical topic in our final panel of the day, the hidden crisis. How does loneliness affect senior health? Without wasting any more time, let's call on stage our esteemed panelist and moderator, Lanique Cross, BTM, CPBS Learning and Development Director, or RX Sense. A big round of applause to our next panelist and moderator.
Hi, everyone. My name is Lanique Cross. I am honored to be here today speaking about the hidden crisis and its effects on senior health. And that hidden crisis is loneliness. I come from a background of healthcare education, and currently I work for RX Sense, an innovative healthcare technology SaaS provider. I'm joined today by a distinguished group of experts who bring a wealth of knowledge and passion to this discussion. So let me take a moment to introduce the panelists. On my far left here, I have Loretta Doga, RNBN, who is a nurse psychotherapist and founder of You Matter Care, an organization that focuses on supporting individuals with addiction through recovery and comprehensive mental health services. Next to her, I have Dr. Christopher Rouse, PhD, LMHC, who is the CEO and owner of Evolve Care Counseling. Evolve Care Counseling is an organization that specializes in accessible, empathetic mental health support with a unique approach influenced by Dr. Rouse's interest in gaming and comic book communities, allowing him to connect with patients through a shared passion. Next to him, I have Dr. Jemima Crescentia, who is the head of medical coding and audit at Cure Medical Centers. And Dr. Crescentia is committed to promoting health education and community awareness through her organization's initiatives. Right next to her, I have Renita Bolt, the CEO and founder of Caring with Compassion Community, an organization that provides a holistic approach to support individuals with disabilities, mental health concerns, and they offer essential resources to enhance life skills, careers, and community integration. And finally, I have Dr. Lillian Alivato, who is the Chief Medical Officer at White Wilson Medical Center in Fort Walton Beach, Florida. Dr. Alivato specializes in value-based care, focusing on improving patient outcomes while managing costs, and have a lifelong dedication to quality patient care and clinical experience. So, opening up the discussion, I want to talk a little bit about loneliness and its context of senior health and how it differs from social isolation. So, loneliness in the context of senior health is different from social isolation. Loneliness is a subjective emotional state. It is a feeling of being alone or lacking meaningful social connections, regardless of how many people you are physically present around. A senior can be surrounded by family, caregivers, yet still feel loneliness. And with loneliness, they experience deep disconnection, regardless of interactions. Social isolation, on the other hand, is an objective condition. It refers to a lack of social contact and engagement, and a senior who lives alone and rarely interacts with others is socially isolated, but not necessarily lonely if they're comfortable with solitude. The key difference is that social isolation is about the quantity of social interactions, while loneliness is about the quality of those interactions. Both can negatively impact a senior's mental and physical health, but loneliness in particular is strongly linked to emotional distress and increased risk of depression, cognitive decline, and other serious health concerns. So let's open up this discussion. First, I'm going to call on Dr. Crescentia. So tell us a little bit about your stance on loneliness as it relates to senior health. And also, can you discuss with us some of the most significant physical, mental, and emotional health effects of loneliness among older adults?
Sure. So, good evening to all. First of all, we should know this old age group. We all know, but still, the age group is 60 to 65. So by this time, people basically become like tired. They become like tired of everything, and even they want to quit from whatever they want doing. But at this stage, we have to give more attention and more activities to them, and we have to engage them in our regular conversation and communications. If not, automatically they feel the loneliness, and the loneliness might be due to any reason, like due to the death of due to their retirements, or due to death of their loved ones, or due to their physical disability, whatever may be. But finally, the result will be the same. So as she's mentioned, for sure, this loneliness obviously leads to physical, mental, and emotional weakness among the old age peoples. So first of all, let me talk about the mental disability or mental weakness, which is caused due to loneliness. If you see, like we all know, whenever people stay alone for a long time, automatically it leads to increased cortisol level. You know that increased cortisol level automatically push you to the depression, anxiety, and mental instability. So this is one of the mental weakness or mental illness which is caused due to loneliness. The second thing is physical weakness. So when some old age adults, due to the loneliness, they feel that they are depressed or they are having anxiety or panic attacks or whatever may be, they obviously start eating less and their motility rate decreases, their movements decreases. So basically because of that, their immunity levels goes down and they are prone to infections and they are prone to arthritis. So they are prone to many diseases. So physically, they are also affected because of their mental weakness and mental illness. Next comes the emotional weakness or emotional illness. So whenever like a senior person, old age people, when they feel alone, they started thinking that they are worthless. Means like they lose the interest what they were doing. Like they were actually involved in many activities previously. Maybe routinely they are involving in some community activities, some mental coaching classes or whatever maybe. When they are alone and when they feel that they are loneliness, they started losing interest in everything. Even they start losing interest to talking to a nearby and their loved ones. So that is the main thing, and they lose their cognitive behaviors. So they start losing everything. Even they have memory losses, they have dementias, they started having Alzheimer's. So all these stuffs automatically comes in because of the loneliness. So obviously it is our responsibility to take care our old age adults or not pushed into this loneliness or the crisis which is caused because of this loneliness. So I hope all of our panelists will be discussing further like how to avoid these crises in old age adult loneliness status. Thank you.
Absolutely. Thank you very much, Dr. Crescentia. As we know, research has shown that loneliness has just a severe risk factor as obesity or smoking. So we definitely need to pay just as much attention as we do other severe health factors. Next question is for Ms. Loretta Doga. So also, can you tell us your viewpoint on senior loneliness? And also, what do you believe are the primary factors that contribute to loneliness in seniors? And how do life transitions like retirement, loss of loved ones, or even health play a decline?
Thank you, first of all, for being here and having me here. I am very passionate about mental health in general. However, as a nurse, during my career, I have noticed since early age that elderly do feel isolated for different reasons. And those are very common. We may not think about these reasons in everyday life. However, are simple things that create that loneliness, which then makes for the isolation. Moving to a retirement home, it is the end solution for a lot of families. That where I have been working and I have been in contact with a lot of elderly and family members who do find difficulties in that transition from home to long-term care. However, there is many different reasons why they do feel isolated to moving to long-term care. It is also loss of trust. They feel like they are not worth anymore. They are betrayed. They left alone. Definitely, we know that a lot of family members have to work, and these days, at least in Canada, everybody has to work and extend hours. Therefore, there is not a lot of time to go and visit them. The visits are very short, right? So that is one of the reasons why they do feel abandoned. Also, feeling abandoned does make them feel lonely, separated from the family, right? Which also impacts their activity level, the engagement with other people in the same facility. And sometimes that loneliness can also, as my previous colleague said, brings to health issues, mental health issues, right? So we do see a lot of changes in behavior. We do see aggressiveness. And we do understand that that can bring also to a depressive mode, right? Also, getting to understand that our medical system is going down. That's a fact. We have a lot of nurses that are leaving. We have a lot of PSWs that have to work extra hours, extended hours. They are drained because of their not well performance. Now the impact comes in the elderly. So their health, it's something that we have seen as now they live their lives and let's move on. We can give medications. We do check the blood pressures and the blood sugars, but it only takes 5 minutes, literally, to have that attitude to talk to this elderly person on the other side and ask, how are they doing? How was their day? How did they sleep? If they're angry, pissed, right? If they're missing anything, is there anything I can do for you? And that's what I've noticed in a long-term care that is creating that, right? Isolation. I don't feel appreciated. I don't feel that I'm worth it. I'm valued, right? Do not forget also, another cause of loneliness, it is also because economical strains, Elderly tend to please the younger generation, their kids. They love to take as much away of burden from them. Therefore, they don't want to burden their young children, right? Young, whatever. I'm not young, but they're younger kids, right? The younger generation. Due to they have jobs to take care, they have kids, they have finances, they have mortgages to pay, so it's a lot of issues. The last thing that a parent at a certain age wants, it's definitely to make their children suffer on top of that. And because of that, they tend to keep their feelings for themselves. Therefore, they will not say how they feel. If they are asked if they're okay, they will just brush it off. Yes, I'm okay. I'll be fine. You don't worry about me. However, loneliness, as it was explained by Lenique in the beginning, it's not something that we can easily spot. That's the problem, right? We expect elderly to say something instead of us analyzing and observing how they're feeling, what they're doing, are they okay, why they're not doing certain things. And not all the time it is because they're isolated or because they're feeling lonely. It could be that that's a coping mechanism as well, right? So we have to be very attentive to what we call loneliness and what could be a coping strategy for that person. Level of energy, we talked about the physical impact and everything coming at that age. Also, loss of comfort and familiarity. It's another thing. We know that the older generation has worked as hard as it can be. We think we have it hard, they had it much harder. We have it much easier because we have the means, we have the technology, we have access to a lot of things. The older generation, they couldn't. So they had to build everything from practically zero. We were given something to bring on, they didn't. So for them to move from their home, which they built, and it was the dream, they have the memories, they have their shops, the hairdresser that they go to, they have the next neighbor that they share, or they compete in the garden, who has the better garden, right? So leaving all of those things and going to a long-term facility where practically you're directed on what to do, that also causes them to isolate themselves, to be alone. I don't belong here, right? Another thing, which is different from this point, it is exactly how are we building the nursing homes, in what perspective? Mostly, it's medical care. And that is the biggest issue that I have seen, at least where I am, where I worked in Toronto. I don't know how it works in America, but it is a big issue. Skill, skill, skill. You apply, 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 and you get into the routine of just performing instead of stopping, thinking, analyzing, and appreciating the other person for what they are. They are knowledge. They are experience. They have a lot to teach us, right? And as I said, it takes 2 minutes to just ask a question, and that question will answer a lot of your questions. You will know how to approach. You will know exactly how to assess and how to intervene, which that's what we need to do.
Awesome, thank you. You made a very good point about societal view on ageism, right? Too often our seniors feel as if they're not being acknowledged, right? And that too can also severely deepen the feeling of loneliness. Very great discussion. Dr. Rouse, my next question is for you. So again, tell us your viewpoint on loneliness and its impact on senior health. And also, can you discuss the steps that healthcare professionals and organizations can take to better identify and address loneliness in senior patients?
Well, thank you for the question. Again, thank you for having me as a panelist on here. I'm really honored. When I think about how we approach things in America, it's more like a multi-pronged approach. Assessment, looking at what are the local resources for individuals, especially the elderly, going through isolation, working on different type of mental health type of paradigms that really attack the negative cognitions that go along with being alone. It's been beautifully recited by everyone here. It's just that they feel they're not worth it. They're alone. No one cares anymore. And for an individual that is growing up, even at that stage of life, it's disheartening. I had a internship at the Province Regional Cancer Partnership, and a lot of individuals I was helping with, they were struggling with loneliness, they were struggling with cancer treatment, and a lot of them were going through kidney dialysis, and for a lot of them, there was no one else with them. So I incorporated using a mind-body interaction using Tai Chi with movement, working together with proper breathing, meditation, a different perspective of how to view the world, and that started to build a small community within all the other patients. And slowly they started coming in. I sadly was not able to carry on with it because I had to work on other stuff for graduate school, which is, how that goes. But the next layer that goes on to it, the fourth component, is looking at different type of policies that we can integrate into our culture that normalizes the stigmas that go along with aging, isolation, and moving forward from there to give these individuals the dignity and the companionship that they deserve. I know that different projects in America have been instrumental in this. The Boston Medical Center has this program that adapted the Thrive model, and within that model, they're able to identify individuals. Usually the gold standard when doing assessments for this would be the UCLA loneliness scale. It's a 20-item, but thankfully there is a shorter one, just 3, because you don't want to stay there forever. But then going from there, once the system is flagged, the next part would come into play of finding resources within the community that would help and be as seamlessly as possible to allow an easy transition to go together with different individuals that would help them. So, different type of social support, different types of social skills. I know AmeriCorps has their own project with seniors that helps incorporate ways to help individuals that don't have mobility. So, such a nice program. It helps the elderly find someone else to talk to, companionship. So a lot of the themes that comes together is finding the opportunity to interact with another individual. When I was a kid, we used to have a lot of the community members that from local churches or that would come over and help the younger generation, just to help bridge that gap. And in that moment, it's magical, because you get a lot of individuals that see, there's such wealth of wisdom, care, love. And sadly, I feel like with the grouping of different forms of technology we have now, it's starting to separate itself. I had a patient that was really brilliant about this, and he, I know I'm going to butcher it, paraphrasing him, but he said, when I look at my grandparents' generation, they observed the internet. My parents, they lived alongside the internet. My generation, we live in the internet. So think about all those different barriers in the way. And, what I want to help achieve is a better way to build a better connectivity with everybody else. So.
Absolutely. Thank you very much for that insight. You know, even AARP online for our tech-savvy seniors has loneliness assessment. And, you know, healthcare professionals can even integrate simple questions within your wellness checks that it doesn't have to necessarily be difficult, but can go a long way in early intervention. So the small things matter.
The small things matter, yeah.
All right, thank you so much for that. My next question is going to go to Ronita Bolt. So again, tell us your viewpoint on loneliness and how it affects senior health. And the question is, how do you think healthcare systems can incorporate social well-being into patient care, and what policy changes would support this integration?
Thank you guys for having me here. This is my third invite here, and I appreciate it. So I want to go and share a story how our organization formed, Caring with Compassion Community. We had a community member in the neighborhood who was going around knocking on doors in my neighborhood, telling everybody about Jesus Christ. And he knocked on my door. I'm a believer. But he was, I think, 81 at the time, and he was taking care of his wife that was 80 years old. And he went on to share with me that his wife had fallen, had hip surgery and everything, but they were not connected to any resources. So that was my line of work, and I had just got fired from a managed care organization I was working at. So he came and talked to me, and he said, why don't you take a walk with me in the community? And he was letting me see all these neighbors he had been talking to. And so from there, I began to connect him to different community resources. At first, he was hesitant because he was like, that's the welfare system and this and that. I was like, no, that's your tax dollars. And so I plugged him in. And so we started making a connection. He's a retired Air Force. He's a retired pastor. And he had all these skill sets that he had a routine of jumping rope every day. He even made the ropes. He had a diet routine. He played banjo, built banjos, and he played the keyboard. And he lived in a 55-plus community that he shared with me. A lot of people were getting placed into nursing homes by their families because their kids lived away. They didn't want to leave, and he tried to have me come in there and share the resources, but they didn't need it. So they said, but long story short, we lost contact for a while, and his wife had passed right before COVID. We were still in contact and stuff, and so he was going through a grieving season, and it was right around Thanksgiving time. We invited him over for Thanksgiving dinner, played the banjo, had another neighbor come by, and that's when we lost a little contact. But a year or two later, he came knocking on my door, letting me know he needed, some assistance and stuff. And when I saw him, he looked so frail. He like shrunk. So I saw the impact physically. I'm like, wow, you look so small, saying that to myself. So I immediately brought him a bag of groceries because he hadn't been eating. So the loneliness of losing his wife, his income went down. He was concerned about how he's going to take care of his house. Another community member with our organization lived in an adult family home, and he didn't feel he fit there, but he had his brother who was younger than him, and his mom wanted him away in an adult family home. He was like 61 years old. And the adult family home had seniors and stuff his age, but they were physically and low functioning. And he felt he wanted to be in his own apartment, get his job. So he called our organization. He got his number from his mental health provider, his peer specialist. And he called me directly and said, I need help getting a job and getting my apartment so I can live in my apartment. And I know I'm going to need some help, but I need this. Light bulb went off in my head. I connected him to that senior who needed a roommate. And when I connected them together and they finally met, they knew each other. They had gone to the same church. So long story short, they made a connection. We found the guy a job. This older gentleman was like 85 now. The younger gentleman was like 61. So he got companionship. And he said, this is like a son I never had. So I say that's a success story. And we also helped the the younger gentleman reach out to an advocacy group. So when you talk about policy change, because his brother was like didn't want him to leave, like trying to control him. He didn't have guardianship or anything like that. So we were telling the young guy, you don't have to listen to him. If this is what you want to do, you're advocating for yourself. We can plug you into Disability Rights Washington. That's a advocacy agency for all populations, mental health, seniors, and everything that's in Washington State where I'm located. And so we set him up to talk to their counselors so they could provide him some support. We also started providing resources about navigating our legislative session, making changes in the system. And we know the adult family homes, they now, I think it was about 5 years ago, something like that, they now have to implement in their adult family homes, give the residents and their options and choices on what they would like to do. Because at this particular adult family home, it was way back in the woods, away from community. You had to, and transportation didn't go out there, and they didn't provide them transportation to connect with their community. And the young guy who was in that home, he lived in the city, but his family wanted him to be placed farther out and stuff. So it was just something that I was not aware of until I got fired from my job. I connected with the older senior, and we started talking, and he showed me around in my community what was happening with the neighbors and things like that. Resources was missing, and long story short, that led me to the other young guy for us providing services to him. So community connection is a big thing. And policy changes, it starts with the community and being aware of what's happening in your neighborhood and connecting, being a connector and connecting to your community, and especially checking on the seniors in your community, making sure they're okay, especially with COVID and things like that. Do they have food? Do they need assistance to go to the grocery store? Do you need me to cut your grass? Or just come sit with you and companion with you. I don't know if that was all a question, but I wanted to share that story because I see that person came and boldly knocked on my door to share the gospel, and that led to us. He was connecting, but it led to much more that was provided for him. So that's how our agency got started, because of that.
Awesome. Thank you so much for sharing. We know that healthcare is not just about addressing symptoms, right? It's about addressing the whole person. So societal interventions like that goes a long way. Dr. Crescentia?
I have some points to add to her comments, actually. So she mentions about the policies, right? So I think United States have a lot of policies inbuilt, and like Dr. Christos mentioned it. So we have Papapal program, like where they need assistance. The young people come to your home, the old age senior home, they help with them from cooking, gardening, and they give companionship for them. So this is a paid program, basically, and some of like Medicare program with cover, I think. But I can suggest, and we have one more program called Time Back. Actually, we were discussing all that. So what does this time back means? Like if young people come to an old senior and they were supporting with all this domestic work or companionship, so these time is stored in their bank, like in their name. So when they grow old, they are provided with these kind of services for free. So it's a good option we can actually opt. And very importantly, again, not even the policy, the family relationship. So from a country where, like India, for sure, we don't have much of old age homes. I'm proud to say that. And we don't have much of loneliness or crisis. The only reason is the family is connected. So wherever you go, wherever you see, it will not, the families look for each other, they care for each other. And also, the families, they consider that older seniors as a blessing. And they don't leave them idle at home. Actually, we were discussing during the panel discussions also, they involve them in all their conversations, in all their daily activities, and very importantly, they were given the best part of their life. As my colleague said, they love to be with their grandsons, like granddaughters, right? So they are given the responsibility to take care of their grandchildren. So that is the greater responsibility. So they become connected, they become active, they never feel the loneliness, and they never, actually this loneliness is a very, very harmful, as she said. It's like smoking 50 cigarettes per day. And obviously, it leads to suicidal sometimes. Like my colleague said, many of them, they commit suicide even because of this loneliness. So the best option for us to always be connected with people and be connected with your friends, even though there are always policies or there are nursing homes there and community hubs are there. For sure, we have to get connected with our families, with their friends, very importantly with our church. So the church communities always help you. So I do appreciate our senior elders to be connected with like the families, the church, and the friends, whosoever, and they continue to do what they are doing. So I think that is, sorry for taking time. Thank you.
No, thank you so much for sharing. Awesome. So my very last question goes to you, Dr. Alivato. Again, share your viewpoint with us on loneliness and its impacts to senior health, and also talk with us about specific programs like telehealth initiatives or technological tools that you believe hold premise in combating senior isolation.
Perfect. First of all, I believe that loneliness is much more than just a state of feeling an isolation and I'm going to talk about from the perspective of a healthcare provider. You know, I'm a physician that has been managed populations of millions of patients in all my years working as a doctor. So loneliness is a public health issue. It needs to be addressed because when we look at utilization and we look at emergency department utilization, you're going to see that those patients that end up at the ED, the risk factor that originated all that was basically loneliness. Some patients, they go to the ED because they are alone. They don't know what to do. They start having anxiety attacks, and I think I'm feeling chest pain. I think I'm short of breath. And they end up at the ED with completely normal workups. And what is that? The physicians say, you know, all your tests are normal, you go home, and that is a revolving thing because then they become what we call in utilization management frequent ED flyers, and they get labeled, and nobody's doing anything about it. You know, the physicians, and I heard many here saying, oh, I have only 15 minutes to see a patient. And there is so much more than we need to educate providers because it's not the 15-minute slot that they have in their schedules at the office. It's the whole office staff, the whole clinical team, the patient-centered medical home approach that it's being so much advertised since NCQA and the American Academy of Family Physicians launched that concept. But are we really utilizing that? Loneliness is an assessment. You can pretty much ask questions. Are doctors, are nurses taking time to look at the patient's eyes and doing what they are supposed to do? I don't think so. You know, my experience, and now I just started being chief medical officer of an organization that is going from the transformation of fee-for-service to value-based. You know, they hate me already because I'm telling them, you need to know your patients. You need to do assessments. You are accountable for the health of those patients. You are accountable for what is going on in their home. We talk, and now I'm very happy that health plans are bringing social determinants of health as something that the doctor needs to address It is important. Do I have food? And we talk a lot about food today, about food quality. Are we even asking our patients if they have money to buy food? What they have money to buy? Are we talking about housing security? My friend here is so worried about housing security. So all those factors, you know, they are getting into a utilization crisis in not only United States. I heard Germany talking. I heard, you know, Saudi Arabia talking. I heard all the countries talking here. And patients are the same regardless where they belong. So no, I'm not being so negative. I think we need to create a workforce and an awareness so that every doctor, you know, that has, at least a person that has an MD after their name, take accountability. And it's a whole team, like nurses, social workers need to work together. So as long as I practice, as long as I'm here, I will fight so the patient has the correct approach. But what programs are? Let's be positive, correct? Let's be a little bit positive after I delivered my message here that I need all doctors to get this live up and work. Well, we have several resources. You know, remember when Facebook came, Zoom meetings, and the pandemic really helped to engage resources because families were having online conferences. You know, they couldn't travel because if they could, they would meet their older members of the family, but they start having conference calls. FaceTime is wonderful. WhatsApp has a FaceTime, you know, feature. So from that, we start. But when we have a lonely patient, that patient went through something, and what resources can us, healthcare providers, plug in, or at least bring the awareness? So I made a little bit of list here, like Get Set Up. Get Set Up is it's a community in Facebook that they teach whatever you want to learn. You know, crafts, meditation, exercise, you name it. Some communities have like thousands of members. Some only have 31. I researched that. There is another, we were talking about AI today, and there is a device that is called, please, I'm not making any propaganda here. Yeah, I have to do that remark. Is LEQ. LEQ, I was really, I started researching because as I'm also a geriatrician, okay? So in 1984, I finished my geriatric specialization. So I'm all for the elderly, and most of the elderly, they live alone or nobody has time for them. So this is something that looks like a device, looks like a lamp with a tablet, and they do have, it's a companion. The difference between Alexa and Hey Google is that AI is proactive. So it does monitor the senior and sees when the senior wakes up and say, hey, good morning, you know, mister, how did you sleep today? And then according to the setup, we can do a lot of the programs to help providers to manage those patients. We can do medication lists. We can include physical activity, goals of care. So you can have a plan of care there. And one of the features that I found it was extremely sweet is that the family uploads pictures, and then they can see the pictures, and the machine asks, tell me a little bit about that time when you were traveling with your kids when they were young. So then they start talking with the machine, they create essays, and this is an end-of-life tool. So when they're gone, the family has all those memories built. So there's a lot of resources, but I guess it's the mission of professionals like us to bring the awareness and to bring to the community, because I didn't know until I had to prepare this talk. You know, I was ignorant about it, and I had to prepare that. So there are other groups, including the Papas. We talked yesterday, someone mentioned that, which is to engage volunteers. It's a community, an application, a website. Then I volunteer my time to spend with seniors. So community is extremely important. Awareness is extremely important. And hopefully we can create more tools, AI, web-based conversations, tools to engage our elderly population, because I swear to God, we are all going to get old here. Yeah. Okay, thank you.
I
Thank
wanted
you
to
so
add
much.
too, managed care organizations and some insurance companies, they are recognizing the social detriments. And like right now, our organization have a contract with Elevated Health, that's an accountable insurance company, to make sure we're providing enough resources in connecting with our community, all ages, but we do monitor and have initiatives for our seniors. And I know Coordinated Care, that's in Washington State, they're providing contracts with grassroots organizations, community-based organizations, because they know that's boots on the ground in the community. So they are doing some things with that.
Amazing. Thank you very much, each and every one of you, for your amazing insights on this topic that does not get enough attention. I hope that each and every one of you will take the insights that you've learned today and take it back to your communities to create actionable approaches to combat senior loneliness. We have 30 seconds left.
Run. Okay, so I'm going to project. Okay, so I'm also in the age tech space like you guys, and I love your talk. I could have listened to you talk for hours. And I'm a comedian. And I actually teach improv comedy to olders themselves. And it is one of the most beautiful expressions of finding a way to watch them connect as an antidote for loneliness. It's
Absolutely.
crazy. It's like Benjamin Buttoning everyone in the room. They lose 20 years. They get taller. They're smiling. And they connect. And it's a long term. So if you're doing it, please do it more. And meet me in the bar. We can talk about it. But like improv as a tool for anti-aging and fighting loneliness, I love it.
Thank you.
Thank you.
Thank you.
Thank you.
All right, thank you, panelists, so much for that. And now let's shift our focus to celebrating remarkable achievements in healthcare. This recognition session is dedicated to honoring the exceptional efforts of healthcare professionals worldwide. These trailblazers have not only raised the standards in the health industry, but have also been instrumental in driving innovation forward. To present these distinguished awards, I am delighted to invite Brian J. Bauer, the founder and executive director of Abundance Foundation, Inc., to the stage. Welcome, Brian. Thank you. And first, I would like to call on stage our bronze sponsor, Dr. Goni Alexandro Weiss, MD, the CEO and founder, Dr. Weiss Wellness, PLLC. We deeply appreciate and are very thankful for your crucial role you have played here at making this event a success. And if award recipients would like to say a few words after their photo, you are more than welcome to. Thank you again so much for your sponsorship. We'd like to have you stay on stage with us because we do have another award for you. Health 2.0 Conference Excellence in Healthcare Award. CEO and founder, Dr. Weiss Wellness, PLLC. Dr. Weiss has 20 years of experience in the industry. She is a board-certified psychiatrist and diplomat of the American Board of Psychiatry and Neurology. Beyond this, Dr. Weiss is a former associate professor, unit chief attending, and psychiatric clerkship director. Congratulations on your award.
Thank you guys. Love you guys. Wouldn't be here without you. Thank you to Health 2.0 and all the attendees.
Okay. Excellent. Thank you. All right. Our next award winner is for Dr. Ashley K. Pendrick for Health 2.0 Conference Excellence in Healthcare Award. Dr. Pendrick is the CEO and founder of Prosper RX Consulting, The innovation she brings to the healthcare space supports medical clinics in adding a practice pharmacist to collaborate with on their teams. She is a board-certified pharmacist on a mission to increase access to pharmacists for all prescribers for everyone's sake. Congratulations. Our next award is for Dr. Carl Faulkner for Health 2.0 Conference Excellence in Healthcare Award. Dr. Faulkner is a president and CEO of Arizona DAV East Valley Veterans Foundation. He is an award-winning professional with over 20 years of experience in research and leadership success. Additionally, Dr. Faulkner is an author and speaker committed to serving the community and humankind.
I'd like to thank Health 2.0 for having me here this year. Thank all of you for attending and for sharing your thoughts on the various topics. I know especially today was very meaningful to me with the different presentations. So thank you and all the best to you as you go about your continued innovation and work.
Our next award is for Chaitana Shah Beneth, Health 2.0 Conference Excellence in Healthcare Award. Chaitana, founder and CEO of Circle Health, is committed to transforming healthcare for the working population. A graduate of the prestigious IIM, Chaitanya has held leadership roles in strategy consulting at Booz & Company. He also led brand and digital initiatives at India's largest maternal hospital chain, Cloud9. Our next award is for Dear A. Dika, Health 2.0 Conference Excellence in Healthcare Award. Dier is the owner, CEO, and counselor of 7P Healthcare Services, Inc., with an MA in licensed professional counseling from Liberty Universities. Dier specializes in SFBT and CBT. He is a certified solution-focused brief therapy counselor and the owner of mental health care facilities.
Thank you, everyone. Thank 2.0 for this great opportunity. This is just overwhelming. It takes a village, and what I see in front of me is the village, and we are the future of health, and we have to change our mind to change our life.
Our next award is for Hector Rosado, Health 2.0 Conference Excellence in Healthcare Award. Hector is the Director of Business Strategy and Operations at Takata. With a proven track record of leading cross-function teams, Hector has successfully integrated advanced technologies and data-driven approaches to optimize processes and foster a culture of continuous improvement. He excels at developing and implementing robust strategies. Congratulations. Our next award is for Dr. Isma Mayai Chalamat for Health 2.0 Conference Visionaries Award. Dr. Chalamat is a psychic CEO of Yoga Health LLC with almost 3 decades of experience across various fields in healthcare. She is revolutionary innovator, disruptor, visionary, and builder of the net positive economy. Dr. Chalamat is dedicated to creating a unique approach in health and that can replace the current model. Congratulations. Our next award is for Julie Smith, Health 2.0 Conference Excellence in Healthcare Award. Julie is the owner and physical therapist for Body Effects and has been an integrative therapist since 1997. She is a board-certified physiotherapist, licensed kinesiologist, and internationally certified soft tissue manual therapist. Julie is known to leverage multimodal therapies techniques in her practice.
I just want to say thank you to friends and family and the other innovators that are here. Thinking outside the box is the only way we get to go forward, so keep thinking outside the box.
The next award is for Centrifuge. Award 1, Health 2.0 Conference Outstanding Organization Award. Centrifuge was established with a groundbreaking vision to build a comprehensive intellectual property portfolio to support its integrated spinal fusion and neuromodule therapy. This innovation culminated in first centrifuge electric transformable lumbar interbody fusion. On behalf of this organization, Justin, the CEO and co-founder, will receive the award.
So I want to thank everyone here for recognizing us, and also our doctor, Dr. Lal, who actually led the procedures.
Thank you, Health 2.0, for the award. We appreciate it. It's been a real pleasure to present Centrifuge to everyone. I think that this is a really cutting-edge and innovative conference with just a very unique approach to medicine, and I think this is very important. So thank you.
Our next award is for Justin Zanenko for Award 2, Health 2.0 Conference Outstanding Organization Award, as well as Award 3, Health 2.0 Conference Visionaries Award. Justin, CEO and co-founder of Centrifuge, Inc., is a certified public accountant with extensive experience in corporate finance and entrepreneurship. He has held positions as Director, Senior Vice President of Corporate Development, Vice President of Finance, and Chief Financial Officer of Recombinetics, Inc. Justin brings his experience and passion to bear at Centrifuge to help address the opioid crisis. Okay. Congratulations. All right, our next award winner is Dr. Kimberly Witch Etheridge, Health 2.0 Conference Excellence in Healthcare Award. Dr. Kimberly Witch Etheridge is the CEO of the Witch Effect, LLC. As a national award-winning public health physician, she is committed to improving care quality, access, and accessibility. She has a long history of providing primary care to communities while working in local and national public health, academia, civic organizations, and service groups.
First, thank you very much. Second, it's White. Go through life with a name like Witch, but it's White. But all I wanted to say is that life comes in threes, and the three words that I want you to all remember is 1, passion, do what you love. 2 is privilege. We're here because we have privilege. Make sure you use your privilege for good. And 3, pediatrics, because everything we need to know about life we learned in kindergarten. And what we do is about the kids. So share, be kind, say sorry, and what else did you learn in kindergarten? And sleep when you're tired. No. No, but thank you very much. I'm honored.
Congratulations.
This next award is for Dr. Nightness Alibi, Health 2.0 Conference Excellence in Healthcare Award. Dr. Nightness Alibi is a PhD student and graduate research assistant at the University of Maryland School of Medicine. She holds a medical degree from Obafemi Awolowo University, Life, Nigeria, and an MSc in clinical genetics from Tech Global University. Dr. Alibi has excelled as a physician in Nigeria, leading impactful healthcare initiatives.
Thank you so much. First, I would like to return all the glory back to God. For every time He uplifts me, I vow to give Him back the glory. Secondly, I would love to dedicate this award to my lovely husband. Thank you so much for all the love, the sacrifices, and everything. Please help me applaud him. Thank you so, so much. And lastly, thank you, Health 2.0. I'm super, super grateful and honored and humbled. Thank you.
The next award is for Crystal Boone, Health 2.0 Conference Excellence in Healthcare Award. CEO and Executive Director of Wings of the Future NFP. Crystal is a licensed clinical social worker with 17 years in mental health. She is dedicated to supporting families involved in the legal system. Her vision is to promote sustainable healing, help clients rebuild their lives, and improve family dynamics.
Well, thank you guys for inviting me, first of all. I really appreciate you guys to invite me and giving me this award. It means a lot to me. I also want to thank my Lord and Savior, Jesus Christ, and my husband, because without God, I would not be able to work through all of the issues that I needed to work through in order to be here today and be in front of you wonderful people, and my husband staying with me for 25 years to get me through so many hurdles to build this company to help all the families that we're able to serve. So, thank you guys again.
The next award is for Dr. Kusmita Chabra, MBBS, Health 2.0 Conference Young Achievement Award. Kusmita passionately explored medical research during her MBBS. Driven by curiosity and persistence, her favorite hobby is creative writing.
Okay, I think I'm the only Gen Z person in the room. I don't know, honestly, it's a little weird to be the youngest person in the room, but it's also really inspiring. And I actually did do quite a bit of research in my undergraduate medical degree, but it was mainly because I felt a little suffocated by the traditional learning systems. And so naturally, obviously, first I thought everything is wrong with the entire world. And then eventually I came down to learning things for myself on the internet. But when I started sharing that on LinkedIn and social media, I realized that I didn't actually sort of speak about how hard it was and how much persistence it sort of takes to keep using the internet to keep learning new things. And so today my dad is here with me. He supported me through all of that. He's a visionary in his own right. He never stopped me from trying to figure out whatever it is that I want to do, learning new things. And he's actually been, I think someone said it takes a village. He's my entire village of a support system. He's standing right there. So thank you. Thank you.
Our next award is for Kylie Bradshaw, Health 2.0 Conference Excellence in Healthcare Award. Kylie is the Director of Operations of Village Caregiving, LLC. She has received notable recognition over the past 3 years, including Caregiver of the Year and a Future Leaders Award. Recently promoted to Director of Operations, Kylie remains devoted to hands-on care, often covering shifts to support the team. Good catch. All right, this next award is for Linique Cross for Health 2.0 Conference Excellence in Healthcare Award. Linique is the Learning and Development Director at RxSense with over 11 years of experience in healthcare and pharmacy benefits management. Linique is a CPBS certified through the Pharmacy Benefits Institute of America and holds a Bachelor of Science in Technical Business Management from DeVry University.
Thank you so much, Health 2.0, for inviting me here. It's been very inspiring, to say the least. I'm happy to be able to just be around so many powerful minds that are clearly going to make a change in healthcare. Thank you for the honor and the recognition, and thank you for having me here.
This next award is for Reverend Dr. Lisa Nesnensky, Health 2.0 Conference Visionaries Award. Reverend Dr. Nesnensky, BS Pharm D, BCPS, is the CEO of Healthy Mindful South. She is a leading authority in integrative medicine, integrating traditional medicine, meditation, and alternative holistic health and healing approaches. Additionally, Reverend Dr. Nesnensky is a certified mindfulness meditation teacher and board-certified pharmacotherapist, and much more.
Thank you so much. I have no words. First of all, I would like to thank the Academy once again for the Health 2.0 award. I see visionary as looking at something not as it is, but what it could be. And so I'm getting chill bumps from that. I feel like, did I say this before? It's like a 40-year overnight sensation that I've worked all my career doing things differently than other pharmacists, than other healthcare practitioners. My kids grew up in a health food and vitamin store. They're both health practitioners. My daughter-in-law is a health practitioner. I want to recognize Dr. Kim Schatz. And I got to where I am on the shoulders of those who have come before me. And now I am in the position to support my sons and their children. So someone mentioned it's all about the kids, and it is. They are the future. That is my vision. I want my granddaughters to say Grandma was a badass.
This next award is for Loretta Daga for Health 2.0 Conference Excellence in Healthcare Award. All right, I think we're ready. Okay, let's do that one again. Congratulations to Loretta Daga for Health 2.0 Conference Excellence in Healthcare Award. Loretta is the psychotherapist and founder at You Matter Care Mental Health and Addiction Services. With over 10 years of experience in the industry, she is passionate about addressing the hidden crisis of loneliness and its profound impact on physical and mental well-being. Her work focuses on understanding, developing, and implementing community programs.
Thank you. Thank you so much. It is an honor to be here. It is my first time in a conference. I'm more hands-on in the community and all the issues. However, I am blessed to be here and to meet a lot of amazing people from different fields, and everybody the same goal, health and well-being. Thank you so much. Thank you.
Our next award is for Mahesh Natarajan, Health 2.0 Conference Excellence in Healthcare Award. Mahesh is the CEO of Heal.mx, faced a challenging journey with sobriety, severe anxiety, and debilitating asthma. This personal struggle catalyzed his transformation, driving him to take control of his life. He has since made it his mission to share his story, tools, lessons, empowering others to invoke their inner healer.
First of all, I want to say thank you to all of you, all the panelists, all the speakers for inspiring me and continuing to inspire everybody here and outside. And secondly, I'm so grateful and blessed to have passion to find me, and for Health 2.0 for recognizing that with this award. Thank you all.
Our next award is for Neha Shah for Health 2.0 Conference Excellence in Healthcare Award. Neha Shah is the founder and integrative nutrition practitioner of Diaspora Nutrition. This pioneering wellness platform supports Indian immigrants abroad in achieving their health goals while honoring cultural food traditions. With expertise in culturally aligned nutrition and wellness coaching, Neha bridges the gap between modern science and ancient Indic food wisdom.
Thank you so much. Thank you, Health 2.0, for recognizing all our efforts and bringing together under one platform. This award is, and this recognition is a symbol of love to my dharmic Indian civilization. It's a homage to my women ancestry who has passed down the pearls of wisdom through the oral traditions. And it's a moment of pride for my Indian community, for the immigrant community who is carrying India in their hearts. Thank you so much once again.
The next award is for Nithahaya Ramamurthy for Health 2.0 Conference Excellence in Healthcare Award. Lead of Digital Analytics at the Mayo Clinic, Nithahaya has 12 plus years of experience in healthcare and consumer behavior. Beyond this role, she is an active member, mentor, industry expert, and peer reviewer. She has devoted her career to using data skills to promote inclusive and equitable digital health products. The next award is for Dr. Ronnie Costello, Health 2.0 Conference Excellence in Healthcare Award. Dr. Costello is the strategic advisor at Regine Global, specializing in life sciences, real estate, and the financial industries. With expertise in structuring innovative investment vehicles, he focuses on driving impact to nonprofits and for-profit projects. He is committed to developing tailored strategies and advancing innovative solutions to improve lives.
Thank you very much for the opportunity. I'm a doctor in economic sciences, not in medicine, but my superpower is to help scientists and entrepreneurs in order to connect and to correctly do a business. So I've done this for health industry for the last 10 years, and I'm very happy to keep collaborating in that. Thank you very much.
The next award is for Sherry Tismal for Health 2.0 Conference Excellence in Healthcare Award. Founder and CEO of Optimal Health Pro, Sherry is a visionary in the wellness industry. As a health coach, she advocates for personalized wellness strategies, supporting them in achieving their full potential. As a speaker and award-winning entrepreneur, Sherry empowers audiences to thrive in key aspects of life.
Hi, thank you so much. Thank you so much for this recognition. I dedicate this to my mom and to my son, who absolutely every day inspires me to live my healthiest. And also with that, like also to encourage and empower other people to do so and to really just, live better for longer. Thank you.
Our next award is for Dr. Cheryl Neelan Kavin, Health 2.0 Conference Excellence in Healthcare Award. As the founder and CEO of Medical Solution Consultants and Chief Medical Officer at Simply Health, Dr. Neelan Kavin leads initiatives that emerge advanced technology and compassion in care. She also serves on the advisory board of Maya.ai, driving AI-powered advancements in healthcare. Dr. Nilan Kalinil holds certifications in AI and healthcare from MIT.
Thank you, Health 2.0. I would like to recognize Dr. Chaco, my mentor, and my partner. So thank you so much for the award.
This next award is for Dr. Shinjini Singh, Health 2.0 Conference Excellence and Healthcare Award. Dr. Singh is a clinical researcher at Cleveland Clinic with over 18 years of experience in medicine and biotechnology. She has strong editorial expertise, serving on editorial and review boards for prestigious scientific journals. Dr. Singh is also well-versed in GCP, ICH, and FDA regulations for drug development.
I'm truly honored. Thank you so much, Health 2.0, for giving us this platform, all of us here, and bringing such great minds from the entire healthcare field. I'm truly honored to meet each and every one of you. And as we say, knowledge is power. So we are going back all power-packed from this conference. And I would like to thank God, because without him or her, nothing happens, and it takes a village. So my village is my mom, my dad, and my father-in-law and mother-in-law. I'm getting emotional because my dad and my father-in-law are up there in heaven. I'm definitely, I know they are very proud and happy right now. And to my friends, teachers, thank you so much. Thank you so much for the award.
Congratulations. The next award is for Dr. Shweta Sinha, Health 2.0 Conference Excellence and Healthcare Award. Founder, Executive Director, and Professor at Kinsa State University, Dr. Sinha is a visionary leader in healthcare management and informatics. With 2 decades of experience, she fosters industry academic partnerships and to innovate and improve healthcare outcomes. She has driven over $10 million in revenue growth for KSU's HMI program. All right, our next award is for Upscript Health 2.0 Conference Outstanding Organization Award. Upscript Health is a direct-to-patient telehealth company providing new distribution channels for pharmaceutical and medical device brands. As a pioneering company, Upscript Health has helped patients across access convenient healthcare and over 2 million prescriptions. On behalf of this organization, we have Peter, the founder and CEO, to receive this award. Our next award is for Dr. Noreen Galleria for Health 2.0 Conference Excellence in Healthcare Award. Dr. Gallara is the CEO and founder of Innerglow, a brand of nutraceuticals backed by research and clinical trials. She is a board-certified dermatologist with a lasers and cosmetic surgery fellowship. She graduated summa cum laude at the as the number one medical student from Jefferson Medical College.
Thank you so much. This is really, truly such an honor. As the founder of Innerglow, I'm beyond excited to accept this Excellence in Health Award. But actually, as a dermatologist, this award represents 10 years of passion, dedication, and research to making the skin and the lives of my patients better. When we first set out, I knew I wanted to do something to help my patients prevent skin cancer. And it's been a long journey. And I'm just so excited that our internal sunscreen gummy is now available. It's clinically proven. And it's been dubbed kind of, sunscreen's new best friend. I would really love to thank all of you for this award. But I do especially want to thank my patients who push me every day to think bigger and to innovate and to make a difference in their lives. Thank you so much.
Congratulations.
The next award is for Vital Welt Pharmacies Health 2.0 Conference Outstanding Organization Award. Vital Welt Pharmacies is a group of pharmacies that provide comprehensive pharmaceutical services and products. They are known for their wide range of medications, health and care products, expert advice, and production of special medicines. On behalf of this organization, we have Stefan Wall, the pharmacist, to receive the award. This next award is for Ryan Zumalt for Health 2.0 Conference Excellence in Healthcare Award. Ryan is a co-founder of TruePoint Healthcare, who pioneered grassroots healthcare initiatives in the post-acute sector before excelling in military healthcare. With a national footprint, Ryan specializes in launching startups, driving financial turnarounds, and implementing value-based care approaches.
I'd like to thank Health 2.0 for having us here today and being with all the innovators and experts in their field and listening to all the conversations, the talks today. It's truly amazing to hear where everybody is moving and then get everybody in the same room. I'd also like to thank my wife, who's that one person that stands behind me on those long days and nights, early mornings, to be able to make all this possible. Thank you.
The next award is for Manaz Kazan Shadaman. Congratulations on Health 2.0 Conference Excellence in Healthcare Award.
Thank you so much for the award, but I wanted to, with everyone's permission, really say one thing. As a chairman of a board, whether it's advisory board or the company board, you're supporting the founders, their vision, and what they bring to the community. And today, I have the co-founder of Viva Valley with me, so I'm going to really dedicate my award to the company and the visionary work that all of the founders do every day and putting everything at risk to bring new products for us. So here is Jennifer, the co-founder.
Thank you to Health 2.0 for recognizing Viva Valet and recognizing our board chair for excellence in healthcare. It is an absolute delight to be here, to work in partnership across all industries, to really make it happen for patients, because we love our patients. So thank you. Thank you so much.
A big congratulations to all of our award winners today. Your remarkable dedication and achievements inspire us all. We wish you continued success as you lead the way in healthcare innovation and excellence. As Day 2 of the Health 2.0 Conference USA 2025 winds down, let's maintain this momentum and carry it into today's energy and insights into the evening. Now is the perfect time to engage in deeper discussions, exchange ideas, and discover innovative solutions on display in our exhibit booths. Be sure to check out the 2.0 conference near the registration desk for a preview of what's in store at our upcoming editions. Connect with Jatine, our representative for the 2.0 conferences, to secure your spot in future events. This is your opportunity to ensure you don't miss what's coming next. A heartfelt thank you to each and every one of you for your active participation. Your engagement truly enriches this event. And a special thanks to our silver sponsor, Centrifuge Inc., and our bronze sponsors VitaWelt Apothecon, Regine Global, and Dr. Weiss Wellness PLLC. I'm excited to see you guys tomorrow for another day full of inspiration. Let's make the most of tonight's networking hour and continue to build connections that will shape the future of healthcare. See you all in a little bit at the mixer.